like you gave presentations, a lot of these by Zoom, to audiences in Kuala Lumpur,
That's correct.
Saudi Arabia,
Yes.
China,
Yes.
all around the world.
Yep.
You've given national presentations related to COVID-19.
Yes.
Overall, can you give us a ballpark estimate of how many presentations you've given since 2020 with regard to COVID-19?
I to count specifically, but it's dozens, probably 40 to 50 at least, but more. I think if you count local talks and media appearances, I've done over 200 media appearances related to COVID.
Very big CV here, Doctor. I've covered some of it. Is there anything within your CV that I've missed that you'd want to highlight for the jury?
Sure. I think maybe it'd be helpful to talk about some of the research projects that we did. So 3 of the big publications that came out that I think were probably the most important work that we participated in. The first was looking at how pulse oximeters might underestimate low oxygen levels, particularly in patients who have darker skin. So we had a research registry with thousands of patients from both Hopkins, but then later on from HCA Healthcare, which is one of the largest national healthcare providers. And we're able to basically look at the measurements from the pulse oximeter, which is a device you put on your finger or your ear, compare that to measurements of blood oxygen levels using what's called the blood gas. And we're able to show that on average, patients who had darker skin or self-reported black patients, they were more likely to have missed hypoxemia, and that led to a delay in them getting COVID specific, and also led to a higher risk of them being readmitted back to the hospital. In addition to that work, we also published 2 different prediction models for COVID. Thousands of patients from Hopkins, we were able to create a prediction model, which basically would take, mostly it was vital signs and laboratory data, but also a little bit about who you are when you're coming into the hospital in terms of your prior health problems. And it was very accurate at predicting the likelihood that someone was going to require ICU or unfortunately die from COVID. And that was a model that we used at our health system to actually understand when we open the next ICU. So on a given non-COVID day, we would have 1 medical ICU with 24 beds. Peak of some of the waves in COVID, we actually opened 7 additional medical ICUs and had up to 160 patients on breathing machines. And so that model was really helpful for our hospital and other hospitals to try to help figure out, hey, we're at risk of needing to open another intensive care unit.
Cover the highlights?
Yeah, I think so. Yeah.
Doctor, you're being compensated for your time in this case.
Yes, I am.
And fees to date are somewhere between $35,000 and $40,000.
That's correct.
And your fee for appearing today and assisting us with this case is $12,000.
That is correct.
Now, in terms of your medical legal work, Doctor, have you testified on behalf of both plaintiffs and defendants?
I have, yes.
And your rates are essentially the same for both?
Yes, they're exactly the same.
Of the cases that you've testified in, if we want to give a percentage of plaintiff versus defendant, percentage-wise, how many of those cases that you've testified in were on behalf of the plaintiff?
It's about 85%, I think.
So predominantly your case reviews have been on behalf of plaintiffs.
That is correct.
You've talked about your research activities, your teaching appointments, but during COVID-19, you were actually serving as a physician in an ICU.
Yes, most of my time intensive care unit.
You were providing consults as a pulmonologist.
Yes.
And critical care.
Yes, I was. Sorry.
No, it's not your fault. The microphone tends to cut in and out, so. You've learned that.
Okay.
We're kind of like that, and then
I apologize if I shouted at anybody.
no, that's perfect. And then the static is coming from Attorney Guzzi.
Is it?
Yeah, so the clerk is doing a good job of muting you every time you're done, and then she puts you back on when and so she's laboring for you.
Yeah, by the time this trial's done, figure it out. Would it help?
I think if you go higher, yeah, so it's not being affected by the swaying of your tie.
All right. let's give that a try. Doctor, as a part of your practice, do you read x-rays and CT scans?
Do.
And you believe that by education, training, and experience, you are qualified to read and interpret x-rays and CT scans?
Yes, and I forgot to mention, I also ran the radiology conference for our pulmonary division for about 5 years, which is teaching our fellows how to read and interpret chest x-rays and CT scans.
Doctor, you were asked to review this matter by my office.
Yes.
And can you give the jury a kind of a synopsis of what materials you reviewed in preparing a report in this case?
Sure. So I reviewed the entirety of the medical record that was given to me, reviewed the primary images that were part of that record. I was given a disc and I was able to review all of those. I reviewed all of the depositions in the case, which were numerous. I reviewed all of the plaintiff's expert reports and then rebuttals to expert reports. I reviewed some additional materials related to signage in the hospital, policies related to COVID-19, as well as policies related to informed consent and DNR, DNI, those types of issues specific to this case.
Based on your review of the records, the deposition transcripts, the reports, 3 reports from Dr. Burdine, did you develop opinions related to the care and treatment of Grace Schara in this case?
I did, yes.
You report in this matter?
I did, yes.
Doctor, if you could take a look at Exhibit 43.
Yes.
You identify the document for us?
This is the report.
That report contains, well, strike that. Move 243 and 243 in evidence. Doctor, before we get into your opinions in this case, be helpful to give the jurors a refresher course on normal lung anatomy. I know they saw it through the eyes of Dr. Binstock as a radiologist, but maybe you can give us some more perspective as a pulmonologist.
Sure.
If it would help you, I've got a board here. There's a pointer stick behind you, and I can put it on the easel. All right.
Yeah, we can do that.
Put it right here. And so you can come down.
Can you guys hear me if I speak without the microphone?
Outside voice, Doctor.
Yeah. So this is just a picture of a normal lung. So there's really 2 big parts of the lung. There's the airways that conduct, that allow us to get the air down into the primary lung. Starts out with the big trachea, and then it branches off into the right lung and the left lung. And then each lung has different lobes. The right one has 3, the left one has 2. And as you come down these airways, you get to what's called the terminal bronchiole, or this is the very smallest airway that we have. And then once you branch off from these terminal bronchioles, you get into these little air sacs. And these little air sacs are surrounded by these blood vessels or capillaries. It's basically deoxygenated blood that's gone to the rest of the body. The body's used up the oxygen and then deposited carbon dioxide there. It comes back to this blood vessel here, and then through this alveolus, oxygen enters from the alveolus into the bloodstream. So send that back to the heart, and the heart that pumps that oxygenated blood to the body. And carbon dioxide leaves the capillary, goes into the alveolus, and then we blow off that carbon dioxide. So the lungs really have 2 main functions. It's to get more oxygen and to get rid of carbon dioxide, which is what our cells make as their using energy. There's also some immune functions that the lung serves. The lung is constantly in contact with the environment, so the lung has a huge number of cells that are just constantly doing surveillance for infection, for different particles. But the main functions are to get rid of carbon dioxide, bring in fresh oxygen.
I believe you also wanted to you had wanted to follow up with a brief discussion on what COVID your lungs look like on COVID, with COVID-19?
When we get exposed to COVID, the spike protein. So the COVID virus has this protein on it that then binds to the lining cells of the respiratory tract, the epithelial cells of the respiratory tract, and that the virus to get into those cells and start making copies of itself. And in some individuals, you might just have upper respiratory problems, cough, runny nose, fever, sinus issues. But in a significant number of people, COVID makes it down into the lower respiratory tract or into the lungs themselves. And what can happen both as a direct response to the virus actually kill the lining cells of the air sacs in the lungs. But there can also be an inflammatory response. The body starts fighting against the virus. And eventually what can happen is cells can become clogged with inflammatory fluid, where you actually, once you damage the lining of those alveoli, you can get proteinaceous fluid that leaks into those air sacs. And so
Yeah. You're using some terms here. So you mentioned proteinate, I can't pronounce the word. Can you explain what that is?
So if you damage the lining of those cells, you basically start having fluid that can leak into the cells. What the composition of the fluid is, filling up these air sacs, you no longer can get air into those air sacs. And so when the blood comes back to this alveolus, it can't pick up any more oxygen. This oxygen can't get there. And it also can't drop off its carbon dioxide because this alveolus is full of fluid. And you can see here, this is sort of an example where the bottom part of this lung here is starting to fill up with air. The airways are starting to fill up with this junk. And so that really just doesn't allow you to move air in and out of those areas. And you develop low oxygen level, what we call hypoxia or hypoxemia. This is actually when you fill up an alveolus like this, and you can't get air in, but you have blood that's essentially just kind of doing a drive-by and not getting more oxygen. We call that shunt. And the reason it's called shunt is you're really just taking this blood and you're past this area, not participating in gas exchange. And once you develop shunt, it's really, really hard to get enough oxygen. You absolutely need supplemental oxygen, but usually when you have alveoli that are filled like this and you have shunt, the only way to raise the oxygen level is to give someone extra pressure to try to blow open, to try to allow oxygen.
How's that typically done, doctor, once you get to the point where there's significant shunt?
Yeah, so the two ways that we can do that, well, there's three ways. The first way is you can use nasal cannula, which is a normal nasal cannula that you might have seen on TV or someone in the hospital. That can get like 6 liters of oxygen or raise your oxygen level to about 40% or so. So all of us in this room right now are breathing about oxygen. So if you go on just a small nasal cannula, I might be able to bump that up to maybe about 40% or so. But we can use these high flow cannulas that can deliver up to 60 liters of blood. So I can get your oxygen level up to almost 100%. If I do that, flow actually can blow open these little air sacs a little bit. But if that's not effective, and oftentimes it's not, we can put a special mask on your face. So it's either called a CPAP mask or a BiPAP mask. And really what that does is it gives you a constant pressure. And then when you take a breath in, it gives you an extra pressure. So it helps open these socked in air spaces. And then if that doesn't work, the next step is to place a breathing tube. When you place the breathing tube, you actually have a little balloon on the end of the tube that creates a pretty good seal. So you can deliver a higher level of pressure and really open up those. That's oftentimes what we have to do.
Okay, doctor. I'm going to need you to remain standing, but you can probably use the board because you put together a diagram for us to kind of illustrate the concept of shunt.
Sure.
Doctor, on your there, I believe there is an exhibit marked 257. Probably towards the back because I think we're in order here.
The board that he was just looking at, is that from yesterday?
Yes.
Okay, so that's been marked and
It's already
received.
been, the board, the fifth needs to be marked. Yeah. What? That's, Warner, you got it, right? You got the PowerPoint last night. I'm pretty sure I sent it. Warner responded back singly and directly to Warner. Yeah, I'm sorry, John, but we did send everything.
You guys are working late at night. Yeah.
Did you find the exhibit, Doctor?
I did, yes.
Are we good?
I just have one question. And I mean, the board, is that the same as 246?
46 and 247.
Okay, thank you. And then up on the screen, Doctor, I think Attorney Guzzi was referring to exhibit. What exhibit is that?
257.
Okay. Counsel, you can approach if you want to. And I, as going back to the question that was asked yesterday, the exhibits are evidence, they're part of the case. Like the attorneys, my rule has been that they share it with each other at least the day before. And many of these things have been for months, and so apparently there was an email mix up last night or something, and but after looking at it, I'm going to allow it to happen. There's no surprises or tricks being played, as far as I understand, and Attorney Flighter, he can cross-examine this witness on anything that he's about to testify to. So go ahead, Attorney Guzzi.
So at this point, Your Honor, I move 257 as evidence.
Yes, subject to the discussion that we just had at the sidebar, it'll be received.
All right, Doctor, can you, again, outside voice, tell us what we're seeing?
Sure. So this is an idealized diagram of a lung that has just 2 air sacs. Okay, and so, or alveoli, whatever word. And what you can see on this left side, this is the blood that's returning from its journey to the body. And so the oxygen level, this PVO2 is really, really low. So this is in millimeters of mercury. So all of us right now, if we were to measure a blood gas, our oxygen level should be about 100 millimeters of mercury. And so when it comes back from the body and our tissue picks up that oxygen, it gets to be pretty low. And you can see here it goes through this healthy part of the lung, where this alveolus has gas that came in from the outside, which is all oxygen. Most of the air we breathe is nitrogen with a little bit of oxygen, and there's no carbon dioxide from the environment. And so as it passes through this alveolus, which is wide open and is exchanging gas, the final oxygen level here is going to be close to about 125. But unfortunately, this alveolus here, this airway has been completely blocked. So no fresh gas can get into this alveolus. So all this blood just comes right by here and ends up with the same really, really low oxygen level at the end that it had at the beginning. And then these 2 areas combine together, and the total oxygen level is markedly decreased because all of this blood is essentially wasted. It can't exchange oxygen. And so this is what we call shock, where it can't get any oxygen into this alveolus. And so you have all this low oxygen blood mixing with the rest of the blood that went to the healthy part. I'm not sure if we have the EQ mismatch on the next one. So this is when you have a total shunt, where there's no air that gets into this alveolus. But a lot of times we just have a partial blockage. So this is what we call VQ mismatch. And the V stands for ventilation. That means how much air is moving in and out. And the Q stands for blood flow. And ideally, in a healthy lung, the same amount of blood is the same amount of ventilation. And so we're trying to be as efficient as possible. We're not wasting any gas. We're not wasting any blood. But if there's a partial blockage or a partial filling of this alveolus, you can see the oxygen level goes up a little bit, 40 to 70. And so then at the very end, your oxygen level is much higher because you're able to get some oxygen into this area that's got some problem. As bad as it is. So when someone has pneumonia from any reason, definitely from COVID, you have some areas of the lung that are completely blocked off and that have shunt. And then you have some areas of the lung that are not getting enough airflow or enough ventilation. All that. And both of those things will drop your oxygen level and get you to the point where you're going to require support, either with supplemental oxygen or perhaps with a machine to help.
At some point during her hospitalization, Dr. Grace developed shunt and or VQ mismatch.
Yes, she likely had both, and that started from the first day that she was in the hospital. So on October 6th, when she first came in, her oxygen levels before she was put on oxygen, her sats were 88 to 91%. And then when they put her on 6 liters of oxygen, her oxygen levels barely improved. And very quickly after arriving to the emergency department, they had to put her on BiPAP, which is that special mask that gives you extra pressure. And even with putting her on BiPAP, when they checked her blood gas, her partial pressure of oxygen was pretty low. It was not responding to what we would have expected with the amount of oxygen she could get.
But if a patient is experiencing shunt or VQ mismatch, does the body try to compensate for that in some way?
Yes, so your compensation for that is to breathe faster. So if you imagine this is your alveolus or your little air, they essentially can hold oxygen and carbon dioxide. If you breathe faster, you actually drop your carbon dioxide level, and that makes more room for oxygen. So your response to having PQ mismatch or shunt and having a low oxygen level is to breathe faster. And we call that hyperventilation or breathing faster.
And based on the records in this case, Ray Schara's chart, is your belief that her hyperventilation or rapid breathing was a result of PQ mismatch or shunt?
Yes, it was.
All right. Anything else on this concept that you want to discuss with the jury?
So when we're talking about shunt, you can see shunt, or you can see sort of the radiograph or a CT scan. You can see filling of those air sacs. So I don't know if we have that picture that we can show. So this is one of Ms. Schara's x-rays. This is actually the x-ray on October 13th. And on an x-ray, air is black, so if you look outside the body, it's sort of dark. And then solid structures are white. So this is the heart here, that's white. These are the bones of the spine here that are white. And normally, you see the airways other than the big trachea here and these big branch points. But if you fill up all the air sacs with fluid, you're just left with a column of air. And so if you look at this chest x-ray here, you see a column of air where we normally wouldn't see it. Here's another column of air here. Here's a column of air here. Column of air here. We call these air bronchograms. And it basically just means we're seeing the airways because you've filled up all the sacs around the airways with fluid that turned them white. So you're left with these columns of air. So this is demonstrating that her air sacs are full of some type of fluid. In this case, it was for COVID-19.
There's been a number of general themes throughout this case. Some of the concept of one of the big ones is ventilators. We've heard a lot of testimony about ventilators, but I don't know that we've actually had a really good explanation as to how a ventilator works, what its purpose is, and why it's beneficial for the patient.
Sure. So those of us here in the room right now, when we're breathing, we have our big breathing muscles, the diaphragm. It's like a big dome in our belly and our chest, and it pushes down into the abdomen. And when it does that, it generates a negative pressure in the lining of the chest wall. And so what that does is it allows air to move from atmospheric pressure, which is 0, down along that pressure gradient, which becomes negative as your diaphragm corrects. So we generate a negative pressure in order to get air to move into our lungs. And then we allow the lung itself just relaxes back to its resting state, and that pushes the air out. So that's what we call passive breathing. When you're really sick and you're either unable to breathe fast, as would be the case with COVID pneumonia, sometimes we need to put you on a ventilator. And what the ventilator does is it actually is a positive pressure machine. So every time you try to take a breath in, the ventilator senses you starting to take a breath, and then it pushes in a set volume of air. And so we can set what that volume is, or we can set a pressure of how much pressure to push in, and then the lungs will inflate to that pressure, and that determines the volume. So a ventilator is a positive pressure breathing machine. The advantage of the ventilator, there's really 3 or 4 things that it allows you to do. The first thing that allows you to do is it allows you to truly deliver 100% oxygen. Because when we put a breathing tube past your vocal cords and inflate that balloon, there's no leaking. We know that if we set 100% oxygen on the breathing machine, you're getting 100% oxygen. There's no extra air that's either leaking in through the mask or leaking out through the mask, as might happen with other devices. That balloon and that endotracheal tube that goes through your vocal cords then also protects your lungs from anything going down into the lungs. So for example, if you're on a breathing mask that's sending in air at high pressure, it can distend your stomach because some of that air goes into your stomach and you might vomit. And if that were to happen, that vomit could go right down into your lungs. It gets blown into your lungs, and that could be devastating. So you're protecting the airway with this breathing tube. The other thing that you can then do, if you have protection of that airway, we can very heavily sedate somebody to the point of them not breathing so fast. When you're breathing very, very fast and you have that shunt physiology that I talked about, your diaphragm is using up so much oxygen. 20% of your blood volume goes to your diaphragm when you're exercising, and you're using up all that oxygen, and then that low oxygen blood goes back to the lung, it goes through that shunt, and your oxygen levels get worse. And so if we put someone on a breathing, we can give them sedatives, like really powerful ones, medicines like propofol or fentanyl, which is a very powerful narcotic. And we can basically slow down their respiration so that we take control of how much they're breathing. And that immediately improves their oxygen level because their diaphragms aren't working so hard. If that's not enough, if you're still really, really low oxygen levels despite heavy sedation, we will sometimes, and we did this very often in COVID, we will give someone a medicine to paralyze them. We will literally give them curare or a version of that, which basically stops all muscle. And so your muscles stop moving at all, and you stop using up that oxygen, and your oxygen levels will slowly come up. And then the final thing that we do on a ventilator, often when your oxygen levels are really low, we will take someone, normally you're on your back in the intensive care unit, facing up to the ceiling. We will put someone in what we call the prone position. We'll put them face down. And what that does is it sends blood flow to the front part of your chest, just based on gravity. And when you have COVID pneumonia, which develops into what we call acute respiratory distress syndrome, and we'll talk about in a little bit, the top part of the lungs tend to be less involved than the bottom part. So if you flip somebody on their belly, their oxygen levels will improve. That's really hard to do if they're on just a BiPAP mask. So the ventilator allows you to protect the airway. It allows you to sedate somebody. It allows you to decrease their work of breathing. It allows you to paralyze them if they're critically ill. And it allows you to put them on their belly safely so that you can improve their oxygen level. What the ventilator doesn't do is it doesn't fix the problem. The ventilator buys us time for either medications to work or for the lung itself to heal if it's going to heal. So the ventilator itself is just something to buy us time for either our other treatments to work or for the lungs to repair themselves over time.
Thank you, Doctor. In this particular case, do you believe Grace would have benefited on a breathing machine or a ventilator?
Yes, I think she would have benefited from being intubated and placed on a full ventilator.
Why is that?
So as we talked about earlier, one of the problems that Ms. Schara had was that her work of breathing was incredibly high because her lungs were filling up with this fluid. Her lungs were getting stiffer. Levels were dangerously low. So she was breathing incredibly fast and using up what little oxygen that she had. Just to give you an example, sometimes we talk about something called minute ventilation, which is basically how much air you're moving over the course of a minute. And the way that we calculate that is we take your respiratory rate, how many breaths per minute you take, and we just multiply that by the size of the breath that you take. So most in this room are probably breathing somewhere between 12 and 15 times a minute. And the size of our breath is maybe a little bit less than half a liter. So our minute ventilation would be about 6 liters per minute. And when you exercise and go up much higher than that, go up to 25, 30 liters per minute, even higher if you're a really high endurance, aggressive athlete. When you look at Ms. Schara's minute ventilation on her BiPAP machine, where you could measure how fast she's breathing and the size of the breath, from day one, her minute ventilations were elevated. That's starting as early as the 6th, her minute ventilation were 10, 11, 12 liters per minute. By the 12th and the 13th, her minute ventilation was consistently in the 20s, 30s, sometimes up as high as I think 37 was the highest that I saw. And so that's 6 times higher than the normal respiratory rate and volume breaths that you and I would take. And that just means she's working really hard to breathe, and that's contributing to her low oxygen levels. The other thing that would have been allowed or possible with putting her on a full breathing machine would have been to give her full sedation to take away breathing. I suspect, based on how low her oxygen levels were, she would have gotten a dose of the paralyzing medicine to try to completely take her diaphragms out of the picture and to allow her oxygen levels to come up. And almost certainly she would have benefited from being placed in the prone position. And they tried to do that when she was on BiPAP, but she didn't tolerate that.
Thank you, Doctor. Another discussion throughout this trial has been use of a medication called Precedex. I
Yes.
know you like to refer to it as dexamethasone, but the word we've been using Precedex throughout
That's
the
fine.
trial, so
Yep.
we could use that term. Is Precedex a medication that you're familiar with?
Yes, we use it all the time in the ICU.
You actually order it? You set titration parameters?
Yes,
You monitor it?
yes,
You monitor the nursing staff in terms of how it's titrated up and down?
yeah. We work together to do the titrations. Yes,
And I think you said it's a medication that's routinely used in the ICU?
yes.
Has it been routinely used with COVID-19 patients?
We use it any patient on mechanical ventilation, and we used it very often in COVID-19.
Could you give us a brief overview of why Precedex is used in the ICU?
Sure. So Precedex is a sedative medication that it's called an alpha-2 blocker. And basically what it does is it provides, it helps with calming people down who are agitated, maybe experiencing discomfort, perhaps from breathing so fast. But what it doesn't do is it doesn't suppress your respiratory drive. And so you can use Precedex as you're trying, particularly when you're trying to get somebody off a breathing machine. So if you go on a full breathing machine with a breathing tube, oftentimes you're very heavily sedated for several days. And as your lungs hopefully get better and we start lightening those heavy sedation medicine, people can develop delirium, they get agitated, they're not sure what's happening to them. And so Precedex we very commonly use to give someone a soft landing as they're coming off the heavy sedative medications to try to get them to be calm enough so that we can assess them and determine if it's safe to take out the breathing tube. We also use Precedex very commonly in the ICU for something called delirium, particularly if someone has agitation from. So delirium is a term we use to describe when someone's mental status is waxing and waning. You know, sometimes they seem to be able to attend to you and they seem like they know what's happening, and then other times they're confused. And delirium can take one of two main forms. It can be an agitated delirium where someone's just really restless and around a lot, and that can be dangerous because if you have special IVs in place or a breathing tube in place, you might dislodge those. Or you can have something called hypoactive delirium where someone is just very sedated and not really doing much. Precedex is particularly helpful for someone with that agitated form of delirium. And we'll sometimes use it in patients who don't even have a breathing machine or a breathing tube. And we use it very commonly in patients who have alcohol withdrawal, who get very, very agitated. And we'll sometimes use it in patients who are, agitated for other reasons but don't have a breathing tube. And we use it in those situations because it doesn't suppress your respiratory drive. So we're not worried about, respiratory rate or making you so sleepy that you don't breathe enough on your own.
Dr. Garibaldi, does the standard of care require an ICU physician to obtain informed consent before ordering Precedex?
No, not.
Why not?
So informed consent in the term that I think you're implying is, when we get consent procedure. So for example, if you're having surgery or if you're having a central line placed or if you're having some sort of invasive procedure, giving Precedex for sedation in the intensive care unit is routine care, just like giving an antibiotic or giving other medications. So we do not obtain informed consent for the use of Precedex.
Is the concept of routine care or routine medications encompassed in what might be called general consent?
Yeah, there's something called implied consent when you come into the hospital. So for example, if you broke your arm and you drive yourself to the emergency department, it's implied that you want to have treatment. And so you don't have to get informed consent to get your chest x-ray or to have your cast put on. But if you need surgery, if they need to take you to the operating room and they need to open up your arm and fix the bone, that is an invasive procedure that comes with significant risk. And so that is a procedure that would require informed consent. But placing an IV, doing a chest x-ray, giving routine medicines like antibiotics or even sedatives for agitation in the ICU, that does not require informed consent.
And Precedex is titratable?
Yes, it is.
Why is it important for a medication like Precedex to be titratable?
Well, so it's important because you have to monitor the effects from minute to minute. The two most common side effects of Precedex are a low heart rate, or what we call bradycardia, or hypotension or low blood pressure. And so Precedex at every hospital that I've ever worked, and I'm pretty sure this is standard at most hospitals, you need to be in an intensive care unit when you're receiving that medication so that we can monitor you for those potential side effects, but also titrate the medication on a minute-to-minute basis to achieve the desired effect. If someone's getting it, am I calming them down? Making sure that they don't become too sedated. And that requires the ability to monitor that person from minute to minute.
You mentioned potential side effects such as bradycardia and hypotension. Are these potential side effects taken into consideration when placing an order to administer Precedex in an ICU?
Absolutely.
Based on your training and experience, how are those concerns accounted for in ICU?
So we typically put hold parameters on these medicines or titration parameters where you say, if the heart rate drops below this, you can decrease the dose, or if it drops below a certain threshold, infusion and notify the physician on call. Excuse me. And then also there are sedation parameters around, there's different ways to monitor someone's level of sedation. So we can say, please titrate the medicine to achieve this level of sedation. And if you go beyond that level, you back off on the minute-to-minute dose of the medicine.
Is it within the standard of care to administer Precedex for a time period beyond 24 hours?
Yes, it is. We routinely use that medicine for days at a time in the ICU.
I take it by your answer, you yourself have ordered Precedex for sedation beyond 24 hours in the ICU.
Yes, I have.
Have you ordered it for up to a week?
Yeah, we routinely use it for that long.
Longer than a week?
I think, if you're going longer than a week, you have to start wondering, is it achieving the effect that you desire? And is it time to start using other medications that would allow you to get off the medicine? When you use it for that long, you can start to develop the risk of withdrawing from it eventually. And that's just something that would just require a longer period of time to get the medicine off and requires other medicines. So usually, as I mentioned earlier, we're using this medicine when someone's hopefully getting better and we're trying to slowly bring them awake and get them off the breathing machine, or if they have something like alcohol withdrawal, that's going to be self-limited, and we'll use other medications as well to treat the withdrawal.
Doctor, have there been studies done about the use of Precedex for long-term sedation?
Yes, there have.
In general, what's been the conclusion of those studies?
So the original, maybe I'll talk about two points. So there's the original studies that led to the FDA approval of Precedex. And so those were comparing Precedex over a 24-hour period compared to medicines, Dipam, which is Ativan, you may have heard that medicine, or Propofol, which is another sedative. And those were the studies that led to the approval of Precedex. But because those studies were only looked at for 24 hours, comparing the effectiveness of Precedex to those other known sedatives, the original label from the FDA to approve the medicine was for 24 hours because that 1,100 person study for Precedex looked at 24 hours. Once it received approval, it became a common sedative in the ICU. And there are multiple studies looking at using Precedex for more than 24 hours, suggesting medicine to use, particularly at the end of someone's critical illness as you're trying to give them that soft landing that we talked about.
You mentioned the FDA package insert. Based on your education, training, and experience, doctor, can you explain to us what the purpose of a package insert is?
Yeah, so the package insert is something that the drug company itself writes, and it's based on the submission that they give to the FDA for approval of the drug. And then that package insert contains information about how the drug should be administered, what the known, sort of elimination of the drug is, its half-life, how long it lasts around in the body. And those are used to sort of set general parameters for physicians and patients to understand what this medicine is about and how it was approved. Once the medicine is approved by the FDA, then physicians are able to use it in other ways, and then we gather real-world evidence about how does this medicine work. And so over the last 15 years, we have learned that Precedex can be an effective sedative for more than 24 hours, and that's routinely how it's used today.
I think you kind of alluded to the idea that after there's a package insert, the clinical use of a medication can evolve.
That's absolutely correct.
Is trying to think of an example that maybe we all might be familiar with, and the one I come up, Wellbutrin.
Sure.
It was. Tell us what Wellbutrin was originally. What the original purpose of Wellbutrin?
Yeah, so Wellbutrin is an antidepressant medicine, and then after it was indication, people realized that if you were prescribed Wellbutrin for your depression, you're also more likely to be able to quit smoking. And so now Wellbutrin is commonly used as part of a multi intervention package to help people get off cigarettes if they want to.
But it was not originally approved for the use of smoking cessation.
No, that was not its original indication. That was an off-label use that has garnered lots of real-world evidence, and now it's pretty standardly used in that way.
Turning back to Precedex, doctor, and the package insert, is the package insert, well, let's start with this. Is the package insert on any medication considered the standard of care for physicians in the ICU?
No, it is not.
What about specifically with regard to Precedex?
No, it is not. We routinely use it for more than 24 hours for sedation.
Do clinicians in an ICU consider the package insert to even be a guideline?
No, it is not a guideline.
What guides you as a clinician? What does the standard of care require of you as a clinician in terms of how you use a medication?
Yeah, so it's partly driven by hospital location. Certain hospitals use Precedex more than others, so it's local experience, local policies, data that's generated over time. Precedex has been available now, I think, for over 15 years. It was a medicine that wasn't part of my training, and I think we didn't start using it in our ICU until probably 2011, 2012. And over time, we understand how to better use this medication from other practices, from studies that come out from our own local experience.
Fair to state, doctor, that sometimes the package insert does not keep up with how a medication is actually used in clinical practice?
Yes, that's fair to state.
And a package insert is not considered a deviation from the standard of care?
It is definitely not a deviation from the standard of care.
Based on your review of the records, doctor, were there indication in Grace Schara's chart for the use of Precedex?
Yes, there were.
Can you tell us what those indications would have been?
So the two biggest indications were agitation, particularly episodes where she was reaching for her BiPAP mask, and as we've talked about, she needed high levels of oxygen and pressure from that BiPAP mask, and so removing that was life-threatening. There are also times where there are nursing reports saying that she was reaching for her PICC line when she was agitated. That's a special IV that goes in her arm that was allowing the care team to draw blood and to give her medications. And so there were definitely reasons to treat agitation, and Precedex is a very good medicine for treating agitation.
Would the use of Precedex, strike that, given Grace's condition during her hospitalization, would the use of Precedex have been considered routine?
I would say yes, in the setting of, we typically wouldn't have someone on BiPAP for this long. We typically would move towards intubating them and putting them on full breathing support when they were this hypoxemic. But given the scenario, I think it was very reasonable and would be considered routine for this scenario when you're not able to intubate somebody, and you're doing the best that you can with BiPAP.
You mentioned the concept of implied consent, and we've talked a little bit about Precedex. Do the medications lorazepam and morphine also fall within the scope of general or implied consent?
Yes, they do.
Did the decision to not allow Grace to be intubated impact the use of Precedex in this case?
Absolutely.
Tell us how.
If she had been intubated, she would probably not have received Precedex. She probably would have received stronger sedatives, including things like fentanyl and propofol, maybe other benzodiazepines like Ativan or midazolam. Versed is the trade name that we use.
Do you have an opinion in this case to a reasonable degree of probability in the field of pulmonology and critical care as to whether the ordering of Precedex in this case was reasonable?
Yes, it was reasonable.
Was it within the standard of care?
Yes.
Do you have an opinion in this case, doctor, to a reasonable degree of medical probability as to whether the titration parameters set by the ordering physician was reasonable?
Yes, they were reasonable.
Was it within the standard of care?
Yes, they were.
Based on your review of the records in this case, doctor, do you have an opinion to a reasonable degree of medical probability as to whether the administration of Precedex by the nursing staff at St. Elizabeth was consistent with the standard of care?
Yes, it was consistent with standard of care.
It was reasonable.
Yes, it was reasonable.
Of Precedex beyond 24 hours in this case within the standard, well, let me start over. Was the use of Precedex beyond 24 hours in this case reasonable?
Yes, it was reasonable.
Was it within the standard of care?
Absolutely.
Is that an opinion that you hold to a reasonable degree of medical probability in the fields of pulmonology and critical care medicine? Yeah. Did Dr. Schara Precedex in this matter?
No, he was not the initial ordering provider.
I know you said in general that consent is not needed for Precedex. As Dr. Schara did not order the medication, Precedex, did he have any obligations under the standard of care to have any informed consent discussion with the Schara family at any point while he was managing Grace's care?
No, there was no requirement for an informed consent discussion.
Dr. Berdine has testified about two instances early on in Grace's hospitalization after Precedex was started. He claims Grace was overdosed. Are you aware of those two instances?
Yes, I am.
Do you agree with Dr. Berdine that Grace was overdosed?
No, she was not overdosed. She was receiving medications within standard titration parameters. And she, on the first instance, on October 7th, she experienced a side effect. She had low blood pressure and low heart rate, which are known side effects. But it's not an overdose because she was receiving appropriate dosing of the medication at the time and appropriate monitoring.
Dr. Berdine also testified that were life-threatening. Do you agree with Dr. Berdine?
The initial event, certainly when your blood pressure and your heart rate drops, that's life-threatening. It was responded to appropriately, and she completely recovered from that event.
Taking into consideration the two instances that Dr. Berdine is referring to, was the continued administration of Precedex in this case reasonable?
Yes, it was.
Was it within the standard of care?
Yes.
Are those opinions, is that an opinion that you hold to a reasonable degree of medical probability in the fields of pulmonology and critical care?
Yes.
All right, doctor, let's start talking about the actual care and Grace's history in the hospital here. She was admitted on October 6th.
Yes, that's correct.
6th, 7th, it kind of came in that time.
Yeah, she came in the IC, the emergency department on the 6th. And
at the time of her admission, doctor, how would you characterize the severity of her COVID-19 infection?
yeah, so there's different ways of classifying it, but by almost all definitions, she had severe COVID, requiring oxygen and she required hospitalization. So that in almost every criteria for COVID, that means she has severe COVID.
Upon her admission on October 6th, underwent an X-ray and then later a CTO angiogram. Did you review those images?
I did, yes.
And can you give us an idea of what your observations are with regard to those images and how they might inform you with regard to your opinions in this?
Sure. So the initial chest X-ray and CT on the 6th showed that she had a diffuse inflammatory process in the lungs, which was consistent with COVID-19. And then if you follow the trajectory of those X-rays throughout her hospital course, they worsen up to October 11th. And then between October 11th and 13th, their X-rays are so bad, you really can't tell if they're much worse, but she certainly had no improvement, either on the radiographs or on how much oxygen she was requiring or what her work of breathing was.
Doctor, we do have an exhibit here that has the various films throughout her hospitalization. Is that something that you might want to refer to? And
Yeah, sure. We're absolutely happy to look at the images.
grab it, and you can come around here and you can grab your
Yeah.
pointer stick.
So this is her first chest X-ray on arrival to the hospital. And just to orient people, this is the right side of the body. This is the left side of the body. The chest. This is that airway. And normally the top part of the lungs here are black. That's where air is. So most of the lungs should be black like this. And you can see here, there's an area of white that shouldn't be there. That's inflammation. And when you see this on X-ray, that could be infection, that could be inflammation, that could be blood. And then there's this area down here, which again, this should be all dark, but it's white to lose. You can't even see the border of the heart. So if you look at the 7th, you still have this area here. That's changed a little bit, but you can see this left lung now is very, very socked in. And here are some of those air bronchograms I mentioned. So this tells you that those air sacs are full of fluid, and you're seeing these airways kind of out there. I'm not scratching the screen. I apologize. On the 8th, maybe it's a little, it's always hard to say on chest X-rays. The IC with this portable machine. So day to day, it's sometimes you can't tell, but you can still see problems here and here. On the 8th, this is later in that evening, you still have this area of white here and here. On the 11th, now you can see almost the entire right lung, and most of the left lung is now whited out. And then here on the 13th, this is a slightly different film. Everything's kind of, this is at the end of the deep breath, and this is probably after she exhaled. We try to have people take a breath in and hold it, but when you breathe so fast, you just can't hold your breath. But you can see here again, this right lung is almost completely socked in. You have all these air bronchograms here. It also has a lot of whiteness here all the way going up to the top. So from the arrival, she had a bilateral pneumonia, and then it progresses over the course of her hospital stay. She had what we call acute respiratory distress syndrome process, which she had bilateral inflammation in the lungs, and it's due to a primary lung problem and not something else like a heart problem. And so she had COVID pneumonia when she arrived, and very quickly progressed to what we call ARDS, or respiratory distress.
And up on the board is the same as Exhibit 249.
This is 249.
Okay.
Thank you, Judge. Based on your review of the records, Dr. Garibaldi, and let me get rid of this so we can see each other.
Thanks.
Are you able to determine whether a treatment plan was formulated upon Grace's admission?
Yes, there was.
And can you describe for us what that treatment plan was?
First thing was to try to raise her oxygen levels. So she started with supplemental nasal cannula oxygen. And when that wasn't enough to raise her oxygen levels to a safe range, she was tried on something called high flow nasal cannula. She didn't like, by nursing description, she didn't like the sound of that flow. And so she was changed to BiPAP, which is that special mask that allows you to give high levels of oxygen, but also pressure, treating the low oxygen with supplemental oxygen. And then they offered standard of care for COVID treatment, which in this case, the treatment she received was dexamethasone. That's a steroid medicine, which has been shown to reduce the likelihood of death from COVID. You have severe COVID. And by severe in those trials, it was patients who were on oxygen in the hospital, which is what she was experiencing. And then they offered two other medicines, which at that time were medicines we were using widely in COVID. One was called Severe. That's a medicine that stops the virus from replicating, so we call it an antiviral medicine. And then they also offered tocilizumab, which is an anti-inflammatory medicine, which has been shown in critically ill patients to reduce the likelihood of requiring either being put on a breathing machine or dying. She was offered those two medicines. Her family decided not to allow those to be administered.
Doctor, based on your education, training, and experience, was the order and administration of dexamethasone reasonable?
Yes, it was.
Was it within the standard of care?
Yes.
And is that an opinion that you hold to a reasonable degree of medical probability in the fields of pulmonary medicine and critical care?
Yes.
Doctor, you have in front of you, I think it's Exhibit 205.
Yes.
Can you identify that document for us?
So this is a progress note by Dr. Carl Baum on October 8th, 2021 at 9:30 a.m.
And 205, an exhibit or document that you relied upon in your review to formulate your opinions in this case?
Yes.
Move for admission of Exhibit 205. 205. 205 is received. Okay, Doctor, you've already told us, note, and I think the date is October 8th.
Yes.
Okay, what is significant about this note as it relates to your opinions in this case?
So there are a number of things that are important here. The first is that it talks about how happened between the 7th and the 8th, and she's requiring higher levels of oxygen, and now she's on higher levels of pressure from the BiPAP machine. Dr. Baum also describes that she was anxious and struggling with keeping the BiPAP mask on, and so that's why that strip. He also mentions that he had spoken to Mr. Schara about whether or not he would consider intubation if it was needed, and he had not yet decided. So it establishes the fact that the team, even as early as the 8th, was very worried that Ms. Schara was going to require intubation if her respiratory failure continued to worsen. And so it establishes the severity of her lung, that it's worsening, the fact that intubation was discussed, and the fact that she needed Precedex to be able to tolerate these high levels of BiPAP.
Doctor, I think you may have told us, but in terms of her overall condition, Grace was not improving at this point.
No, she was in fact getting worse.
Would this have been a point in time, in your opinion, where intubation would have been within the standard of care?
Yes, it would have been within the standard of care. It's a judgment call, but someone on this level of BiPAP, on this amount of oxygen, who's not improving, intubation would definitely be within the standard of care.
Is there anything else about this note from October 8th, 2021 that informs you and assists you in reaching your opinions in this case?
The other thing that's discussed in the assessment and plan is the need for nutrition. So when you're critically ill and you're working this hard to breathe, we know that giving someone nutrition will help them keep up their strength and hopefully be able to make it through their illness. But she's not able to take off her BiPAP mask because when she does, her oxygen levels fall. And so she's now on her 3rd day of hospitalization and has not been able to tolerate. And so this is sort of laying the groundwork for an issue that's going to be coming down the pipeline if she doesn't improve. She needs to get nutrition to get well.
Now, you mentioned a discussion about tocilizumab.
Yes.
Is there a certain time frame within which that medication, at least in 2021, would have been effective?
Yeah, so the trials that looked at tocilizumab looked at giving it within the first 48 hours of illness. So we're right on that cusp, right? So she had gone on BiPAP late on the evening of the 6th. So now we're on the 8th. So she's within that 48-hour window. So if it's going to be effective, it's more likely to be effective if given within those first 2 days.
Doctor, as long as we're talking about medications here, based upon your review of the records in this case, was there ever any indication that there was any type of bacterial infection going on?
No, there was not.
Based on your review, was there any indication at all that it would have been appropriate to administer antibiotics?
No, there was no indication for any antibiotics, just potentially an indication for an antiviral against COVID.
The antibiotics are used to treat bacterial infections.
That's correct.
Okay, doctor. The next document I want you to take a look at is Exhibit 212. Identify that document for us.
Yeah, this is a note from Dr. Daniel Leonard, who's one of the pulmonologists, on October 10th, 2021. And let's see, reading through it real quick.
I gotta do some legal work first.
Yeah, please.
Move for admission of Exhibit 212. Permission to publish. Doctor, is Exhibit 212 a document that you relied upon in formulating your opinions in this case?
Yes, it is.
And I'm sorry, did you identify it for us, what area of specialty was?
He is a pulmonary critical care physician.
And can you explain to us, or describe for us, how this particular note and what's contained in it help formulate your opinions in this case?
Sure. So it establishes a few things. The first is that Dr. Leonard describes Ms. Schara as being calm and more conversant than she was the day before. Yes, that she's calm at this point in time. It also shows how significant her lung disease still is. So she's now on higher levels of BiPAP than she was on the previous note. Previously, she was on pressures of 15/10, 15/12, and she's still requiring 100% oxygen. So she's approaching the maximum of what we can provide through BiPAP. It also provides some blood gas data, which I'm sure we'll talk about a little bit later, but oxygen level is severely low. So her PO2 is 52. So to put that into context, we talked earlier, all of us sitting here, our PO2 should be about 100 if we were to directly measure it from one of our arteries. If we went on BiPAP at 100% with this level of pressure, our PO2 should be about 500 to 600. And Ms. Schara's PO2 is 52. So that just provides clear evidence that her lungs are not working. She simply cannot get oxygen from the environment into her bloodstream. And so I think that's how this note was most significant.
At this point in time, on October 10th, 2021, do you believe she was experiencing the conditions of shunt and VQ mismatch?
Absolutely. When you don't, the hallmark of shunt is not raising your oxygen level when you receive supplemental oxygen. So the fact that her PO2 is 52, that's evidence that she clearly has a lot of shunt.
And by the way, doctor, you mentioned, I believe you mentioned arterial blood gases.
Yes.
Did you review those results?
Yes, I did.
At least at this point in time, doctor, on October 10th, 2021, is there any evidence of a metabolic acidosis?
No. So Grace, well, the primary problem that Ms. Schara has is a respiratory alkalosis. I know that as you look at her pH, a normal pH is 7.4. If it's lower than that, it's an acidosis. If it's higher than that, it's an alkalosis. Her pH is 7.44, so she has an alkalosis. And then in order to figure out what's driving that at the carbon dioxide level, If the carbon dioxide level is low, that means you're blowing off your carbon dioxide, and that raises your pH. And so we call that a respiratory alkalosis. So she has a respiratory alkalosis on that day. Her serum bicarbonate is 21, which is normally it's about 24. So technically she meets the criteria for a metabolic acidosis, but she has a metabolic acidosis to compensate for how fast she's breathing. So the way I would describe this blood gas and her serum bicarbonate, this is a respiratory alkalosis with a secondary metabolic acidosis that's compensating for her breathing so fast and becoming alkalotic. Your brain, when your blood pH starts to rise, it actually is very bad for the cells in the brain. And so your brain has sensors that say, whoa, you're breathing too fast. I have to stop you from breathing. So, there's only so far you can breathe and so low you can drop your carbon dioxide. The kidneys sense that. And in about 2 to 3 days of breathing really, really fast, your kidneys will start to waste bicarbonate to compensate and try to bring your pH from being alkalotic and high back down to normal. You never quite get back to normal, but if she didn't have a bicarb of 21, her pH would have been even higher. So she has a respiratory, that's the primary problem.
Metabolic acidosis that you're describing here, is that different than what Dr. Burdine is referring to?
Yeah, it's completely different. This is a normal kidney compensation for someone who's breathing really fast.
It's not in any way life-threatening?
No, the breathing fast and the low oxygen level is absolutely life-threatening. The bicarbonate of 21 in compensation for the respiratory alkalosis is not life-threatening. It's an important compensation.
And is her respiratory rate at this point driven by the respiratory alkalosis?
Well, it's driven by the lung disease, and that's causing the respiratory.
And at this point in time, if you're a treating physician, is one of your goals to try and control that respiratory rate?
Well, it's difficult. My goal at this point, having been on, if someone's on BiPAP, we usually think of BiPAP as a bridge. It's a bridge to getting better, or it's a bridge to going on a full breathing machine. And we know from other studies in infectious disease that if you're not getting better within 48 hours, you actually do better if we put you on a full breathing machine than allowing you to be on BiPAP for a long period of time. And so at this point, as they were thinking already on the 8th, we're now day 4, she's not getting better. She would have benefited at this point in time from being placed on that would have been my major goal at that time, would be to try to get her on a full breathing machine so we could support her more effectively.
I don't know if it's too clear or not, but this breaking point.
Morning break at this time. So I think we'll do what we have normally done, which is like that 20 minutes. And if that's different than what you guys need, just let the bailiffs know. Folks with you, and a reminder not to discuss this with anyone, including each other. The jurors are excused. All right, you may be seated. Doctor, you can step down if you want, or you can stay there. But if you leave, if you could be back in 20 minutes from now, so like at on that.
That's okay?
Yeah, absolutely. Okay, during that session, we had one sidebar. It was regarding Exhibit 7. I think Attorney Fleiter, you had some concerns that you hadn't received, that you looked through it, and on page 1, you had concerned about like a learned treatise that might not have been cited or referenced. I think you said, Attorney Guzzi, it wasn't a learned treatise. I was just making a record. And then there were like 2 pages where there were some issues, and I think Attorney Guzzi, you said you weren't going to use it, or those pages. Attorney Fleiter, you took it back with you so you could look at it. I tried to explain to the jury on, the exhibits, to buy you some time to look through it, but also because we might not give the complete exhibit, we might just give portions. So anything you want to add to that sidebar, Attorney Fleiter?
No, Your Honor, I think that's accurate.
Attorney Guzzi?
No, Your Honor.
Attorney,
No, Your Honor.
okay. Anything you need to do?
No, Your Honor, from plaintiff.
Does any of the attorneys want to be in here during the lunch hour? To work? Because I've worked it out where they'll have staff if you want to be here. And I apologize, I didn't realize that it wasn't open to you guys until yesterday, but if you do, just let the clerk know. But it can be available for you if you want to be here to work. It'll be closed to others. Okay, we'll see you at like 1:45 on that clock. We're adjourned.
So we're finished up our first morning session with yet another doctor fully bought into the defense and saying that COVID is what killed her and had absolutely nothing to do with the drugs that they never asked for permission to give her. I think this is exactly what we expected out of the defense. I think that there's probably going to be another 2 more witnesses that are similar to this testifying basically that because of the lung condition is why she died, and it has absolutely nothing to the medication. They haven't gotten to the point where they've talked about on cross yet on would overdosing on these drugs potentially cause the same issues. So I'm excited to hear for that, and I'm sure that there's going to be rebuttal witnesses to speak against them from the plaintiffs at some point as well. So still going on this. It looks like we'll have about 10-15 minute break. What I've noticed is that most of these breaks go a little bit shorter because they have another hearing kind of in the middle where they bring the jury in. So we should be back in just a few more minutes. I appreciate everybody's patience. A quick note for those of you joining us for the first time. The stream that we're utilizing here is from the Children's Health. They have a very, very low quality stream to the point where sometimes the stream actually resets and goes backwards for some reason, and I have to refresh it and start over. So just be patient with me. I will be keeping an eye on it as much as humanly possible. Try and catch that as quick as possible so you won't lose any time. But I do make mistakes, so I apologize for that potentially in advance. Generally happens after lunch for some. So hopefully everything will be working out just fine, and we'll keep this going all day. Thanks.
one more juror, so we're back on the record in 23 CV 345. Just approach, since we have a minute as we're waiting for a jury. Good. Well, welcome back. I heard you are ordering Mexican today, so that's going to be delivered at 11:30. So my plan right now is to see if we can go an hour and 40 minutes until like that 11:30. If you need a break before that, just let. But it'll be this witness the entire time, and from what I understand, we're not going to be finished with them at 11:30. So our plan will go until 11:30, and then we'll take our lunch break. All right, Attorney.
For 10th, 2021, do you have an understanding that Mr. Schara was asked to leave the hospital?
Yes.
What's your understanding as to why Mr. Schara was asked to leave the hospital?
So he had exhibited signs and symptoms of COVID, and there was a hospital policy that, patients, or excuse me, visitors who had COVID could not be in the hospital.
Was it a breach of the standard of care to have Mr. Schara removed from the hospital based on showing signs of COVID-19 infection on October 10th?
No, it was not a breach. That in fact was the standard in almost every hospital in the country.
What kind of dangers might be posed to have someone with an active COVID infection without PPE in the hospital?
So I think there are two big risks. One is the risk to staff and other visitors to the hospital of potentially spreading the virus. The other risk is to that person themselves. They're sick. They're not a patient in the hospital. If something were to happen where they needed medical care, it would be a dangerous situation.
Concerned both about patient safety with regard to visitors and
And for the person who's sick.
Doctor, the next exhibit that I want to have you review is Exhibit 214. I believe you have that in front of you.
I do, yeah.
Are you able to identify that document for us?
So this is a note from October 11th, Dr. Carl Baum at 11:30 in the morning.
And is this a document that you reviewed and you relied upon in formulating your opinions in this case?
It is, yes.
Permission of Exhibit 214? Permission to publish. Doctor, explain why this note was significant in formulating your opinions in this case.
So it again talks about her being on low dose Precedex. They're trying to titrate that off, but she was calm when Dr. Baum saw her today. It also talks about she's tolerating the BiPAP, but she's not able to tolerate the Vapotherm, which is the high flow nasal cannula, because it's too loud. It also goes over, she's still on 90% oxygen. She's on a little bit less pressure on the BiPAP, but she's still breathing 32 times a minute. So her work of breathing is still significant. And then he also talks about the COVID treatment. She's getting her dexamethasone, but she's no longer a candidate for tocilizumab or remdesivir because we've moved out of that time window. And then it also talks about the nutrition issue, which, as we said, was going to be an important thing to is to be able to deliver nutrition.
Dr. Baum's note refers to the pressure settings on the BiPAP machine.
Yep.
15/12 with FiO2 of 90%. Can you translate that for us?
Yeah, so the 90% is how much oxygen is being delivered. So as we talked about earlier, we're all breathing about 21% oxygen, so she's getting 90% oxygen. And then the pressure is the top number, or the first number is the inspiratory pressure. So every time you take a breath in, that's how much pressure in millimeters of mercury is being blown into the machine to help you take a bigger breath. And then the second number is the constant pressure. We call that the end expiratory pressure. The way I think about it is, imagine if you're driving down the highway at 50 miles an hour, you stick your head out the window and open your mouth, you have a constant pressure. And what that does is it tries to open up the airways. And then every time you take a breath in, you slam on the gas and go a little bit faster so more air comes in. So it helps you take bigger breaths, but it also helps open up those blocked air sacs. So she was on 15/12, which is a pretty significant amount of BiPAP. It says up top on the physical exam 12/5, but if you look at the BiPAP charts and in the assessment and plan, it was 15/12.
What are the max settings for pressure settings on a BiPAP?
It depends on the indication. If someone has respiratory muscle weakness, so if they have a degenerative neurologic disorder and they're not able to take big breaths, we might raise that inspiratory pressure as high as 20 for some people. The expiratory pressure, the second number, I mean, once you get above 10, it's really hard to maintain that pressure because you have leaks of the mask. These are really, really high settings. This is about as high as you could probably have for someone with respiratory failure from an infection.
Doctor, is there anything else in this exhibit that you would have utilized or relied upon in formulating your opinion in this case?
No, those are the main things. And again, just his remark that it's difficult for her to tap long enough to eat a meal, that just, again, tells us that she's dependent upon this machine right now. She can't take it off to.
Well, let me ask you this, doctor. I mean, you give us a little bit of an idea of what they're referring to here. I mean, in terms of what happens when someone's trying to be given oral intake with a BiPAP mask.
Yeah. So in order to eat with a BiPAP, you can't eat with a BiPAP mask on because you're constantly having this pressure being blown in the face. So it'd be very, very easy if you put something in your mouth for it to just get shot down into the lung. Because unlike when you have a breathing tube in place, we don't have any protection of the airway. So the air can go in the BiPAP mask, the air goes both into the trachea down into the lungs, but also goes into the stomach. And so if you had food or liquid in your mouth and then you have this BiPAP mask on it, it might shoot that down into the lung, and that would cause inflammation and injury to the lung. And the fact that she can't, every time you take the mask off, number one, you're no longer delivering that 90% oxygen, but you also lose all that pressure that you had built up inside the chest to keep things open. So if you had some that had opened up from that pressure, the moment you take that mask off, they completely collapse down again. We call that de-recruitment or collapsing of the lung. And so she was not able to tolerate being off that BiPAP mask long enough to be able to take in anything by mouth.
And doctor, I want to be clear about your testimony on the aspiration. You're saying that's something that can happen. You're not saying that it happened in this case.
That's correct. There's no evidence that happened in this case, but that's one of the reasons you can't eat when you have the BiPAP mask on. It's too high risk.
What about in terms of removing when you're talking about removing the mask for oral, what happens with oxygen saturations at that point?
They'll fall, and there are multiple documentations by nursing in the chart. Whenever her mask was removed, to either try to feed her or to try to have her tolerate the high flow nasal cannula, her oxygen saturations would fall, and they'd have to put the mask back on.
A little or a lot?
I mean, I'm not sure exactly how to define that, but they would fall to dangerously low levels.
The next I'd like you to take a look at is Exhibit 218. Do you have that in front of you, Doctor?
I do.
Are you able to identify Exhibit 218 for us?
And this is a note on October 12th by Dr. George Gandev.
What's Dr. Gandev's specialty?
Pulmonary critical care.
And is this a document that you relied upon in formulating your opinion?
Yes, it is.
For admission of Exhibit 218. Thank you, Judge. Tell us what is significant in this particular progress note in terms of your opinions in this case.
So I think it again established Ms. Schara was. He talks about how yesterday she had a brief period of time where we were able to decrease the FiO2 on BiPAP. and he was maybe a little bit encouraged, but this morning we had to increase it back up again. He also mentions that her PO intake, which means how much she's able to take in by mouth, has been extremely limited. And it brings up the idea of a feeding tube or other ways of providing nutrition. He talks about trying to try that Vapotherm again, which is the high flow nasal cannula, but she's not been able to tolerate that to date. Those are the main things, establishing that she's sort of going up and down, but she remains critically ill. He also talks about, he mentions she's in the chronic phase of COVID-19 because he thinks the x-ray may start showing some signs of fibrosis. So I think it's starting to mention that if Ms. Schara is going to recover because of how long she's been ill, it's likely going to be a process. It's not going to be something that happens overnight.
You mentioned fibrosis. Can you explain to the ladies and gentlemen of the jury what exactly fibrosis is?
So fibrosis just means scarring. And so when you have ARDS, this acute respiratory distress syndrome that we talked about, it usually starts out with this diffuse inflammation that with fluid, and then patients can go one of two directions. They either get better over time, either because you've treated the infection or you've given them time for the lung to heal. But unfortunately, some patients go down a different pathway and they start developing scarring of the lining of the lung. And in those patients, it can be very difficult to ever get them off a breathing machine. Not entirely clear if that's what was happening, but she's in that realm of, wow, it's been now 6 days. She's not getting any better. She's certainly at risk for developing this scarring phase from her acute lung injury and the ARDS.
And would scarring be considered long-term damage to the lungs?
Yes, many people who recover from ARDS, long-term scarring of their lungs and diminished lung function.
Is Dr. Ganda's observation of that the x-rays show some fibrosis, is that an indication that Grace's condition is continuing to deteriorate?
Yes, this is one of the many factors that suggest she's not improving.
All right, doctor, the next document I'd like you to take a look at is Exhibit 220. You have that in front of you?
I do.
Identify that document for us.
So this is a note by Dr. Anthony Zamet. He's an infectious disease doctor, and this was on October 13th, 2021.
And is this a document that you relied upon in formulating your opinions in this case? It is. Move for admission of Exhibit 220.
No. That's received.
All right, doctor. In reviewing this note and the contents of, tell us what was significant to you in formulating your opinions in this case.
Yeah. So the first thing that Dr. Zamet says is that she continues to be BiPAP dependent. She's on maximum BiPAP measures now. That she's having her oxygen levels drop down to the 80s, and he thinks that she may need to get intubated. He then goes on to say that in his recommendations, it appears that she's slowly losing the battle with the BiPAP. Her oxygen saturations are in the 80s. She likely may need to be intubated, unfortunately. I think this just clearly establishes that things have not gotten better, they've gotten worse, and that they're on maximum life support, essentially, short of putting Ms. Schara on a breathing machine.
I see that there's a number of lab results listed in that note. Were any of those significant to you in formulating your opinion?
They're just indicative of Ms. Schara is inflamed. So her CRP is a C-reactive protein that for a while during COVID, we were measuring that routinely every few days just to get a sense of where someone's inflammation levels were. And this is pretty high. Normal's less than 2. It's on the hospital lab, but at most hospitals it's less than 2. So this is pretty high. The LDH is another inflammatory marker, also really high. The D-dimer is very, very high. That's a marker of just sort of small blood vessel dysfunction, if you will. So shows you that she's very, very inflamed. And we know that because she's on max settings on the BiPAP and her oxygen levels are still dangerously low.
And the inflammation, is that being driven by acute respiratory distress syndrome?
Yeah, that's part of it. All acute respiratory distress syndrome caused by COVID-19.
I guess I'll just ask you this, doctor, in terms of inflammation, tell us about how that affects the patient's condition in the context of ARDS.
Sure. So the continued inflammation, number one, we know there's inflammation in the lung. We've looked at her chest x-ray from October 13th, and it showed that it was worsening and both lungs were filled up with fluid. So a lot of that inflammation is actually in the lung itself. But there's all sorts of other things that happen when you have COVID that can lead to problems with the microcirculation, which maybe is why her D-dimer is high up. So you're having problems delivering oxygen to the tissues that need it. And she also has low oxygen levels. So all of this just tells you how sick she is and is clearly evidence that she's not getting better.
Doctor, is there anything about Dr. Zymet's note that you haven't discussed that was significant to you formulating your opinions in this case?
No, I think we've covered the major issues.
All right. Talk about Dr. Shokar's time when he was caring for Grace. But first, you had mentioned something about minute ventilation before.
Yes.
I think you prepared a graphic, or I take that back. It's actually
That's just from the chart. Yeah.
Matt, can you number 258? 57. No, 58. Do you have exhibit 258?
I do, yes.
Can you identify that document for us?
So this is the respiratory therapist flow sheet for the BiPAP on October 12th, 2021.
And is that document relied upon in formulating your opinions in this case?
Yes, I did.
Permission of exhibit 258.
No.
So I might have to stand up to point at stuff. Are you guys able to
Just keep your voice up a little bit, doctor.
Yeah. So this is basically her BiPAP flow sheet. So this right here, this spontaneous VT, that's the size of her breath. So you can see her breaths are between 400 and almost 700. So for her size, that's actually a little bit big. She's only 4'8". So her breaths probably normally would be more like 300 or so. So she's taking pretty large breaths. They have a set rate on the machine of 14. So if the respiratory rate dropped below that, the machine would kick in to give her extra breaths. But her actual respiratory rate is 34, 27, 41, as high as 49. And then this VE here is just multiplying the size of the breath times the number of the breaths. And remember, I said a normal ventilation for us in this room would be 5 to 6 liters per minute. Per minute ventilation was 16, 17, 21, 27, 19, 19. So she was 3 or 4 times what should be normal. And so at the same time, she's also on 100% oxygen, highest amount of oxygen we can provide. And then these are her pressure settings. She's on 15/12, which again are very, very high pressure settings. It's approaching the max of what we can do with this machine. And with that, you see multiple oxygen levels, 87, 86, 86, 86, 90. So despite the maximum pressure on the BiPAP machine at maximum oxygen, she's barely getting her sats above 85%, and her work with breathing is really high.
And this is from October 12th of 2021?
Yes, it is.
We've heard the reference to the concept of work of breathing a few times.
Yeah.
And maybe it's obvious to everyone. Can you get, not so much to me. Can you give us a kind of idea of what that means, work of breathing in medical terms?
Sure. So there's lots of things that go into it. The simplest measure that we have is your respiratory rate. So most of us in this room right now, our respiratory rate should be 12 to 16. When we get sick, it gets faster. Ms. Schara's respiratory rate, as measured here, is in the high 40s. So, 3 to 4 times what it should normally be. So that's one measure of the work of breathing. The minute ventilation that we looked at also tells you that she's working hard because she's moving 4 times the amount of air that we would normally move. The other measures of work of breathing really come from looking at the patient, looking at the way the chest and the belly are moving together. We all have, our main muscle of breathing is our diaphragm, but we also have muscles up here in our neck and our chest that actually can help generate an additional pressure. And so you can look at someone and you can see, are they using these extra muscles in their neck? Are they contracting their abdominal muscles to blow the air out faster? So it's really hard to get that from the chart because that's not something that's documented, but it's very clear from her respiratory rate and her minute ventilation that she is working really hard to breathe. Just to put this in perspective, there's something we call the maximum voluntary ventilation, which is how much air can you move in a minute? And for most people, it's you take how much air you can blow out in a second and you multiply that by 40. And so you can sort of estimate that for Ms. Schara based on her height. Her maximum voluntary ventilation is probably about 50 or 60 liters per minute. And she's moving like 30 liters per minute of air. So she's like, for days, is running a marathon, right? She is working at near capacity. And there's only a limited amount of time that you can do that before you just can't do it anymore.
All right, doctor. Let's talk about the period of time in which Dr. Shokar was caring for Grace. I believe you have Exhibit 217 in front of you.
Hang on one second, let me find it. Yes, I have it.
Can you identify that document for us?
So this is a note by Dr. Shokar on October 12th, 2021.
Is this a document that you relied upon in reaching your opinions in this case?
Yes, it is.
Move into evidence Exhibit 217. So doctor, what I'd like you to do is kind of give us a little bit of detail about what Dr. Shokar is documenting in terms of Grace's condition on the morning of October 12th, 2020.
Sure. So when he examines her, she's on the BiPAP. He says she was comfortable, although not verbal at that time. She was on Precedex, which is the sedative that we've talked about. He remarks about her variable FiO2 and BiPAP. She's at that point in time, she's on 85%, and she's still on those pressures of 15 over. He does say she was able to prone, which means she was able to lie on her belly. And as we talked about, sometimes we do that to try to help with your oxygen levels. He talks about her respiratory rates between 31 and 48, and her oxygen saturation at that time was 92. He did notice some crackles when he listened to her lung, which means that she takes a breath, hear sort of like a sound, which tells you that the lungs are filled with fluid or scarring. You can't really tell the difference at the bedside. He goes over her labs, which again show the elevated D-dimer. He talks about her blood gas, which we can go over in a moment. He reviewed her x-ray from the day before, which showed that things had gotten worse as we had looked at from the 8th to the 11th. Ms. Schara's x-rays had gotten worse. And then he currently, on the bottom, he talks about she's hyperventilating, and we'll get into the blood gases later, but that basically means she's blowing down her carbon dioxide and she has that respiratory alkalosis. And he's worried that this might impair her oxygen level. Breathing this fast is using up a lot of oxygen. And so he's worried that if that increases, they may have to do something about it. He's worried about her breathing so fast that her oxygen levels won't tolerate that.
Let me stop you right there
Yeah.
for a second, doctor. What you just mentioned about that Dr. Shokar is evidencing concern of or thoughts of basically do if a respiratory rate increases. that would seem to be, that's evidence that Dr. Shokar was already thinking it.
Absolutely. He recognizes how critically ill Ms. Schara was at this point.
I'm sorry, I didn't mean to interrupt you, doctor. Keep on going.
And then he also talks about discussing nutritional status and what they might be able to do in terms of nutrition. Again, thinking about how are we going to get her out of the situation? She needs to get nutrition if she's going to recover.
Yeah, and also documents the level of Precedex that she, at the point he was in the room.
Yes, he said it was at 0.6 at that time.
Are you able to determine from this record what the indications were for that level of Precedex?
Well, he mentions her breathing fast, worried that it's possibly from anxiety. She's calm and somewhat cooperative, as he describes. So that would imply that if the Precedex is being used to treat agitation and anxiety, it's working at this point in time at that current dose.
Doctor, when you look at some of the data in this particular film, it kind of looks like things are, I mean, when you look at temperature, et cetera, would it be fair to say that Grace was kind of stabilized at this point?
I don't like to use the word stable or stabilized. She's critically ill. I mean, she's on near maximum BiPAP machine with low oxygen levels. So she's hanging on where she is, but I would avoid the word stable because I think she's critically ill.
I mean, was she at a point in time, based on what you're seeing here and everything that you've gone through up to this point, was she at a point where she could potentially crash at any time?
Absolutely.
By crash, we mean cardiac arrest?
Yes.
And that would be due to respiratory failure?
Yes, in this case, it would be due to low oxygen levels or high.
So even on the 12th, would you consider her condition to be emergent?
Yes, she's critically ill.
Anything else about this note that you think important or you thought was important in terms of formulating your opinions?
No, I think we've covered the major points.
All right. You have exhibit 222 in front of you.
Yes, I do. This is Dr. Shokar's note from October 13th, 2021.
You relied upon this document in formulating your opinion?
Yes, I did.
Evidence exhibit 222. You blow it up a little bit. So Dr. Garibaldi, tell us what is significant to you in this note.
I think it might be, is it okay if I just read the first paragraph? I think it might be helpful to go through it.
If you have comments about the various
Sure.
entries, go ahead.
So Dr. Shokar wrote, the patient was doing well on same settings of BiPAP this morning of 20/15 at 100%. So now she's on actually a higher level of BiPAP than she was before. She was on 15/12. Now she's on 20/15. To be honest, I've never used BiPAP settings this high. This is really, really high. She was unable to wean to 90%. That means they couldn't drop her oxygen level because she desaturates to the 80s, her oxygen level falls. She had an episode where she got agitated after being assisted to Precedex was increased to help control agitation as she is starting to try to pull out a pick and remove the mask. So I think this clearly describes the danger of her agitation. With the mask on, she's barely maintaining her oxygen levels. If she pulls the mask off, that's life-threatening. She requires restraints by the time of interview with the goal to remove the restraints as soon as possible. The agitation was so severe that they had to put restraints on her hands so that she couldn't get to the BiPAP mask or to the PICC line. She was able to prone here and there overnight, which means she was able to lie on her belly. This morning, it seems that we've been having less success proning her for more than 20 to 30 minutes as she returns back over onto her side. And they're going to continue working on the proning. So I think this establishes how sick Ms. Schara is. She's now on even higher levels of support. She's more agitated, and she's potentially trying to remove the only thing that's keeping her alive. And so it clearly establishes the rationale and the need for the Precedex to try to prevent her from doing those things. So that's sort of the medical piece of this note, which I think is really important. Next piece clearly establishes the substance of the conversations that Dr. Shokar had with Ms. Schara's family about.
And how about we do this? Let's
Yeah.
go back to that.
Sure.
'Cause I want to kind of finish up or take us through the events of the 13th. Doctor, in reviewing the records, can you give us a sense of the overall clinical presentation of Grace on October 13th, in particular in the afternoon and evening?
So over the course of the evening on the 12th and into the 13th, Ms. Schara clearly was worsening. She's requiring more BiPAP. She's on maximum oxygen. She's more agitated. And despite all of these things, her oxygen levels are barely hitting the 90% mark. She has now reached the limit of what can be done medically for her, short of putting her on a full breathing machine. When you're on this much oxygen and this much support on the BiPAP and it's not working, to do anything else. The only thing that could have saved her life at this point would be to put her on a breathing machine, intubate her, sedate her, paralyze her, put her on her belly. That's really the only medical thing that could have been done to save her life at this point.
Can you give us an idea what her respiration rate was in the afternoon?
So her respirations were climbing. So if we look at that same respiratory therapy chart that we looked at on the 12th, on the 13th, her minute ventilation rose above 30. Her respiratory rates were routinely in the 40s to 50s. I don't recall a single respiratory rate less than 20. So her increasing, the amount of support she was requiring was increasing. Her ability to raise her oxygen level, there were a total of 14 different distinct measurements of her pulse oximetry that were below 90%, and many of those were below 80%. She had clearly reached the maximum support that could be provided, short of putting her on a full breathing machine.
As a pulmonologist and critical care doc, Dr. Garibaldi, do you have a major concern at this point about her respiratory rate?
Yeah, I mean, respiratory rate in the 50s with a minute ventilation in the 20s to 30s is not sustainable.
Given the fact that case intubation was not an option, would it be reasonable for a physician to attempt to use medications to try to reduce that respiratory rate of breathing?
As to facts, not in evidence, that intubation was not an option. It was an assumed fact in the question. It's not in evidence.
Okay. Based on your review of the records, Doctor, in Grace Schara's chart, were you able to come to the conclusion intubation had been recommended and it was not available as a tool for the physicians?
Yes, so Dr. Shokar documented 2 discussions where he talked to Ms. Schara's family.
This might be a good time to flip back to.
Oh, sure.
I think it's 222.
Yep, that's the one that the second paragraph of 222.
Yeah.
There's also 219 also has, the 2 discussions are 219 and 222.
Let's start with 219.
Okay.
Sorry about that. A little bit of a curveball. Okay. Based on your review of the records up until time, did you see anything in the records that indicated that the physicians at St. Elizabeth had been given authorization to intubate Grace?
No. So there's this discussion on the 12th where Dr. Shokar raises the possibility of having to put her on a full breathing machine, or intubating her means putting a breathing tube in and putting you on a ventilator. And on the 12th, when she was getting sicker, they had this discussion, and the family had not yet decided what they wanted to do about that. And Dr. Shokar made it very an urgent decision. We need you to decide as soon as possible, because at any point she could get to the point where we need to put her on this breathing machine. And then the following day, they had another discussion, at which point they clearly said that consensus was Ms. Schara to be placed on a full breathing machine. She was do not intubate, or DNI. And that was an order that was placed in the chart by Dr. Schara, or excuse me, by Dr. Shokar after that discussion with the Schara family. So it was very clear that on the 13th, intubation was not a medical treatment that was within the goals of care of the Schara family.
And by the afternoon of the 13th, information was in Grace's chart that she was do not intubate.
That is correct.
So back to my question, at this point in time in the afternoon of the 13th, when Grace's respiration rate is in the 40s, 50s, her work of breathing is an issue. And there's no ability to intubate, would it be reasonable for a physician to administer medications in an attempt to reduce the respiratory rate and extend Grace's life?
Yeah, this is an impossible situation. The only way to save her life, in my opinion, was to put her on a breathing machine. So since that wasn't an option, I think it was very reasonable to try to reduce her work of breathing just a little bit, to see if we could maybe have her not use as much from working so hard to breathe, and maybe that buys her a little bit of time. So I again want to emphasize how difficult a situation this is and how rare this type of situation is. What Dr. Shokar did was very reasonable given the constraints that he was facing in terms of not being able to place her on a full breathing machine.
Now, throughout her hospitalization, Grace had received doses of lorazepam.
Yes, that's correct.
Is lorazepam a medication that is routinely used in an ICU?
Yes.
And in terms of standard of care, the administration of lorazepam, I want to break it down a little. Prior to the afternoon of October 13th, that was within standard of care?
Yes, absolutely.
So let's be more specific and talk about the lorazepam administered in the afternoon. It's your understanding as to the doses of lorazepam that were administered to Grace.
Yes, she received two 0.5 milligram doses. And just so everyone, lorazepam, you may have heard this medicine before. It's called Ativan, is the common trade name for it.
What are the indications for Ativan or lorazepam?
Yeah, the main reasons we use it are for anxiety and agitation.
Can you give us some idea or characterization of how large a dose 0.5 milligrams is?
That's the lowest dose we give.
What about, what about when you administer 2.5 doses of lorazepam within a 3-minute period? Is that still considered a minimal dose?
Yes, typically when we give the bolus dosing or acute dosing in the ICU, we use 2 milligrams. Someone's seizing, we might use 5 milligrams. So half a milligram times 2 is just 1 milligram, and that's a very low dose of this medication.
Does lorazepam have something known as, well, let me back up. You're familiar with the term peak effect?
Yes.
Can you explain to us what effect is?
So it's basically the amount of time it takes for the drug you're administering to achieve its desired or maximum effect. And for Ativan, it's on the order of 5 to 10 minutes. If you give it IV, it'll be different based on the way in which you give it.
And you've ordered lorazepam?
Yes, many times.
In your experience, if a patient were to experience an quote unquote overdose event after administration of 2 doses of 0.5 milligrams of lorazepam 3 minutes apart, would you expect evidence of that overdose would be observed within?
Yeah, I mean, on the order of minutes, 5, 10, maybe on the outset, 15 minutes.
Is there any evidence in the record, on the records that you reviewed, that indicated some type of overdose within 15 to, at all?
Yeah, so I'll be careful with the word overdose. Like overdose is when you give a dose of medicine that's outside the recommended therapeutic dose of medicine. So even if she had experienced a side effect of the Ativan, which she did, it wouldn't be considered an overdose because she was getting therapeutic dosing of the medicine. But no, there was no evidence that she had an adverse effect from the Ativan that she received.
So I'm using the wrong term by using overdose.
I wouldn't use overdose here.
That's not a fair characterization.
No, and she did not have any adverse effects in the chart, and it was certainly not an overdose.
Based on review of the medical records, were you able to determine the purpose for which lorazepam was administered at 1746 and 1749 on October 13th?
Yes, it was administered for a combination of agitation and work of breathing.
Was Dr. Shokar, well, let me back up. Do you have an understanding that it was earlier dose was pursuant to an PRN order by Dr. Beck?
Which dose are you referring to as the?
36 dose.
I believe that's correct.
And your understanding is that Dr. Shokar gave a verbal order to Holly McGinnis to administer the second dose at 1749.
Understanding, yes.
Was Dr. Shokar's decision and subsequent order to administer 2 doses of 0.5 milligram of lorazepam 3 minutes apart on the evening of October 13th, 2021, reasonable considering the circumstances that he was facing?
Yes, it was.
Was Dr. Shokar's decision and subsequent order to administer 2 doses of 0.5 milligrams of lorazepam 3 minutes apart on the evening of October 13th a breach of the standard of care?
No, it was not.
Explain your basis for that opinion, please, doctor.
So as we talked about earlier, Ms. Schara at this point was on the therapies that were within her goals of care. And Dr. Shokar is trying to reduce her work of breathing in the hopes that he can buy her more time for her lungs to recover.
Moving forward to later in the evening, based on your review of the records, doctor, were you able to determine whether a dose of morphine was ordered and administered to Grace Schara?
Yes, she did receive a dose. I can't remember the exact time. I believe it was sometime after 6 o'clock, but I can't remember the exact time. I apologize.
Now, doctor, there's been evidence in this case that before the morphine was administered, the monitors in Grace's room were not picking up a blood pressure. Are you aware of that from your review of the records?
Yeah, if you look at her vital sign charts, the blood pressures are recorded every 30 minutes, and then there's a stretch where there are other vital signs recorded every 5 minutes, but there's no blood pressure being recorded.
But there's a pulse.
There is, yes.
And
Yes.
we clearly know she did, it's not that she had no blood pressure, right?
Yeah, I can't determine from the records why there's no blood pressure reading that's recorded there.
If she had no blood pressure, period, she would have expired at that point.
Yeah, she would have had a cardiac arrest.
Doctor, under normal circumstances, would you be concerned about ordering the administration of morphine to a patient with a low blood pressure?
Yeah, under normal circumstances, when you give morphine, you can get an initial drop in your blood pressure. Usually happens within the first 5 to 10 minutes if it's going to happen. Doesn't happen all the time. So you want to be mindful of that. But I think in this particular situation, the reason the morphine was given was because her respiratory rate was in the 50s and her oxygen saturations were in the 70s to 80s. And again, it's this balancing of trying to breathing to keep her alive. So I don't think this was a normal circumstance.
Ask you, these, and you've said it a couple times, these weren't normal circumstances, were they?
No, they were absolutely not. This is not a normal situation. This was an end-of-life situation where Dr. Shokar was doing the best that he could to try to keep Ms. Schara alive.
Because the standard of care in this case actually would have required intubation.
If intubation was within the goals of care of the Schara family, then absolutely Ms. Schara would have been intubated.
And by virtue of the decision to make Grace DNI, that intervention that would have been standard of care was not available to Dr. Shokar?
That is correct. He was not able to place Grace on a full breathing machine or intubate her.
Going back to the blood pressure, in reviewing the records, were you able to determine what happened to Grace's blood pressure after the administration of the morphine?
Yeah, so shortly after, maybe 15, 30 minutes after the administration of the morphine, she had a normal blood pressure. That was the next recorded blood pressure. So there's no evidence that if the blood pressure had been low, it wasn't recorded, there's no evidence that the morphine led to low blood pressure.
What can you tell us about Grace's respiratory rate after the morphine was administered?
So the respiratory rate came down from the 50s to the high 30s, low 40s.
Would that still have been a concerning respiratory rate?
Yes, that's still concerning, but it's less concerning than 55 to 60.
Oxygen saturation levels.
Yeah, so our oxygen saturation actually came up after the morphine. I think the highest recorded after that was either 96 or 98 for a short period of time after the morphine.
And 2 milligrams of morphine, is that considered a small morphine?
That's probably the typical dose that we would use for most people in the hospital.
And again, talking about peak effect, what would be the peak effect of morphine?
If you give it IV, it's probably about 10 to 15 minutes.
And if a patient was to experience a side effect due to the morphine, you would expect to see it within that 10 to 15 minutes.
Yes, you would expect to see it within that 10 to 15 minutes.
And in this case,
Yeah, the only blood pressure we have after the morphine or immediately after morphine administration was a normal blood pressure.
So do you have an opinion to a reasonable degree of medical probability as to whether the intervention by Dr. Shokar in administering the morphine had the effect that he?
I think it did for a short while. There was a small improvement after giving that dose.
Water a little bit more time.
Maybe a little bit more time, yes.
Administration of the ordering and administering of 2 milligrams of morphine, a breach of the standard of care.
No, it was not.
All right, doctor, let's go back to the topic of DNI and DNR orders. Yeah, we can leave, Matt, this is good. Then get ready for the 10:13. Doctor, have you been in the unfortunate position of having to have DNR discussions with patients? Or
Very frequently. Yes.
not a fun conversation, is it?
No.
One of the hardest things that you do as a physician?
Yes, I think it is.
Take those conversations very seriously.
Absolutely.
Do you have an understanding as to what the standard of care requires of a doctor having a DNR discussion with a patient's advocate when that individual is an inpatient in the ICU?
Yes, I do.
And if, let me ask you this, doctor, does the standard of care require a witness?
No, it does not.
Does it require a document signed by the patient or a patient's advocate to be in the patient's chart?
No, it does not.
Is the fact that there is an order indicated in the EMR entered by the physician, is that sufficient to document the DNR?
That plus a documentation of the discussion, yes.
Doctor, have you heard of something called a POLST, P-O-L-S-T document?
I have, yes. That stands for, well, let me make sure I get it right. Physician ordering of life-saving treatment.
And what, can you give us a general idea of what a pulse?
Yeah, so a pulsed form is something that a patient and their family will fill out with usually a physician, which outlines their code status. So it deals with issues related to DNR and DNI, but it oftentimes deals with other issues like if, if I'm in a coma, should I get additional nutrition? If I have a serious infection, should you bring me back to the hospital? So it details a number of different things in addition to the code status that we're talking about. Pulsed is the term is different state by state. I don't know what it's called in Wisconsin. Different states have different requirements about whether or not that needs document. Usually states require that is a signed document by the physician and either the patient or their healthcare surrogate. But that's different than what happens in the hospital. When you're in the hospital, what you do is you document the discussion and then you place an order in the chart. There is no informed consent form or signature that's required by a patient or their surrogate for a DNR, DNI order in the hospital.
Pulse orders are, from your perspective, that might be something you see when a patient comes in?
Yeah, so they oftentimes there's something that would be presented to the paramedics, for example, if someone calls 911 or when someone comes into the hospital, or them out when we're transferring a patient who's leaving the intensive care unit, so that everyone's very clear when this person leaves the ICU, what are their goals and their preferences, either as they're transferring to another facility or as they're going back home. We wouldn't fill out a pulse even to move someone from the ICU to another unit in the same hospital. The orders and the notes from the chart would suffice for while you're in that one facility.
So as far as this case is concerned, the concept of a pulse form is entirely irrelevant.
Yeah, it doesn't, they could have filled out a pulsed form going through all these different preferences, but for this particular discussion about DNI, the discussion that was had, the documentation of that discussion, and then placing the order in the chart met the standard of care.
So, this is 219. All right. Let's talk a little bit about the discussion that occurred on the evening of October 12th, 2021. Doctor, I want you to kind of walk us through it, and from your perspective as a pulmonary and critical care doctor who's had these types of discussions with the patient, okay?
Yep.
Tell me, I guess, what's all being conveyed?
Yeah. So I think the first thing that Dr. Shokar is documenting, and this is the discussion that he had, was just reviewing how sick Ms. Schara was. So the first, he says that her oxygen saturations have deteriorated, requiring increasing BiPAP settings, 100% FiO2, yet still her oxygenation was in the low 80s. So despite near maximal support, her oxygen level is still dangerously low. In response to that, they increased those levels to 20/15, as we talked about, which is a really high setting. And that improved her oxygenation to the high 80s, so it helped maybe a little bit. And then he goes on to say he initially discussed with Mrs. Schara, Cindy, the patient's mother, goals of care in regard to worst case scenario if she was requiring intubation. And she deferred me to her husband, Scott, or Mr. Schara. He called Mr. Schara, had a family conference with him and his children in regards to worst case scenario if the BiPAP at max settings was ineffective. So they talked about they can do the positional changes like proning. And then they went over scenarios in regard to intubation versus leaving her on BiPAP in the situation of her hypoxia versus even going towards comfort care. So they're even starting to talk about, well, if we can't put her on a breathing machine and the BiPAP's not working, should we think about moving towards comfort care? And then we spent, this is a 60-minute conference. And the end of that conference was the family's going to convene and decide on what to do, hopefully before the evening. They initially wanted to decide by tomorrow morning, but he implored them the importance of deciding as early as possible, given her deterioration throughout the day. And then he goes on to say, we do need a direct answer in regards if she needs intubation, if we should intubate, and should we do resuscitation. And then the last piece I think is also very important here. He discussed with them in regard to a cardiac arrest in the context of respiratory arrest or respiratory distress. And he mentioned the futility of doing CPR, compressions, defibrillation if we can't intubate underlying lung disease and ongoing hypoxia. So basically what he said is that if we can't put Grace on a breathing machine because her oxygen levels are low, and then her heart stops from low oxygen levels, we're not going to be able to bring her back. Because if the reason she dies is low oxygen levels, and we can't put her on a breathing machine to raise the oxygen, we can't get her back. We can't fix the reason that her heart stopped. So he was very clear in this discussion that if we're not going to put her on a breathing machine and she dies from low oxygen levels, which is what happened, they would not be able to get her back.
In other words, he was indicating that under that circumstance, quantitative measures would be futile.
Yes, he even uses the word futility in his note.
Do you agree that at this point in time in Grace's condition, that without intubation, resuscitative measures would have been futile?
Yes, they would not have been effective.
Is that an opinion you hold to a reasonable degree of probability in the field of pulmonary and critical care medicine?
Yes.
In terms of this overall conversation, Doctor, it looks like Dr. Shokar discussed, I guess, the goals of care here,
Yes.
and that's reasonable within standard of care,
Absolutely. This was exactly the type of conversation that needed to be had.
the entire conversation.
Yes.
And as part of the standard of care for these types of discussions, does the standard of care require you to answer questions on behalf of the family?
Yes.
And what does this particular note indicate as to whether Dr. Shokar answered the questions of the family?
I mean, he writes, we spent over 60 minutes during this conference to answer all questions that were posed and counseled as best as possible in regard to the unfortunate situation.
And that's also within standard of care.
Absolutely.
So in terms of this discussion, 12/2021, is it your opinion to a reasonable degree of medical probability that this conversation was consistent with the standard of care in terms of discussing DNI and DNR orders? Let's turn to 13. Doctor, on the 13th, there's a continuation of this discussion. Again, from your perspective as a pulmonary specialist who's had these types of discussions, can you tell us what the information is that's being conveyed here?
So they had a repeat discussion to revisit the issues they talked about on the 12th. And he writes that the family had deliberated yesterday after our conversation and decided for a DNI status, which means do not intubate. And then this discussion, we discussed in regards to CPR resuscitation and the futility of doing CPR in the situation in regards to DNI. And they agreed in regards to not pursuing resuscitation via CPR or defibrillation in the event of respiratory arrest leading to a cardiac arrest. So basically, the family had decided that placing a breathing tube and putting Ms. Schara on a breathing machine was not within their goals of care. And they talked about how if she were to die from respiratory failure, if she were to die from low oxygen levels, it would be futile to try to do CPR or to pursue resuscitation. And so at that moment, they agreed to place a DNR order. And that was the appropriate order given the do not intubate decision.
If at some point in time after this order is entered, if, well, strike that. Let's do this. In reviewing this note, and then two notes in tandem covering the DNI, DNR discussions.
Yes.
Were these discussions reasonable?
Yes, they were. They were necessary.
And code status is important to hospital staff, right?
Yes, and to patients and their families.
Right. And why is code status important to the hospital staff as well?
So the staff needs to know what to do in the event of an emergency. We need to know, are we doing CPR? Are we placing someone on a breathing machine? Are we shocking their heart? And you need to know that right away because every moment counts when someone is critically ill. If someone has a cardiac arrest, we know that the longer you wait before you start resuscitation, the less likely it is you're going to survive. So we need to know before it happens, ideally, what we're going to do in the event that it happens.
And if the family's desires or wishes are to not intubate a patient, not without a clear order in the chart, hospital staff in an emergency is going to intubate the patient, right?
That's correct. If there's no clear order in the chart,
And
the default is to do all resuscitative measures, including intubation.
And if that's against the wishes, that is potentially deviation from the standard of care.
Yes, that would be to resuscitate someone against the family's wishes would be a deviation in the standard of care.
And are those opinions that you hold to a reasonable degree of medical probability in the fields of pulmonary and critical care medicine?
Yes.
Overall, general question in terms of the entry of the do not resuscitate order on October 13th, 2021. Did Dr. Shokar meet the applicable standard of care for a hospitalist in an ICU?
Yes, he did.
So we talked a little bit about metabolic acidosis, and we're getting close to the end, Doctor. And I told you that Dr. Burdine has referenced to metabolic acidosis. You prepared a graph for us or chart showing various ABG results. And
I did, yes.
Part of 257, Matt. Thank you. So tell us what you're trying to convey to us through this chart as it relates to Dr. Burdine's metabolic acidosis theory.
Yeah, so this.
Speak up. Doctor, there is a bit.
Right, this chart shows 4 blood gases starting on October 9th through October 12th. And then also I pulled the nearest serum bicarbonate level on those days. And so what you can see on each one of these days, Schara's pH was elevated. So to remind you guys, above 7.4 means she has alkalosis. That's the primary problem. The carbon dioxide is less than 40, which tells you she's breathing off carbon dioxide, which is why she's got a pH that's higher than normal. These are oxygen levels that just show that her oxygen is severely depressed. She was on 100% oxygen for almost all of these gases. And then here is your serum bicarbonate. So a serum bicarbonate less than 23 technically is a metabolic acidosis, less than 24 is acidosis. On 4 separate occasions before the 13th, each time the serum bicarbonate was low, it was breathing really fast and having respiratory complications. So the most reasonable and likely explanation of bicarbonate of 19 on October 13th is exactly the same explanation that's going on these 4 days. Breathing really, really fast. The carbon dioxide levels are low. She has this respiratory alkalosis and her kidneys are healthy responding. I also brought up this NIM gap. And I don't want to go into too much into this, but these are all normal values. These are basically someone's serum labs and look for unmeasured anions. If you have an elevated level, usually above 14 or 15, that tells you your body's making extra acid. Right? If you had a lactic acidosis, meaning you're not delivering adequate oxygen or blood to your tissues, lactate starts to build up, and this will start to shoot up. It'll go really high. It'll get up to the 20s or 30s. And so Dr. Burdine has written in his reports that this bicarb of 19 meant that Grace had a severe metabolic acidosis because she wasn't delivering blood. If that were true, her anion gap would have been elevated because she would have had a lactic acidosis. She did not. And so the most likely explanation. I'm sorry. Okay.
All right, Attorney Guzzi, you can continue. Just make sure you turn your microphone back on. I know you turned it off.
Yeah, so the reason I made this chart is just to show that the most likely reason that her bicarbonate was a little bit low on the 13th is the same reason it was a little bit on the 4 days leading up to the 13th. There was no evidence that Grace had a primary metabolic acidosis that would have had to have been a lactic acidosis. There's no evidence for that. The most likely explanation is this was a response for her breathing really fast because her lungs were so sick.
And then his testimony, he talked a lot about base excess.
Yeah.
How does that relate to what you're showing us up?
Sure. So when you get a blood gas, you'll get an estimate of what the serum bicarb would be. And then it'll also say what your base so base excess. If you had an acidosis, the base excess basically tells you, or let's say a negative base excess would mean that you have to add some extra base to raise your pH back to normal. So it basically means you have a metabolic acidosis. I didn't get into all the base excess here because clinically we never use it. We look at the blood gas pH, we look at the PCO2, we look at the serum bicarb, we calculate the anion gap. I don't do clinicians who routinely talk about base excess. I could have showed those here. There are some days where she had a negative base excess, some days where it was close to normal, but the preponderance of the evidence shows that she had a respiratory alkalosis with a secondary metabolic acidosis, and she was never acidotic. She never had an acidosis. She always had a pH above 7.4.
Dr. Burdine also testified or was asked whether a negative base excess could be an indication of either respiratory alkalosis or chronic respiratory alkalosis. And he said a negative base excess wouldn't potentially be an indication. Is he right on that?
No, he's wrong. A negative, and it could be caused as a primary process, or it can be exactly as I've shown here, a secondary process to a respiratory issue.
Doctor, in your report, you talk about the ABGs. I think you made a reference to ABGs done on the 13th.
Yeah.
No ABGs were done on the 13th.
No, when you look at the chart, the ABGs go vertically and horizontally. So 11th ABG thinking it was on the 13th. The last ABG is the ABG on the 12th that I'm showing here.
Was there any indication on October 13th to order an ABG?
I don't think so. There's nothing. I mean, we know what the primary process was. We know that her lungs were getting worse, and we didn't really have any additional. There was no additional therapies that could be applied other than the therapies that were being given.
And let me narrow that down. So were there any indications in the morning and the afternoon of the 13th to have an ABG done?
I mean, as she's getting worse towards maybe an ABG would have been an additional piece of information to try to understand what's happening, but I don't think an ABG at any point on the 13th would have changed the ultimate outcome, given the fact that the only therapy that would have changed the outcome was intubation, and that was not possible.
In reviewing the records, did you see any indication that, Dr. Shokar did order ABGs later in the afternoon?
He did at sometime around 4 or 5 o'clock. I can't remember the exact time.
And that was a step.
I believe it was, yes.
What does that mean?
That means please do it as quickly as possible.
Was that reasonable?
To order it stat? Yeah, absolutely.
And was it within the standard of care?
Yes.
Dr. Burdine also testified on occasions, or several instances, that if Grace had been taken home and put on BiPAP and supplemental oxygen, Grace would have survived COVID-19. Do you agree with that?
I do not.
You've got a couple of slides to show us why you disagree with that.
Yeah, so I think the first issue is that so when you talk about, Grace had a home CPAP machine because she had sleep apnea. Those machines are designed to deliver just the end expiratory pressure, just that second number in the BiPAP numbers we've been looking at. But they're only designed to give up to 6 liters of oxygen for someone who chronically needs oxygen. And so 6 liters of oxygen will get you up to maybe 40% oxygen. And as early as the night of the 6th, Ms. Schara was on as high as 100% oxygen and was always on 70 to 100% oxygen. There is no home CPAP or BiPAP device that can deliver that much oxygen. So I think that's really what I wanted to say there. The other thing to think about is we don't send people home on BiPAP when they have an acute new process. We'll send someone home on BiPAP if they have chronic respiratory failure from muscle, or maybe they use it at night because they have a chronic lung disease, but we don't do it in the acute setting. The only place that Ms. Schara could have received the care she needed was in the intensive care unit, which is where she was. If you go to the next slide, I want to talk about the amount of oxygen that she was requiring. So if you look at someone who's on 100% oxygen on a BiPAP machine or a ventilator, it's about 40 to 50 liters per minute of oxygen that we deliver. 40 to 50 liters per minute. The best home concentrator that concentrates home gets up to 10 liters per minute, right? And there are reports of people like putting two of them together, which you're not supposed to do, and it probably is not super effective, but maybe you get up to 15 to 20 liters a minute, which is still half of the amount of oxygen that Grace required. If you look over the course of a day, that would have been up to 72,000 liters of oxygen. The biggest tank that we have is like 7 liters. And so that would be like 6 ginormous 100-something pound tanks being delivered every few hours to a machine that is not designed to deliver that much oxygen. In the hospital, the way that we actually meet this requirement is we call them oxygen farms. We live ginormous silos of liquid oxygen. Some hospitals make it on their own. Other hospitals, the hospital, Hopkins, where I worked at for 25 years, we had a company that would make liquid oxygen and then deliver it to these oxygen farms. And the reason is that 1 liter of liquid oxygen delivers almost 1,000 liters of gaseous oxygen or oxygen that you can breathe. There simply is no way to deliver the amount of oxygen that Ms. Schara needed outside of the intensive care unit. It's not possible. She would have died from hypoxia after leaving the ICU within hours to days. She could not have survived anywhere other than in that intensive care unit.
Doctor, and you may have mentioned this earlier, from a point in time in Grace's hospitalization where the only intervention that could have preserved Grace's life was mechanical ventilation.
Yes.
And when do you think that was?
It was certainly on the 13th, but it would have been very reasonable to place her on a breathing machine, have the goals of care much earlier than that.
Doctor, do you, based on your review of Grace Schara's medical records, do you have an opinion as to whether Grace's condition had deteriorated to the point that on October 13th, resuscitative measures would have been futile without mechanical ventilation?
Yes, I agree that resuscitation without mechanical ventilation would have been futile.
Is that an opinion that you hold to a reasonable degree of medical probability?
Yes, it is.
Do you have an opinion as to whether Grace's death was caused by Precedex, lorazepam, or morphine, either separately or in combination?
It was not. Grace's death was COVID-19 pneumonia leading to distress syndrome and hypoxia.
Is that an opinion you hold to a reasonable degree of medical probability within the fields of pulmonary and critical care medicine?
Yes, it is.
Did the order, and I think you've just testified as to your opinion as to what you believe the actual cause of death was?
Yes. Her cause of death was COVID-19 pneumonia leading to acute respiratory distress syndrome.
Of the care or treatment rendered by Dr. Shokar cause harm to Grace Schara?
No.
Is that an opinion you hold to a reasonable medical probability in the fields of pulmonary and critical care medicine? Yes. Did any of the care or treatment rendered by Dr. Shokar cause Grace's death?
No, absolutely not.
Is that an opinion you hold to a reasonable degree of medical probability in the fields of pulmonary and critical care medicine?
Yes.
Did any of the care or treatment provided by the hospital staff of St. Elizabeth harm to Grace Schara? Is that an opinion you hold to a reasonable degree of medical probability?
Yes, it is.
Did any of the care or treatment rendered by the hospital staff of St. Elizabeth cause Grace's death?
No.
Hold that opinion to a reasonable degree of medical probability?
Yes.
Conversations with Shokar and the Schara family regarding DNI, those conversations, do you have an opinion as to whether those met the appropriate standard of care?
Yeah.
Is that an opinion you hold to a reasonable degree of medical probability?
Yes.
Doctor, have all of the opinions you've given here today been given to a reasonable degree of medical probability in the fields of pulmonary medicine and critical care medicine?
Yes.
Thank you, doctor.
Thank you.
I have no questions, Your Honor.
All right, cross attorney Slater.
Thank you, Judge. Start just briefly where you started with Attorney Guzzi. You're being paid $12,000 today to testify for Dr. Shokar.
Yes, I am.
Okay, would you have done it for 10,000 or did you need 12?
That's my standard rate, and that's in
Okay.
keeping with other experts, what they charge for ICU-related consultation.
Okay, so usually I'm charging that kind of money for this thing?
Yeah, the folks I know who do this is within their standards, yes.
I want to talk about first some of the things that you discussed with Attorney Guzzi and some other questions.
Sure.
I think we've only got a half hour before the lunch break, so we're probably not going to get through everything.
That's fine.
First of all, are there any questions that you wish Mr. Guzzi would have asked you that you didn't get to answer, or anything else that you wanted to share with the jury?
We covered most of the important things in the case.
Okay, any important things we didn't cover?
Off the top of my head, I can't think of any questions that I wish he had asked.
You reviewed the medical records in this case, correct?
Yes.
And you also reviewed depositions in this case?
Yes, I did.
Okay. Why do you keep on looking at Mr. Guzzi?
That I am.
Okay, I thought you just were.
No.
Actually, let's move the podium out of the way. Better?
Do you mind to the side? You, Attorney Frankowiak, okay. We'll just, we'll get it over to the side.
Okay, doctor, you said that your medical record in the deposition is correct?
Yes, that's correct.
Okay, where in the record did you see that Dr. Shokar told anyone in the Schara family that Grace needed a ventilator right away?
Well, if we can go back to his notes, we can
Sure.
talk about all the scenarios that he talked about.
About scenarios, I mean, when did he call them and say, hey, your daughter's going to die right now if you don't put her on a ventilator? Where did he say that at?
Well, I don't think he documented that specific discussion. There's multiple discussions that were documented where he told them how sick, how we're approaching the point where she might not survive without a ventilator.
Okay, but the question that I asked, that's not in the record, correct?
I don't believe that specific question's in the record.
You spent 3 hours with Attorney Guzzi. You never mentioned any oversedation events on October 7th. Why is that?
I mean, he didn't ask the question about it. There was an event we talked about side effects of medications.
Yeah.
And I believe I talked about that where she had bradycardia and hypotension on the 7th.
Okay, on October 7th. And
Yeah.
she had it again on October 8th, right?
From the night of the 7th into the morning of the 8th. That's
Okay.
correct.
And in fact, the event on October 8th actually required atropine, dopamine, norepinephrine, right?
Yeah, she required support for her bradycardia and
Okay,
hypertension.
and some of those drugs had to be put in through a PICC line, right?
Yes, she had a PICC
Okay,
line, which is
what's-
essential.
What's a PICC line?
Line is a central line. Basically, it goes in the brachial vein in your arm usually and goes all the way up and sits down into your heart.
Right,
And so it allows you to give medicines that might otherwise be caustic to small veins. It also allows you to draw blood very, very easily. So a lot of medications or a lot of blood draws, or if they need medicines that are best delivered centrally to large vessels, that you can use a PICC line or you can use a central line in the neck. And
in fact, on October 8th, Grace's condition was such that she actually required these resuscitation drugs to go right into her heart. Is that right?
I wouldn't call. She needed vasopressor drugs.
Okay,
So
norepinephrine. Okay, somebody, you're trying to, it's like an EpiPen. Is that what's in an EpiPen?
no, it's a different drug. That would be epinephrine. Norepinephrine is another substance that raises your blood pressure.
Okay,
Doesn't have
similar drugs.
similar, but not the same drug.
You never mentioned the fact in your direct that Grace had this reaction to Precedex and required these drugs. Did that inform your opinion of whether Grace was overdosed on the 13th, or how did you consider the fact that this had happened on the 8th?
I think I did mention that she clearly had a side effect to Precedex, which was the bradycardia. I would not call it an overdose because she was receiving therapeutic dosing of the drug. She had a known and common side effect of that drug, which was why she was in the ICU to be monitored for that. And when that happened, they responded appropriately.
Drug drops your blood pressure to the extent you need to have a line put into your heart. You wouldn't call that an overdose?
No, it's not an overdose. It was a side effect of the medication. It is a known complication of that medicine, which is in the ICU when you get it.
Yeah.
They were anticipating it, they saw it, they treated it, and she had no long-lasting effects from that episode.
So if it's a known side effect, that's not an overdose?
No, it's not an overdose, it's a side effect. An overdose would be if they had given her 5 times the recommended dose of Precedex. That would be an overdose. They gave her standard therapy, and she had a known adverse reaction to it.
So your position, I would assume, would be that it's impossible to overdose someone as long as you're giving the recommended dose.
Well, we're getting into semantics here, but she was getting therapeutic dosing of Precedex, and she had a known complication to it, a known adverse event. That is not an overdose. She did not accidentally get 5 times the recommended. That would be an overdose. And that can happen. You can accidentally give someone 10 times the dose of insulin. That's an overdose. But if you have low blood sugar from giving a regular dose of insulin, that's not an overdose. That's a side effect of insulin.
Yeah, and I hate to really stick on these terms, but I think it's an important term, right? I'm sure you would agree. We had a toxicologist in here, and for the defense, and he defined an overdose as any dose having an ill effect on the patient. You, I guess, would disagree with the toxicologist.
Well, I'd have to see his whole testimony, but in my understanding and the way I use the word overdose, an overdose would be you gave a dose that was outside the therapeutic range, but an adverse event can happen with the regular dose of the medication that you give, and that's what happened in this particular case. I don't think that, honestly, I know you're sticking on this point, but she was within the accepted range of the dosing of this medication, and she had an adverse effect that is a known recognition or known problem with this drug. They responded to it accordingly. I don't think it matters what you call it. She wasn't receiving an inappropriate large amount of Precedex. She was within the standard of care.
Yeah, thank you. I just want to be clear. You would have to review his entire testimony to tell us if you disagree with that.
I haven't heard or seen his deposition. I haven't seen his expert report, so I don't know exactly the context in which he's using it.
Yeah. Point. You did read the depositions in this case?
I did read the depositions. I don't think I saw the expert report from this particular toxicologist, though.
Read the expert depositions?
I did, yes.
Okay, do you remember in Dr. Goldberger's deposition where he actually defined overdose?
I'm happy to read the section now. I don't recall. It's been months since I've read his deposition. I'm sorry.
I think we got the point. Yeah. You took a position here with attorney that morphine does not require consent in the ICU, right?
It's context dependent, but to give it for pain control or for anxiety or shortness of breath, no. If you're using it to do an invasive procedure, then yes, that would be part of the consent process. But in this case, it did not require consent.
Okay, you would agree that morphine is an opiate?
Yes, it is.
Okay, you familiar with the opiate crisis country?
Yes, I don't see it has any bearing on sedation in the intensive care unit.
Well, my point is that people, they get killed with these drugs, right? You're aware of that?
Yes, I'm aware of what happens when someone takes these drugs outside of medical supervision.
Okay, but the point is, these can be potentially dangerous drugs, is that right?
Absolutely.
And so it would be your position that in an ICU, a physician can give a potentially deadly opiate to a patient and never get consent for that drug?
Yes, that is standard of care. We do not get consent for giving pain medicines or anxiolytics in the intensive care unit.
Does a physician even have to tell the family member or the patient that he or she is about to give them this opiate before they, inject it?
Well, we usually tell people the treatment plan and what we're trying to do, but we don't tell patients or their families before every dose of every single medicine.
Oh, of course not, but we're talking about morphine, right?
Yeah, we do not routinely get informed consent for morphine. It's not standard of care.
Yeah, I understand. That wasn't my question, though. My question was, do you tell the patient or the family member before you give it?
Well, usually it's about what we're giving them. Yeah,
Is there?
but it's not to get consent. I don't understand what you're getting at, sir.
Well, we've heard testimony in this case, doctor, that the family members weren't even told about the drugs they were receiving. So the question that I'm posing to you is an example of morphine. Standard of care, in your opinion, even require a physician to tell a patient that they're going to get morphine?
And there are multiple points in the chart where there are documentation of describing the reason for both lorazepam and X.
Does
in the
someone
chart.
come into the room every morning with a copy of the chart from the day before?
I don't believe so, no. I'm not sure what you're getting
Okay.
at.
Well, I'm getting at, that doesn't mean the family knows it's happening, right?
Documentation that there were discussions with the family about the reason to give lorazepam and the reason to give Precedex. Those are documented in the chart earlier on in the hospitalization. And we don't make distinctions between, if it's okay to give a sedative in one situation, permission for each individual sedative.
You talked a little bit about the Precedex package insert. Remember that? Do you ever look at those documents?
I did, yes.
You looked at the Precedex one.
Did, yes.
Okay. Do you ever look at those outside of in preparation for your testimony today?
I'm on the pulmonary drug advisory committee for the FDA, so I look at package inserts all the time.
You ever look at them as part of your practice?
No.
What's in those package inserts?
So it's of study information. So what is the studies that led to the FDA approving that drug? And that will include the phase 1 studies that show how the drug is metabolized, time to peak onset, how it's eliminated in the body. It'll show the phase 2 trials looking at effectiveness, and then it'll show usually for medicines like Precedex, there was a phase 3 clinical looking at comparing Precedex to other commercially available sedatives. And so all of that data is in the package insert. And then it also has prescribing information for providers. I believe it has something like a section for patients, which gives a summary of sort of a high level summary of all of those things.
Mention any adverse effects?
Oh, no, the adverse effects are in there.
Okay, yeah.
Yep.
And how are those adverse? You're on the FDA, approval panel. Where do they get these adverse effects out of? These studies that are done?
Yeah, these are from the clinical trials that were done that led to the approval of that medication.
How long do those take?
Oh gosh, it depends on the risk benefits of that particular drug. The whole approval process can take up to 7 to 8 years.
Okay.
I don't know the specific studies for Precedex were, I think, about 1,100 patients, but I don't know the time frame and how long it took to.
So there's years of study that go into these things. They list the adverse effects. there's this information, but I think you also testify that you don't even use these things as guidelines in your practice.
No, the package insert is absolutely not a guideline.
We talked about a number of notes from Dr. Shokar. They were up on the screen, you remember?
Yes.
Dr. Shokar here at this trial has actually challenged the accuracy of some components of the medical record. My question to you is, how do you know Shokar, his notes accurately reflect his conversations with the family? How do you know that?
Just based on my own standard practice, I usually try to write as accurately as possible, particularly around conversations around the end of life.
Okay, do you practice with Dr. Shokar?
I do not practice with Dr. Shokar, but I can tell you that in reading tons of family conference notes, his notes are very well detailed and outline his thought process better than most notes that you would read in a medical record.
Do you have your report up there?
I do, yes.
You remember writing that report?
I do, yes.
You discussed a concept today called secondary metabolic acidosis. You remember that?
I do, yeah.
Not in your report, is it?
No, I discussed the respiratory alkalosis and how Ms. Schara did not have a primary metabolic acidosis.
And you never said there was a secondary metabolic acidosis. This was the first time that maybe outside of conversations that you've had that you've even talked about that concept.
Well, the reason I brought it up today was in response to a specific rebuttal, that report that Dr. Burdine had written that I didn't see before my own deposition. So I didn't think it was necessary to get into the concept of a secondary metabolic acidosis when it was clear that Ms. Schara did not have a primary metabolic acidosis.
Yeah, and that would normally be a good point, but you said that you based that opinion on the medical record, which I presume you had, when you wrote your first opinion, right?
Yes.
Okay. You didn't say that you were, basing that on Dr. Burdine's rebuttal report.
No, she clearly, as I showed with the primary records from the chart, she had a primary respiratory alkalosis. That was her main metabolic derangement.
You're here to, well, I know you were hired by the law firm representing Dr. Shokar, but here as an expert, I mean, you're not here to be an advocate for Dr. Shokar, right?
No. To talk about the facts of the case.
Tell it like it is, right? And part of telling it like it is would be explaining to the jury some things that might not support your case, right?
Sure.
Okay. I get it. You have it mirrored now. Doctor, you never mentioned anything when you were in direct examination from Attorney Guzzi. You never mentioned anything about Grace feeling better or any of her COVID symptoms actually improving. And I asked you at the beginning of your cross whether or not you wish you would have been able to say something, and you said no. I want to show you. There's not a question yet. I want to show you one of the exhibits that we looked at. Okay.
Get out of it or present.
Okay, this was exhibit 214. There was a part of this note that you didn't think was notable. I'm gonna highlight it here. Oops.
Yes, It's Texas.
Hold on. I got it. I can do it. All right.
I thought it was the young guys that were supposed to be able to handle it. That's right.
Okay. So here it says, this was in Dr. Baum's note from October the 11th. It says, while she states she is feeling better, cough improving. You didn't tell that to the jury when you're talking about Grace's condition and how it was so. Could you please explain to the jury why that wasn't important for you to bring up, that she was feeling better and actually her cough was improving on this day?
Yeah, I mean, it's great that she was feeling better. I honestly jumped down to where she's on 15/12 with BiPAP on 90%, which tells you functionally what's happening with her lungs.
Yeah, but
So
wasn't
you're
my
absolutely right.
question.
I
Yeah.
should have said that. I should have read that out. I don't know why I skipped over it. We read
Yeah.
through a lot of notes.
Okay, so yeah, you should have said that, right? Because that's part of the clinical picture here.
Sure.
Yeah, but you
the
didn't.
clinical picture was also she's on 15/12 of BiPAP setting, on 90%.
I hear you, but I'm
Yeah.
just going on what you said. It's important to show both sides of the case,
Sure.
right?
No,
You're here as an expert.
I absolutely should have read that. I don't know why I didn't.
These people are relying on your opinion, and they could believe you. I'll withdraw it. I mean,
Set a time, so, because the court reporter's trying to take it down, and she's been staring at me for the last couple minutes.
sorry.
So just a reminder, no.
I want to talk about the respiratory flow sheet. You remember that?
Yeah, I do. Is this the one from the 12th?
This is the one from the 12th, yeah.
Okay.
You said that you relied on this in forming your opinions in this case, correct?
It's part of the data that I used, yes.
Yeah, of course, right. When did you get this? When did you get this document?
So this is the last like 30 pages of the revised medical chart that I got in like May of 2024.
Okay, so you got it at the same time we did, about 5 weeks ago or so.
Whenever that, I have two medical charts. The second one, which is the newer one, has this in it.
Okay, so this wasn't part of your original opinion, thing that you added on after you got this?
I'd have to look back at my records and see when I got this. I think I knew what her BiPAP settings were, and I knew what her respiratory rate was. So I don't know exactly when I saw this, but I thought I had it before my report went in, but I'm not 100% sure.
Okay, you think you might have got this last year?
It's like the last 30 pages, the 90-page chart. And I'm pretty sure I had that before I prepared my report for everyone.
Okay, I want to go to 217 here. You
I'm
testified.
all out of order. Hang on
Yeah,
a second.
sure. You testified. Okay, we got 5 minutes, I guess. You testified when you were looking at this doc. We're going to zoom in for a minute in a second. I know the jury can't see it. You testified with this document that this reflected that Dr. Shokar was having concerns about Grace's hyperventilation affecting her O2 or oxygen levels. Do you remember that?
Yes, I do.
Okay, but you didn't talk about this part here at the bottom. And it says her last ABG actually revealed a normal PCO2, and do not expect that the elevated respiratory rate / hyperventilation is impairing her oxygen at this time. Did you read that with me?
Yeah, do I see that?
Okay, why didn't you explain to the jury that actually Dr. Shokar did not it was impairing her oxygenation at that time? Why didn't you tell them that?
What I think I said was that he was laying the groundwork for if her respiratory rate increases even further, then he would be really worried about how it would impact her, and laying the groundwork for why he eventually gave her morphine.
Oh, so he wasn't concerned at this time. He was just laying the groundwork.
Oh, I think he's concerned. She's hyperventilating. She's on high doses of BiPAP. He's laying out on multiple notes on this day. He had family discussion talking about how critically ill she is and we need to decide an intubation. He's absolutely concerned about her respiratory status.
Okay, but he did not think at this time actually that her elevated respiratory rate was impairing her oxygenation.
He wrote that. I don't agree with that. I think it absolutely was.
Okay, you disagree with Dr. Shokar in this note.
Particular point, I think her respiratory rate and her minute ventilation was absolutely impairing her oxygenation.
Anything else with him on before we keep going?
No, I think that's a point where I think the data supports that she was breathing really fast, high minute ventilation, and was profoundly hypoxic.
Okay,
They're all intertwined.
Why didn't you tell the jury that you disagreed with Dr. Shokar's analysis at this time?
Because his analysis, you asked me what I thought was most important about the note. That was the direct question.
Yeah.
From Mr. Guzzi. And what I thought was most significant is he's talking about how the respiratory rate, if it gets worse, is likely going to be impairing her oxygenation, which then lays the groundwork for why he gives her morphine.
Okay.
So I didn't go, you can go through each one of these notes and find a sentence that I didn't talk to the jury because the question I was asked was, what did you find most important about this note? Not read the entire note. So I had to pick and choose the things that I thought were important to explain to the jury because there are 50 progress notes that we could have gone through.
Yeah, I get it. And this was something you didn't think was important enough to explain, right?
No, I didn't think it was important in how I used this note in making my opinion, which was the question that I was asked.
Probably a good time for a break, Judge. Oh, we can. Okay, sure. Doctor, we saw a chart earlier in this trial with Dr. Berdine's testimony, and it showed the different drug administrations that were happening on the 13th, and it showed Grace's respiratory rate kind of laid on top of that. In your review of the record, did you notice any correlation between respiratory rate and the drugs that were given?
Yeah, the biggest correlation was on the 13th when she was given the dose of morphine. There was definitely a decrease in her respiratory rate. It went from 50s to down to the 30s.
Okay.
And her overall minute ventilation dropped by about 20%.
Understood. Besides that, did you see any correlation? Maybe as the drugs were being given, the respiratory rate was going up. Did you see that?
I can't recall. I know the chart that you're talking about that Dr. Berdine wrote. I don't have it in front of me, so I can't recall those exact.
Okay, would it
charts.
refresh your recollection if I showed it to you, or?
If you want to ask me questions about it, I need to see
Okay.
it.
We'll get it after the break.
Sure.
It'd be great, yeah.
Members of the jury, I just got a note saying the food is back, but it's being unloaded, but I figured it would be up in the room within a couple of minutes. So just a reminder, not to discuss the case with anyone, including each other. The bailiffs will get you your phones and so you can use those, and we'll see you back here probably in about an hour. Jury, it's excused. Doctor, if you step down if you want, you can just be back here in an hour. All right, everyone may be seated. Yeah, you can step out if you want, or you can sit in here if you want, whatever Attorney Guzzi tells you. Mr. Fleiter, you were missing for a day and a half, and you kind of fired up.
I'm ready to go, Judge.
You're knocking off Mr. Mendenhall when he's coming up to assist. Were you locked up in a closet or what?
Good night of sleep.
Okay. We had one sidebar during the time, and Attorney Fleiter, you had asked for the sidebar, and it had to do with this secondary metabolic acidosis, and I think you expressed to me that He never had provided that opinion, that it was a new opinion. Um, During his deposition testimony, he said something different, I think is what you said. And Attorney Guzzi, you said, you know, they had asked the wrong questions, which I think was fabricated probably, but consistent. I mean, that was our conversation. And then what I said was, I think it's all proper cross-examination, just like what I did when the plaintiff's experts were up here. I gave to give opinions. I also said I didn't know what he said during his deposition, but you could definitely use it to impeach him. Anything you want to add to that sidebar?
No, Your Honor, thank you.
And I was careful, Attorney Boylan, when they walked away, not to say objection one way or the other because of what I did yesterday, if you objected or not, or just ask for a sidebar.
I objected.
Okay, see, I didn't overrule you because I didn't want to do what I did yesterday. So in essence, the objection was overruled and I allowed Attorney Guzzi to ask the questions. Anything you want, Mr. Guzzi? Mr. Frank Koyak?
No, Your Honor.
All right, I think we're up to date on the exhibits, other than the clerk is working with the plaintiff, I think on 3 or 4 things. So if you can just keep making sure we get those ones marked from yesterday. Those would be exhibits 82, 83, and 87. And then I was handed a note this morning that exhibit 1, which is the medical record, but that hasn't ever been marked yet, even though I think you guys are working on that, right? Attorney Fleiter?
We actually just had a copy printed. We're picking it up today. We didn't know what was happening with that, so we have a full copy. We got it. We have the number of copies then.
Okay, so so those 3 exhibits from the plaintiff yesterday, and then that exhibit, kind of clean that up, hopefully before the weekend.
And then, yeah, I think it's important. There was some additional pages to being part of the record. Those are coming into the same exhibit 1. Okay.
So just look at whatever is going to be marked as exhibit number 1, make sure everybody agrees, and then get it with the clerk and we'll mark it, okay? Is 12:30 good for everybody? Okay, all right, we'll see everybody then.
So that was definitely an interesting morning. I think this guy was completely full of crap. But I guess we'll see what the jury had to think about that. Looks like we're about to go to lunch now, and we'll see what happens. I think the rest of the cross right afterwards. Still haven't tried 1775 coffee? Now's your shot. The 1775 starter kit just dropped, only 1,000 units. You're getting the bold dark roast that hits harder than a CNN fact check, the smooth medium roast, and the vitality mushroom coffee for clean energy and laser focus, no crash. All single origin, small batch, toxin free, and mold free. Plus, you're also getting a gold spoon clip because freedom isn't scooped with plastic. A frother strong enough to stir up your coffee and your mother-in-law's political opinions. And a black 1775 tumbler that says, I don't take life advice or caffeine from a woke sea witch. $170 worth of coffee and gear, yours for $99. This is for the ones who've been watching 1775 blow up on Rumble, wondering if it's actually worth it. Spoiler, it is. Go to 1775coffee.com/studio and grab your starter kit before they're gone. Bold beans, clean fuel, and a morning routine that stands for something. Just like Rumble does. Start your day with coffee that actually backs what you believe. So for those of you watching on YouTube, I recommend coming on over to Rumble. There's a more active chat. You can actually interact with the people talking about this today. So come on over to Rumble. See you guys in a little while.
we go. Okay, doctor, before the break, I mentioned a chart that showed the respiratory rate and drugs that were given here. You can see this top portion of the chart, the green kind of block being the Precedex level, the orange bars being lorazepam administration, and the last gray bar there being morphine. And I asked you a question whether you had analyzed or determined whether there was a correlation between respiratory rate in this case and the different drugs that were administered on October the 13th. I asked if it would be helpful for you to view this chart, and then obviously, viewing this chart, assuming you can see it, do you notice any correlation there?
Yeah, I'm gonna have to, I can't see that far, so I'm gonna have to stand up and look. And this is the first time I'm seeing that.
Standing as you're answering, you can, or you can sit and stand however you want. And do we have a hard copy for him to look at as well? Has this been marked as an exhibit?
It was part of Dr. Burdine's, which we'll have to submit tomorrow as a hard copy. I didn't know we were going here today.
Okay.
But we'll have a, I guess, copy of the full presentation to submit for the clerk tomorrow.
First pass looking at this, let's go up until the first lorazepam bar. Precedex dosing starts out at 0.8 and goes up to as high as 1.4, which is the highest dose we typically use. And you can see that on 0.8, the respiratory rate's fluctuating, so 37, 32, 40, 37. As the dosing goes up, there's a little bit of a drop from 41 to 32, but then it rises again to 52. So I don't see a correlation there between Precedex dosing, the respiratory rate, and in fact, as we talked about earlier, Precedex typically doesn't slow your respiratory rate. So I wouldn't have expected to see a big change with changes in the Precedex dose and the respiratory rate. Lorazepam can slow your respiratory rate. I don't know what that 2 is. That's at noon. So that was probably when she got her dose around the time of her NG2 placement. And you see a respiratory rate actually goes, there's no drop in respiratory rate there. So that doesn't seem like the lorazepam did it. I don't think that was the dose she got. And I know that she got 0.5 milligrams, not 2 milligrams, as that implies later on. And then here you see her respiratory rates in the 50s. And then she gets the doses of lorazepam and then the dose of morphine. Not the doses she received. That's too high a dose of lorazepam. She got a quarter of that dose.
So we've already been through the timeline. I guess.
Well, you're asking me to
No. I'm just asking if you see any correlation. It sounds like your answer is no.
The only correlation you see is after the morphine, the respiratory rate drop.
Okay.
That was the intent of doing that analysis.
Sure. On the 13th, did Grace ever have a rep of 50 before she was receiving the max dose of Precedex?
On this chart, no, but I'd have to go back and look through all. These are not all the respiratory rates that were reported, so it's possible she did. But again, as we talked about, Precedex doesn't raise your respiratory rate, or doesn't lower your respiratory rate. It shouldn't impact.
Well, I'm not talking about it lowering. I'm talking about it going up.
Yeah,
And I'd have to look through the whole chart. These are not all the respiratory rates in the chart, but on this chart, there was not a respiratory rate above 50 until the highest dose of Precedex was released. But as we talked about, the Precedex was raised in response to your agitation, which also raises your respiratory rate. So
You're aware that Dr. Burdine's opinion, based on your review, was that Grace's fast breathing was due to oversedation from Precedex?
yes, I disagree with that opinion.
I know. Okay, we're going to move on from this chart. We're going to go to what was marked as Exhibit 222. Talk about this section right here. Please, well, I'll just read it. It says here in the second sentence, she again was in restraints as above, relatively nonverbal, as she was a bit more sedated with Precedex as she was yesterday. Nurse Holly McGee said that Grace was in fact not in restraints on October 13th. Based on your review of this record and the other records in this case, do you agree with that statement? Is that reflected in the record?
I mean, it's written here in the chart, and there are orders for restraints, so I have no way of knowing if, based on the record, when the restraints were on and off. Sometimes we give patients restraint holidays, so maybe at this particular time, she was sedated enough that they felt they could take them off.
You don't
But-
think this is clear when he's talking about?
So at this point, it says she was in restraints, so I have no reason to believe that when he examined her, she was in restraints.
Okay, the patient was seen and examined at bedside today. She again was in restraints as above.
Yes, I think at this point in time, when Dr. Shokar was evaluating her, he saw restraints on her. That's what he documented.
Okay, so you can tell when this was.
Well, if you look at when the note was dictated, it was dictated at 12:57 and was transcribed at 1:30. So presumably he saw her before 7. But I can't tell you exactly what time he saw her. We don't always write our notes at exactly when we see the patient.
You've talked about the term sedative. What is a sedative?
It's a medicine that, well, it's going to be circular. It sedates you, calms you. We typically use them for patients with anxiety or agitation.
Based on that definition, I would assume that you would agree lorazepam would be a sedative in certain cases.
Yes.
Okay, I think you testified that I think you used the term peak effect of morphine was 10 to 15 minutes after it was administered.
Yeah, I think that's right. I'd have to look it up to be sure, but that's close.
What time was morphine administered here on the 13th?
I'd have to look back at the chart to know the exact time. It was sometime after Dr. Shokar evaluated her after 6 p.m. But I don't know the exact time.
Would it refresh your recollection if I gave you a copy of the medication administration summary?
That would be great. Thanks. So it was 2 milligrams of morphine. The order was at 18:30 or 6:30. So it was administered between 6:30 and 6:31.
So there's a time here next to Holly McGinnis that says 6:15 morphine given, not the time that this was administered.
Well, actually, so the order says start at 18:30, stop at 18:31.
Yeah.
And then below that, it says 8:15. So I honestly don't know on this medical administration record if that means it was 18:15 or 18:30, but usually you don't give a medicine before it's ordered. So that's why I looked at the 18:30 as the start and the stop date.
Based on this record, I guess what is your, I mean, you look at these, I assume, I mean, you tell me, when was it given?
Yeah, and this is a different medical administration record than the ones I use at the hospitals I've worked, but this looks to me like it was started at 18:30. So I think that's when it is, but I don't know how to reconcile that 18:15. I don't know
So-
what that means.
Assuming it was given at 18:30, that's 6:30 p.m., right?
Yes.
Peak effect of the morphine would have been 6:40 or 6:45.
Later than that.
Okay. I'm showing you what's been marked as Exhibit 45. What's the blood pressure on here at 6:40?
Sorry, I can't read that far. I'm sorry.
You want me to give you a copy? I got one right here. You can have it.
The blood pressure is 98 over 68 with a mean pressure of 79.
Yeah, so that's 635. So we're not at peak effect yet. What about when we hit peak effect? What's the blood pressure? Not recorded because it's undetectable.
Don't know.
Don't know why. Okay, so
I
morphine.
honestly don't know why.
Morphine happens to be hitting its peak effect right as we stop seeing any blood pressure here.
Well, again, I don't know why the blood pressure is not being recorded, but this would probably be around the time of peak effect.
Okay.
Um,
Could it be that because the blood pressure is not detectable at this time?
That's one possible explanation, sure.
What other possible explanations might it be?
I mean, depends on where the cuff is, depends on what her perfusion is. If you cycle the cuff frequently, sometimes you don't give the blood vessels time to distend, so you don't get a good reading. But
Yeah.
certainly that's one of the potential explanations.
I mean, you know, Grace, around this time, and we've already
Yes.
discussed that hypotension is a concern when you're dealing with Precedex. I mean, this is measuring blood pressure, right? I mean, you would agree that it would be important to be measuring blood pressure when someone's on Precedex.
Absolutely, sure.
Okay. I want to clear something up. Testimony that ABG or an arterial blood gas was not indicated in the evening of October 13th. And then you said that Dr. Shokar actually did order an arterial blood gas stat, which means right away. And then you were asked, indicated, or was that proper? But then you said yes.
No, I was asked if that was reasonable. So I think it was reasonable. I don't think the blood gas at that point would have provided information that would have led to a change in care that would have altered the, but it certainly was reasonable to get more data. But at this point in time, Ms. Schara's oxygen saturation is dangerously low. She's maxed out on ventilatory therapy. The only thing that would have saved her life at this point is putting her on a breathing machine, and the blood gas is just going to tell you she's critically ill and needs to be on a breathing machine. There's nothing else that would have changed what you're able to do at that point.
You would agree that an arterial blood gas test is the best way to detect whether there's metabolic acidosis?
It's the best way to detect what your pH is, and then you can use that to determine whether or not it's primary respiratory or metabolic. So it's part of the
Okay. Yes.
algorithm.
What's the better test for detecting?
It is the standard test for knowing what someone's acid-base status is. Absolutely.
It's the best test? Is there a better test?
The best test.
Okay, that was my question.
Okay.
Okay, doctor, I want to talk about Grace's access to an advocate while she was in the hospital. In this case, you agree that having someone there to be Grace's advocate to her when she was ill?
Sure. For someone who's not able to advocate for themselves, it's always great to have an advocate with them if possible.
And in general, having someone in the room to be able to do things that can be helpful to a patient who's not able to necessarily understand what's happening at a given time. You would agree with that?
Sure.
But despite that, you also believe that Grace's father leaving the hospital did not have any effect on the medical provider's ability to communicate with him or his wife. You agree with that?
They clearly had access through cell phone communication, FaceTime communication, and then for most of the remainder of Ms. Schara's stay, her sister was in the room. And there are multiple notes documenting phone calls and FaceTime conversations and updates with both the sister and the parents. So I think they clearly had access to speak to Grace's advocates.
Okay, and that's just as good. as being there in terms of communication? That's your opinion?
I think it's helpful, but this is a very common situation in COVID. We conducted most of our family meetings by phone or by Zoom. If someone had COVID and they couldn't be in the hospital, we did our best to communicate with them outside the hospital with any means that we had available.
Okay, is that like, are you saying that it's not as good? Is that your way of saying that? Or I just asked, is it as good when they're not there?
I think it can be as effective, and there were clearly documentation of being able to access the Schara family on multiple occasions to give them updates.
Okay. And I want to talk about that because we have heard testimony from Cindy Schara that they were on a FaceTime call when Grace coded on October 13th, and that they were begging medical providers to save their daughter and screaming that she was not DNR. My question to you is, assuming that testimony is true, do you think that Grace's parents were able to effectively communicate with medical providers at that point?
Well, I think there were also testimony in deposition saying that even at that moment, it should have been clear ascension that under no circumstances was Grace to be intubated. That was also in the same testimony.
I'm talking about the testimony here at trial.
I haven't heard that testimony.
Okay. I want to talk about your experience with X-rays. Do you look at X-rays as part of your practice?
I do.
Would you say you've looked at more or less than 50 X-rays?
More than 50 X-rays.
Way more. How many you think?
Thousands of X-rays.
Thousands of X-rays. Okay, there was another doctor here who said that he knew a lot about X-rays. Yesterday, Dr. Binstock, you know him?
I do not know.
Okay. Do you know he's serving as an expert on this case?
Yes, that I do know, but I do not know him personally.
You are aware from your review of the record that there was an X-ray performed on October 13th, correct?
Yes.
And you reviewed that imaging as part of your review of the record in preparation for your testimony today?
Yes, I did.
Okay. Dr. Binstock testified that the image on the 13th looks worse than the image on the 11th. My understanding of your opinion is that the imaging on the 13th does not look worse than the imaging on the 11th. Is that correct?
To a degree, they both look really bad. So subtle differences from really bad on the 11th to really bad, maybe subtly worse on the 13th. I think we can reasonably disagree with that. They were both very bad chest X-rays.
Okay, you guys can reasonably disagree because it's kind of hard to tell.
Yeah, X-rays are not the best way to tell what's happening with lung function.
Yeah.
The best way to tell are the blood gases. And we know that Grace had a significant amount of shunt and was on higher levels of support. And so she was getting worse from a lung standpoint. And the X-ray is not the best test to tell you that. It just looked really bad on the 11th and also looked really bad on the 13th.
Okay, and I think the fact that it's not the best, important to remember, right?
No, I think what's important to remember is the best way to tell is the information we already had, which was her oxygen saturation, her blood gas levels, the amount of support that she was requiring on BiPAP. She was clearly clinically worsening from the 11th to the 13th. Extra thing on the chest X-ray that you can see on the 13th that you don't see on the 11th is that she has this big stomach bubble. And so what's probably happening there is she's on BiPAP. And as we talked about earlier, it's shoving air into your mouth with each breath. Some of that air goes down into your belly, into your lungs. So that's just a sign that her stomach was getting distended from all the extra air.
Is there a name for that condition?
You'd probably call it aerophagia.
Okay,
So
aerophagia.
basically digesting air. That's probably what you call it.
Well, I'm happy you brought that up. What, if anything, are do to address this aerophagia?
Well, there's really not much you can do because it's a consequence of being on BiPAP. So, I mean, it's a known risk of being on BiPAP.
Okay, so why did you bring that up?
Because it's a difference in the chest X-ray between the 11th and the 13th. And what it does is it actually pushes the diaphragm up and maybe smushes that left lung a little bit. So maybe that's why you'd call it worse. So.
Okay. I want to talk about communicating with families about sedation in the ICU.
Yeah.
We've heard multiple people testify about Grace being on sedation, including yourself, in the ICU. Based on that testimony, I would assume you would agree that Grace was on sedation on October.
Yes, she was.
And do you believe that sedation was indicated at that time, every time on the 13th?
Yes, I mean, as was documented multiple times in the chart, she was agitated, she was pulling at her BiPAP mask, and sedation was really the only way to continue to deliver the therapy that was keeping her alive.
Okay. So it was being used to control agitation. That's what you're saying?
Yes.
Was it being used for any other purpose?
So when the lorazepam was administered and then the morphine, if you want to lump those together, then that's where we start talking about trying to and again, this was after the point where it was very clear that the only medical therapy that would have helped was likely intubation and mechanical ventilation, and that was not on the table.
Grace was somnolent or non-responsive at 6 o'clock on October 13th, right?
Yeah, I think there was a nursing note that she was less, certainly there's the physician note that said she was less responsive, and then I can't remember if somnolent was the word that was used, but I think that's right.
Yeah, would you disagree that the words that were minimal or non-responsive?
I mean, I'd have to see the note that you're looking at to know for sure, but that sounds right.
Well, let's show it to the jury so everybody knows what's going on. I'm going to give you a copy in just a second.
Thank you.
Can the jury see that okay, or you want to go a little bigger? So we'll do one at a time here. I'm handing you what's been previously marked as Exhibit 33. I want to look at the entry there on the left first. October 13, 5:30 p.m. Are you with me?
Yes.
Okay. The Passero opioid-induced sedation scale here, that doesn't say agitated, does it?
No, it says somnolent with minimal no response.
Okay.
But then it also says respiratory quality labored. So we have sort of two competing things, right? She's clearly not as responsive, but she's also still got.
We're talking about agitation. Over here on the right side, this is 6:09 p.m. Same thing, somnolent, minimal/no response.
Yeah, and again, it says respiratory quality labored, and when you lump in the morphine here, the morphine wasn't being given for agitation; it was being given for respiratory work of breathing.
I understand that, but Precedex was still on at the max level here when, I mean, the medical record's saying that.
And I think shortly after this, Dr. Shokar discontinued the Precedex. I don't remember the exact time.
Well, things can happen fast, right?
Absolutely. But I will say, if you have someone who's labored and they're breathing and not responsive, who's on 100% oxygen on max BiPAP dosing, that is the time when you would place them on a mechanical ventilator and intubate them, and that wasn't an option here.
You do not believe that any written consent in the ICU, that's your position?
That is standard of care, yes.
It is your opinion that the standard of care for an ICU is to communicate with patients and their family the indication for sedation and the potential risks and benefits of sedation. Is that correct?
Yes, and that had been clearly documented as having discussions about both the lorazepam and the Precedex at prior points during her admission.
Okay, when you say prior points, I just want to be clear about that. What day are you talking about?
So there was I can't remember the exact note, but I think Dr. Baum described it on, maybe it was October 8th, using lorazepam for agitation to make sure she can keep her BiPAP mask on. And I can't remember which provider talked about the indication for Precedex, but there of this medicine being used for this particular indication.
And you believe that Dr. Baum explained the risks and benefits of this drug?
I'm not sure what the substance of that discussion was, but he clearly discussed that medicine with the family as documented.
Well, he might have said, I'm gonna communicate with patients and their family the indication for sedation, so the reason for giving it,
Yeah.
and the potential risks and benefits.
Yeah.
it's documented in the medical record that a doctor explained the potential risks and benefits of lorazepam?
It's documented the reason why they gave the substance of that conversation was, but typically we talk about, hey, we're giving this medicine to try to calm this person down. I'm worried about their breathing, so there's always a chance that this could make the breathing worse, but this is the only thing we can do. This is the best thing to do right now to try to get them to tolerate their therapy.
And that's documented where?
Well, that wasn't documented, but there's no informed consent. Communication happened.
I thought you said it was documented.
Well, it was certainly documented, the indication, and that we're going to use it for this reason. It was not documented all the potential risks and benefits. We typically do not have that discussion for every single medicine. So I don't, and we certainly don't document every single discussion we have with families. So
Okay, I want to talk about informed consent for a do not resuscitate order.
yeah,
DNR is a type of code status that a patient can have. You would agree with that?
yes.
Okay, and so there's DNR and then there's full code. Is that accurate?
There's more than just that. So
Okay.
there's DNR, which means do not resuscitate. There's DNI, which means do not intubate. There's DNR, DNI, which usually go together, but not always. So for example, I don't want to get into hypotheticals, but they usually go together, but not always. And then there's also other things you could talk about. So for example, you could talk about, well, under DNR, there's 4 or 5 different things we do during resuscitation. Sometimes we talk about each one of those discussion.
Okay, and the code status basically determines what treatment a patient will receive if they crash or if they code. Is that?
Yes, that's correct.
Now, you testified that there is no requirement for a patient to sign any authorization for a DNR. Is that correct?
For a DNR in the hospital, when you're a hospitalized patient, the requirements are to have a discussion. We write in the chart the note, we write the note of what happened, we write our order, and we do not provide a signed, we don't require signatures, and we don't give the patients a copy of that.
And it's also your opinion that the standard of care does not require even a witness to this conversation, correct?
Correct. You do not have to have a witness for that discussion. We do it all the time. Ideally, you would. Ideally, you'd have the whole family together. You're talking about it. What I like to do when I'm in the ICU and everyone's there, I like to bring the nurse in and have them with us because usually some insight into what's happening that I may not have because they're in the room a little bit more. But there are times when we can't do that. So it is not standard of care to do that. In this case, it didn't happen, but that's not a breach in the standard of care. This is how these discussions oftentimes happen. And I will say the documentation from Dr. Shokar across his 2 or 3 notes was quite extensive and really went through all the things that you would want to document for a code discussion.
Okay, does the standard of care require that a DNR bracelet be used?
Not. It used to be before we had electronic health records that you can access on your phone that we would put bracelets on everybody. I don't believe that's happening right now at Northwestern where I just started working. So I do not think it's standard of care now that everyone can pull up their phone and the first thing it shows on the record is someone's code status. So the digital stuff has really changed our ability to access that.
So you think that's kind of an old?
Yeah, I think that predates when we, I could pull up my phone right now and look at the electronic health record of any patient at Northwestern Hospital right now.
Got it. Do you know of any hospitals that have that sort of process in place right now?
Meaning electronic health record?
No, the bracelet. Do you know any hospitals that use that bracelet system?
Not the hospitals I'm working at right now.
Okay.
There might be older hospitals, but I do not think it's standard of care.
But you're not aware of it?
I'm only aware of the hospitals where I've worked.
Okay. So I just want to be clear, doctor, if a DNR put on a patient's chart, the family and the patient, they don't actually receive any notice of this order, and no document is actually sent to them that says, hey, your family member was just put on a DNR, FYI.
The DNR only happens after you have that discussion with the family, so they're already aware.
So, I mean, I get a notice on my phone, when I swipe for $3 or something like that. I mean, you're saying that the DNR doesn't even require like a little slip or nothing like that?
It does not. I mean, patients have the ability to access their chart, a computer or a phone, and it would be available in that chart, but it's not something that's automatically provided.
So what if there was a misunderstanding on a conversation with the doctor about DNR status? How would the family member be aware that there was a misunderstanding?
I mean, it's the discussions that we have, and we continue to update families and talk to them every day about what's happening.
I mean, that could be a big problem, right? I mean, that could lead to a jury trial.
I suppose that could, but I mean, the documentation here was very clear about the discussions that were made.
And you believe that everything in regard to the DNR policy followed Ascension's or St. Elizabeth's DNR policy?
Yes.
In fact, doctor, you did review a DNR or code status policy of St. Elizabeth when you prepared your opinion, correct?
I did, yes.
We're going to look at it.
Yeah.
Okay, I'm showing you what's been marked Exhibit 90.
Can I have a copy of that?
Yep. Does that look like the code policy that you reviewed?
It does, yes.
And based on your review that you conducted prior in this litigation, you agree that this policy represented the standard of care for code status? So I want to draw everybody's attention here to this section. It says the decisions about code status will be made consistent with the organization's policy on informed consent. Did I read that correctly?
Yes, and if you read the organization's policy on informed consent, which I have, this policy is in conjunction with that, and DNR, DNI discussions are not informed consent. So if you'd like to, do you have that policy that we can look at?
Yeah, we're going to look at it.
Yeah, okay.
Okay, handing you what has been marked as Exhibit 91.
Thank you.
Okay, first I want to talk about the purpose here. Oh, you did say this was the document that you reviewed, right? The informed consent policy?
Yes, it is.
Okay, it says the purpose of this policy is to ensure that an appropriately obtained informed consent conversation is conducted with the patient before undergoing a surgical invasive procedure and other specific procedures and circumstances as described throughout this policy. The informed consent conversation between physician and patient is crucial in order to respect the inherent dignity of all patients. Now we're going to move over to page 5. I want to talk specifically, this is a section called Process for Obtaining and Documenting Informed Consent. And I think this is what applies here in circumstances where the decisional patient or authorized decision maker for a non-decisional patient is not present to sign the consent permit or have a face-to-face conversation with the physician, it may be permissible to obtain verbal consent. There should be documentation on the patient's signature line that the patient is unable to sign verbal consent given.
This does not apply to code status discussions. This specifically applies to all surgical. If you read the paragraph above, for all surgical and invasive procedures, this is not a surgical or invasive procedure.
What you're saying is that you think that this document only applies to surgical and invasive procedures?
So we can go, we need to go through the whole document because there's lots of different.
Hold on a second. You'll have redirect with Mr. Guzzi.
Oh, no. So
Oh, there's no question.
If you don't mind. So
Yeah.
what was the last question?
I don't remember. I think we were saying, I was asking, your opinion is that this document only applies to invasive and surgical procedures.
yes, this document applies to invasive and surgical procedures. Intubation, mechanical ventilation, and code status are not part of that policy.
And that's despite the document that we just looked at that said that this policy applies to DNR and DNI, right?
That's a misrepresentation of what that other thing said, and we can look through. It's basically just saying that it can't conflict with the informed consent policy, but under the informed consent policy, it outlines what invasive procedures and treatments are, which include medical procedure or treatment that invades the body by cutting or puncturing the skin or by inserting instruments into the body, except for those procedures that are duly authorized to be performed by medical experts other than a physician. Resuscitation is not an invasive procedure or treatment, and that's what this policy is governing. There's also implied consent in this policy, which I'll read to you. It says, when a patient submits to anticipated care, this is what we talked about earlier about someone coming to the emergency department with a broken arm, there's implied consent that you're going to get a chest x-ray and a cast. But if you have to go to surgery, then you flip down into the informed consent where you have to document, have a signature of the patient, or you can do verbal consent with a patient's authorized representative if they're not present. This does not apply to code discussions.
We're looking on the screen here at the code status policy. I mean, it says the decisions about code status will be made consistent with the policy on informed consent.
Yeah, and the policy on informed consent clearly outlines the procedures that require informed consent, which are invasive and surgical procedures, not code status discussions. So it is consistent. It just doesn't apply.
Thank you. I want to look at some other stuff that's in this document here. So we have here at the bottom, duration of informed consent. You see that?
Yes. What page are we on?
This will be page 5. So indeed, it does discuss surgical procedural permits. But as we look at some other pages here, it's not just about surgery. I mean, here's stuff about administration of blood products.
Yeah, so in the hospital, the things we get consent for, and we didn't talk about blood products, and I'm sorry to bring it up. It's invasive procedures, and we do informed consent for blood transfusions because of the risk of infection, but also because there are many people who, based on their religious beliefs, would not want blood products from people.
Okay, and here's something else here you didn't talk about. Here it's talking about radiation, chemotherapy, epidural pain management. That's in here on the informed consent policy, right?
Sure.
Okay, let's keep going. Here we got stuff about alcohol and drug screens.
Sorry, I can't see that. I'm sorry.
There you go. So,
And this is about expectant mothers and newborns. I'm not sure how that
okay,
applies.
but I mean, my point is, Doctor, it's not really just about surgery and invasive procedures here. I mean,
Sure, but this policy clearly outlines the other things that I didn't mention, which included those 4 things that you listed, but clearly does not include code status discussions.
well,
It is not standard of care to have that discussion, and it's not covered under this policy.
okay, well, we've all seen the policies.
Yes, we have, and it's not covered in there.
We're going to move on, doctor. I want to talk about how lack of blood pressure can reduce oxygen levels. You would agree that lack of blood pressure can stop oxygen from getting to the tissue, correct?
Yes, if you don't have blood that's being delivered to the tissue, the blood is what carries the oxygen. So a low blood pressure can impair tissue oxygenation. But in this particular case, what was happening is there was no oxygen to be delivered because her lungs were so sick. So that was the mechanism by which she wasn't getting oxygen.
Mm-hmm. And I think you mentioned it earlier, but you would agree that it's important to be careful if someone is hypotensive or has low blood pressure at the time that morphine is given, right?
Yes, you have to be concerned.
And in fact, low blood pressure and low heart rate are the 2 most common side effects of Precedex, correct?
That is true, yes.
And you would also agree that low blood pressure can affect the accuracy of an oxygen meter?
It can, yes.
And whenever you're using a medication, you would want to understand the potential side effects and what someone's prior experience has been with the particular medication, correct?
Yes, you would.
In fact, there's an expectation that you understand the patient's history that you're caring for, and there are a number of ways actually of doing that, correct?
That is correct.
And certainly in the chart, if something's been documented, then that's one way you'd become familiar with that history, right? That was a yes?
Yes, sir.
You're aware that Grace's blood pressure became undetectable on October 13th?
Yes, there are multiple empty boxes that we looked at over those 5-minute intervals. So
Okay, but I'm talking about it based on your review of the record, a note from Holly McGinnis that actually said blood pressure undetectable. You reviewed that as part of your...
I definitely reviewed it. I don't recall what time that was. She certainly had an undetectable blood pressure, unfortunately, at the time of her death.
Okay. Well, I don't mean at the time of her death, doctor. I mean, right here at 6:10, I think we talked about, you thought that morphine was given at 6:30, so this is 6:10. And this is a note from Holly McGinnis. You see HJM up there?
I'm sorry, I can't see that.
Okay, let me get it. See this
Thank you.
note from Holly McGinnis? 6:10 or 6:09. You with me?
Yes. Uh-huh.
Okay. Right down here, Holly McGinnis says BP undetectable. You see that?
Yep, I do.
Okay, you reviewed that as part of your review of the record?
Yes, I did.
Okay, but in your report, you say that Grace never had a blood pressure less than 60 before she died.
I'd have to look back and report. I think I gave before either 6
7.
o'clock or 7 o'clock. I can't remember what time I
think it's
used.
before 7 p.m., but it's right in front of you.
Yeah, I think I did say 7 p.m., so I miswrote 7 p.m. instead of 6 p.m.
Oh, you miswrote 7 p.m.
Well, either I didn't see that number or I put down the wrong time in the chart. I wasn't trying to lie about it.
Okay.
Well,
I mean,
and I think it's important to recognize, if you go back to the other note that you showed us at that time, her respiratory rate's 51 and her SAT's 90 on max oxygen support. And so this is all part of the process of her getting sicker.
we're being overdosed.
No, I would disagree with that.
I know. So we have undetectable blood pressure at 6:09 p.m. Based on your review of the record, I mean, what was done to respond to this blood pressure? We talked on the 8th, they gave norepinephrine, atropine, dopamine. 13th, we have literally undetectable blood pressure. What was done in response to that? I mean, what did they give her the same drugs? Why not? Or why?
Dr. Shokar came and evaluated her, sorry. Dr. Shokar came and evaluated her and was very concerned about her work of breathing. He gave her some morphine and her blood pressure actually came up at 1635. So the next blood pressure that we had was actually normal blood pressure after that note of the undetectable blood pressure. And again, just, undetectable doesn't mean it was low. It just means the machine didn't pick it up. So it could have been low. I don't disagree with that.
Yeah.
But the next blood pressure we have at 1835 is a normal blood pressure.
Well, let's talk about that blood pressure. Here it is, 1835, right? I think you should have this one up there with you.
Yeah, I'm not sure what exhibit that is, but so I can stand up and look at it.
Oh, it's okay. I mean, we can get you another one if you want. Should have it over there, Mike.
Oh, I do have it. I'm sorry.
Okay.
You handed me a copy. Yep.
Okay. Now we talked about blood pressure. There's these three numbers there in the middle, 3 rows.
Yep.
I want to talk about this top row, ECGHR, beats per minute.
Yes.
What is that?
That's your heart rate.
Okay. How many heart rates does a person have?
1.
Yeah, right? One. Yeah, makes sense.
Hopefully.
Hopefully. So that's the beats per minute there. Now I want to look at the other number there under SpO2 rate. It says beats per minute. What's that mean?
So the pulse oximeter is measuring the difference between light that's absorbed with an arterial pulsation and with a venous pulsation. So the difference between the two. So it gives you the oxygen saturation, also gives you a pulse.
Heart rate.
So yes, a heart rate. So the EKG is more accurate than the pulse oximeter at determining the pulse rate.
Yep. And those two numbers are pretty far off, don't you think, each other? We got, I'll pull it up here.
Yeah, there's 3 numbers that the heart rate on the pulse oximeter is low. It's 37, 36, and 40. But the EKG is 76, 75, and 83.
Yeah.
So the EKG is the correct value there. The EKG is not subject to the same artifact that a pulse oximeter reading will have.
And that pulse oximeter reading not being the same as the ECG reading. I mean, like you said, you can only have one heart rate, right?
Yeah.
So it sounds like the pulse ox reading is, kind of wrong, right?
Well, so there's ways of looking at the quality of the actual waveform. And so this doesn't provide that. Like you can look and see what the peak of the pulse oximeter waveform is. And some machines actually give you stars, 1 star, 2 star, 3 star. So I don't think this reading will tell you that. But I think if there's a big discrepancy between the pulse oximeter pulse or heart rate and the EKG pulse, I would use the EKG. But I'd also be worried that the pulse ox may not be accurate if there's that big discrepancy. But we already know that for the last 7 days, every time a blood gas has been checked, her oxygen level is very low and she requires high levels of oxygen. So she was clearly going to continue to be hypoxic during this. And she was. I mean, I don't know how much I would believe this, but she's satting 90% when she's on 100%, 15/12 of BiPAP. So as we all talked about, if we all went on BiPAP right now, our SATs would all be 100%. So she's barely at acceptable range despite all of the support that she's getting. But I would worry about those 3 numbers or those 4 letters, or sorry, those 4 readings where the pulse ox heart rate's really low. I'd be worried about how accurate those particular readings might be.
You mentioned on your direct examination with Attorney Guzzi that you made a mistake on the blood gas tests on October the 13th. You know what I'm talking about?
Yeah, I did. I misinterpreted based on the way it's written that the October 11th blood gas was the October 13th blood gas. There was no blood gas
And
that
you
was
guys,
drawn on October 13th.
yeah, you guys kind of moved through it kind of quickly,
We-
but
We
was,
talked about it, said what
Yeah.
happened.
well, it was sort of a big deal, right?
Well, I think the reason it's potentially important is that if that blood gas had happened on October 13th, then it clearly would have disproven the metabolic acidosis theory as a primary thing. So it still doesn't change my opinion based on the prior blood gases that we looked at. The non-ion gap bicarb of 19 on the 13th, which was exactly what it looked like on the 9th. The overwhelming explanation for that is still a respiratory alkalosis and a compensatory metabolic acidosis. So it doesn't change my opinion.
Yeah, doctor, I still think we haven't quite made it clear how big of a deal this blood gas on the 13th that doesn't exist. I don't think we've been clear exactly about how big of a deal that was in your opinion here when we took your deposition and you formulated your opinions in this case. You understood when you rendered your opinion that Dr. Berdeen said that Ms. Schara had a severe metabolic acidosis on 10/13 that was from shock related to the use of dexmedetomidine. You understood that.
Yes, and I disagree with that opinion.
I understand. And dexmedetomidine, that's Precedex, right?
That's Precedex, yes.
And you're aware that Dr. Berdine said that this metabolic acidosis is what led to Ms. Schara having an elevated respiratory rate. You were aware of that part of his opinion?
Yes, but she already had an elevated respiratory rate, and as her oxygen level got worse, her respiratory rate continued to rise. So her worsening lung disease was the reason for her elevated respiratory rate.
Yeah, thank you. And your opinion at the time you wrote this report was Ms. Schara had several blood gases on 10/13 that definitely disprove this theory. And according to your opinion, most notably, Ms. Schara's last blood gas at 1350, that's 150, had a normal pH of 7.43, a normal PCO2 of 37, and a normal calculated bicarbonate of 24. Are you sitting here today saying that this blood gas that you relied on that didn't exist, that wasn't a big part of your opinion here in this case?
Well, certainly a part of my opinion, but there are multiple facts that back up the strength of that opinion regardless. She had a respiratory alkalosis throughout her entire hospital stay. She had multiple times where she had a bicarbonate that dipped below 20. There was no difference on the 13th compared to the other times that she had a gas. And it doesn't change my opinion that what was happening to her is she was dying from hypoxia, from low oxygen levels from COVID-19.
Okay, that's all I got for you now, doctor. Thanks.
Just a couple of questions for you, Doctor. There was a brief conversation or question about a note in which it appeared that Grace was, and I'm not using the right words here, feeling better.
Yes.
Just because a patient is feeling better from a symptomatic standpoint, does that mean that the
No, I mean, obviously it's great that she was feeling better on that day, but we clearly have her vital signs, her oxygen levels, and her BiPAP support that suggests that her lung disease was continuing to get worse.
you were asked some questions about a graph that was put on the screen something put together by Dr. Burdine, and I think Attorney Flighter actually used the word correlate. Does that chart demonstrate any form of causation?
No, absolutely not. So correlation is not causation. You know, gray hair is associated with having heart attacks, but it doesn't cause heart attacks.
What about no hair?
I think you might be okay.
Doctor, if there's a verbal order, does that always get recorded at the same, or before or at the same time that the medication is administered?
No, it is not. So sometimes, you know, the nurses will have to put that in the chart to get the medicine out of the MAR unless it's a code situation, but the order itself will be signed later by the physician who gave the verbal order.
Thank you, Doctor. Appreciate your time here today.
Thank you.
Frankowiak, anything?
Just one question, doctor. You were showed a document that mentioned the word somnolent, but at the same time also said labored breathing. Do you remember that?
Yes, I do.
Does a lengthy period of time where an individual is not getting enough oxygen for very low SpO2 or very low oxygen, can that result in somnolence?
Yes, that absolutely can decrease your mental status. Yes.
Okay. Thank you. That's all I have.
Okay. Do any members of the jury have questions for this witness? Okay, looks like two, and so if we can take those and take those over to Attorney Guzzi first. As those questions are being viewed by the attorneys, I just want to take a minute to address the spectators who are in the audience. If you go outside the courtroom at the next break, you'll see that I had entered a general order in this case that's posted right outside the courtroom. I would encourage each of you to review it again. But the important parts of it that I think, given what has happened slowly throughout this trial, but I think it started yesterday and then into today, is paragraph 12 of that provides warning for each of you that you will be removed from the courtroom if you do anything that's distracting or disruptive in any way. I think the last paragraph of it you should read because there can be sanctions and contempt of court that we take up at a later time. I've gotten a little lazy or relaxed on the rules as this trial has gone on because I try not to create issues. I mean, there's enough things going on with my world that if I cannot create issues, that's great. But for example, when I come into the courtroom to start a session, there shouldn't be talk or conversation. And when the jury's leaving, there shouldn't be talk or conversation. If you want to talk at any time, it should be done in the hallway. Earlier this afternoon, I'm embarrassed to tell you that I received 2 notes from the jurors indicating that they were bothered by some of you. I'm not going to call anybody out, but I will tell you that you're all on notice. And from now on, for the rest of the trial, you do something, you make a noise, you talk, you laugh, you make a sound, you think something's funny, you're just going to be removed immediately without question. I don't know any of you other than the people who have testified in this case and a couple others. So I'm going to do it without any discrimination. I'm not trying to favor anybody. I don't know who any of you are, but it's just not tolerated. And when I get these letters from the jurors, I go, okay, I'm not doing my job because my primary role is to provide them an opportunity to be comfortable and to listen to this evidence without distractions, including from any of you. You have a right to be in here. It's a public trial, but you don't have a right to be disruptive or a distraction. So I'd encourage you to knock it off and just understand this is your last warning. Hope that addresses the questions from the jurors, and I apologize that we even have to go there. I'm going to mark as exhibit 560, the questions from juror 630. All right, I'm marking as exhibit number 561, the questions from juror 587. Questions, doctor, are the following. First off, one of the jurors noticed that on the DNR policy that was just shown in court, that it has a copyright date of 2022. And the question is, were these policies all the exact same at the time of Grace's hospitalization, if you know?
Yeah, I think it shows, that was the code policy you said?
It says the copyright date on the DNR policy.
Oh, the DNR policy. Yeah, so the code policy, it says it was last reviewed on January 14th, 2020. And so these are constantly reviewed. So this is probably the policy that was in place, but I'm not an expert in Ascension's policies, but I think this probably was the policy that was in place.
And the one you were referring to, is that exhibit 90 or 91?
That's exhibit 90.
Okay, and what about with respect to 91?
91. Sorry, I just put these in different order. So 91. Oh, I lost the front page. Sorry. I will find it. So 91 was written in December 2017, was last revised in May 19th, 2021. So that was before this happened. And then the next scheduled review is going to be in 2024. So this was the active policy at the time that this happened.
With respect to just a different set of questions, have you ever heard of or experienced a patient's anaphylactic reaction to Precedex? And if so, describe.
Yeah. So I've never seen anaphylaxis. So anaphylaxis is when you have a severe allergic reaction where your blood pressure drops, sometimes your throat will close off, maybe you get hives, and that can happen to any medication. That can happen to a bee sting. That would be different than the low blood pressure and slow heart rate. That would be a side effect of the medicine. And it's the way that it works. So it works centrally on these alpha receptors in the brain, but it turns out there also are alpha receptors on some of our blood vessels. And so sometimes people can have a slight drop in their blood pressure and a decrease in their heart rate in response to Precedex, but it's not the same thing as like a bee sting allergic reaction. I have not seen an allergic reaction like that from
11th doctor's notes indicate, begin quote, feeling better or doing well, end of quote. Is it possible that on October 7th, Grace had an allergic reaction to her?
Again, I don't think it was an allergic reaction. I think it was one of the known side effects of Precedex. If you look at the clinical trials that were done for Precedex, the number of people out of the 1,000 people who got Precedex, about 20% experienced low blood pressure and about 5% experienced a slow heart rate. So it's a fairly common thing that we see, which is one of the reasons that when you're getting this medicine, you're always going to be in an intensive care unit, or you're going to be in like an operating room or like an anesthesia suite where they sometimes use it for sedation for procedures.
Next question is, so on October 12th and October 13th, when Precedex was administered to Grace, possibly the Precedex caused some agitation or thrashing and eventually sleepiness? That's a question. Is that a possibility?
Yeah, so there are sometimes patients can have sort of, it's almost like a paradox. You're using this medicine to try to calm them down. Sometimes they'll have the reverse of that. They'll get agitated with the medicine. I don't think that was happening here because they were describing she's a little bit agitated, so we went up on the dose, and then there's times when she's calm. So I don't think this was like a response to the medicine. I think she became sleepier because the medicine was calming her down. I don't think the medicine was causing her agitation.
And I'm just going to ask this last one. You may have answered it already, but because it's written here. No allergic reactions have been mentioned in this case yet. Is it possible that Grace's decline or death might be related? If not from Precedex, maybe plastics, NG feeding tube, or liquid fluids given to her caused the decline, question mark, side effects, question mark, why or why not?
Yeah. Again, I don't think this was an allergic reaction. Certainly on the 7th and the 8th, what happened was pretty consistent with when you start Precedex. Sometimes people have a drop in their heart rate and a drop in their blood pressure. Later on, she was so ill on the 13th with oxygen levels that were consistently in a really dangerous place, and she was breathing so fast. I think what honestly happened is she just was no longer able to keep up. She probably wasn't delivering oxygen to her tissues, and her heart was under a tremendous amount of strain from that low oxygen level. So I don't think this was a medication side effect or overdose. I think she died from her respiratory failure from COVID. And unfortunately, we saw that so often back in 2020 and 2021.
Any other questions from any of the jurors? Okay, back to you, Attorney Boozy. Any follow-up questions or answers? Attorney Frankowiak,
Nothing, Your Honor.
Attorney Fleiter.
Yeah, Doctor, just one little section I forgot to cover. My understanding is that you do not believe that consent was required for Precedex, morphine, or lorazepam, correct?
That is correct.
Okay. But you would agree with me that regardless of whether or not it was required, no medical provider in Grace's case obtained any consent whatsoever for any medication that was given to Grace.
Nor were they required to.
Is that a no?
No, they were not required to.
I understand that we just covered that you thought that they weren't required to. My question is whether or not any medical provider obtained consent for any medication while Grace was at the hospital.
No, they did not.
Okay, thank you. No further questions.
Any other questions from the jurors? Any follow-up to that, Attorney Boozy?
No, Your Honor.
Attorney Frankowiak?
No, Your Honor.
All right, Doctor, your testimony is complete. You may step down.
Thank you.
Thanks for being here today, and I think you're free to go. Is that correct?
Yes.
Okay. Have a good day. The defense's next witness.
Your Honor, I believe we will call Mr. Nick Sylvia. I'll just grab him.
Yeah, go ahead and switch and. Right, so if you want to remain standing, and if you could raise your right hand. We'll swear you in.
You do solemnly swear or affirm that the testimony you shall give shall be the truth, the whole truth, and nothing but the truth, so help you God?
I do.
Please have a seat. Can you please state and spell your name for the record?
Nicholas Sylvia, Nicholas Sylvia.
Witness Attorney Frankowiak.
Mr. Sylvia, are you a pharmacist?
I am.
Are you currently employed?
I am.
And with whom are you currently employed?
Ascension Healthcare,
Do you have a job title at present?
Regional Director of Pharmacy.
What hospitals do you presently oversee in that capacity today?
Columbia St. Mary's Milwaukee, Ascension Columbia St. Mary's Ozaki, Ascension St. Elizabeth Hospital, Ascension Mercy Hospital, and Ascension Calumet Hospital.
What does your job presently involve?
So I am responsible for overseeing the medication management processes for all the pharmacies that report up to me. So from procurement to waste, I oversee all the processes to ensure regulatory compliance, budgetary numbers, adherence, safe medication use. I'm also responsible for ensuring staff competence.
Did you have the same employer and hold the same title in 2021?
I did.
And what were your job duties and responsibilities in that role in 2021?
Similar responsibilities, but different locations. So I was overseeing Ascension St. Elizabeth, Ascension Mercy, Ascension St. Michael's, and Ascension Calumet.
As a pharmacist, do you have a PhD in pharmacy?
I have a doctor of pharmacy, yes.
Okay. Are you licensed in the state of Wisconsin to practice as a pharmacist?
I am.
How long have you been the director of pharmacy with responsibility over St. Elizabeth Hospital?
Approximately 10 years.
Do you have any supervisory responsibility over pharmacists in the hospital?
I don't have direct supervisory responsibility. I have a manager who works at St. Elizabeth, and that manager in turn reports up to me.
Okay. And how many pharmacists worked at St. Elizabeth in October of 2021?
Approximately 15.
Did pharmacists play at St. Elizabeth Hospital in 2021?
So pharmacists serve lots of purposes as providing value to patients. So first and foremost, they would review orders from physicians for appropriateness. They would oversee the processes for pharmacy technicians, the appropriate dispensing of medications. They'd answer questions from other clinicians involving medications. They would be involved in decentralized services, so they'd be on the units and involved in interdisciplinary rounds. They dose medications under protocol from physician. Those are some of the services, not all inclusive, but some of the services.
As director of pharmacy for those hospitals that you mentioned, are you personally familiar with medications that are typically used in the hospital intensive care unit at those hospitals?
I am, yes.
Are you familiar with anti-anxiety and sedative medications that are routinely utilized in the ICU of those hospitals that you oversee?
I am, yes.
And as director of pharmacy from 2021, are you familiar with the anti-anxiety medications that were routinely utilized in an ICU setting at your hospitals at that time?
Yes.
Are you able to identify any such anti-anxiety medications that were in routine use in the ICU in 2021 at St. Elizabeth Hospital?
Yeah, certainly, yeah. So principally, the primary anti-anxiety medication we use in the ICUs are in a category of benzodiazepines. So lorazepam, midazolam, there are others, anti-anxiety medications. So phenobarb and barbiturates can be used, but not commonly. But yeah, principally it's benzodiazepines.
Okay. And Doctor, I'll talk a little bit about pharmacy procedure. Do you understand as you sit here today that you're providing testimony in a lawsuit brought by the father of a young woman named Grace Schara, who was a patient at St. To your knowledge, did you participate directly in the care of Grace Schara?
I did not.
detected, for example, the potential for an adverse drug reaction?
So significant drug interactions would flag.
Okay, how briefly, how would that work?
So when the physician or clinician acting on behalf of the physician would enter the order in, if it was a significant drug interaction, it would flag with a notification requiring their acknowledgement of the concern before proceeding with placing the order. And then upon verifications on the pharmacist side, the pharmacist would also receive a similar notification indicating their requirement for acknowledgement of the concern before proceeding with verification of the order.
Okay. In October of 2021, did the hospital's pharmacist play any role in reviewing medication orders issued by a physician?
Yes.
Okay, well, what was that role generally?
So the pharmacist reviewed the orders for what we would consider clinical appropriateness.
For additional pharmacists reviewing medication profiles in the ICU?
Would have been.
Okay, who or what was that? Can you explain that?
It'd be my pleasure. So St. Elizabeth operated like a decentralized pharmacist model. So there'd be a pharmacist in the ICU practicing with the nurses and physicians. And as part of that pharmacist's responsibilities for every day is they review every ICU patient's medication profile. And if they identified a concern, they'd bring it to the physician, normally during interdisciplinary rounds.
Okay. Can you briefly explain how in 2021 an order flowed through Meditech, starting with the initial placement of the order?
The order would be placed by the physician or a clinician on behalf of the physician, like a nurse or pharmacist even. And after the order is placed by that physician or clinician, the order would flow through the electronic health record to a pharmacist. At that point in time, the pharmacist would assess the order for clinical appropriateness. If the pharmacist considered the order clinically appropriate, they would then verify the order. Now, upon verification of the order would then flow to the medication administration record, and that's the record the nurses use to administer the medications. And that medication administration record would give the nurse guidance as to what is the medication, what is the dose, what is the route, basically the instructions for using the medication consistent with the order from the physician.
You mentioned that a pharmacist reviews the medication for clinical appropriateness. Can you just describe what you mean by clinical appropriateness?
Yes. So this is by all means not an all-inclusive description of a clinical appropriateness, but clinical appropriateness would be an assessment when an order would come down. Is the medication being given in an appropriate unit for the medication's use? Is the medication being used for an appropriate indication? Is the medication being used for an appropriate dose? Is the medication being given via an appropriate route? Is the medication being given via appropriate frequency? Are there any clinical concerns with the medication, i.e. significant drug interactions, contraindications, et cetera?
St. Elizabeth in 2021 reviewed a medication order for clinical appropriateness and determined that it was appropriate. Would that then be captured in the Meditech system?
Yes.
And generally, how would the pharmacist verification be confirmed within Meditech?
So in Meditech, the way confirmation would be confirmed is the pharmacist login initials, or so their login password, their username, I should say, would be captured in the system as a verification with a date and time stamp.
Pharmacist noted a potential issue with a medication order. Was the pharmacist trained in October of 2021 to reach out to the physician who placed the order in order to bring that to the doctor's attention?
Absolutely.
Would the Meditech system in 2021 record, for example, the order source of a medication order?
It would.
Okay. When you use the term order source, what are we talking about?
So order source is basically the means in which the order is captured in the electronic health record. And so to give some examples to paint a clearer picture, so let's say the physician were to put the order in directly, that would go in as a direct order entry order source, denoting in the electronic health record that the physician himself or herself put the order in. If there was to be a verbal or telephone order, that would accordingly be captured in a different order source, denoting this is the means by which the order was communicated, so that it was input in the electronic health record.
Okay. Did Meditech in 2021 also record when or if a medication was verified by a pharmacist as being clinically appropriate?
It did, yes.
And is that something you'd be able to verify by looking it up in Meditech?
Yes.
Okay. I want to talk a little bit about medications involved in this case. There are 3 medications that appear in Grace's medical chart that have been mentioned in this lawsuit, and those would be Precedex, lorazepam, and morphine. Are you familiar through your education and training as a pharmacist and your role as director of pharmacy for those hospitals you mentioned with the dosages of these medications that would typically be withdrawn from the pharmacy for use in an ICU setting at those hospitals?
Yes.
Okay. Were you able to check the pharmacy order records for each of those 3 medications in Grace's case?
I was, yes.
Okay. Your Honor, if I may approach. Okay. Mr. Sylvia, I'm just going to hand you a document that we marked as exhibit number 366 earlier.
Thank you.
Have you seen documents like that, or do you know what that document is?
Yes, I'm very familiar with documents like this. This is a section of what appears to be Grace Schara's medication administration record.
I just want to be clear. I'd like to see the document before it's presented to the witness. I know I have them in my email and I'll look them up as well, but I'd like to at least know what the witness is looking at a moment before he starts answering questions. 66, Your Honor.
Okay. Mr. Sylvia, or Dr. Sylvia, I apologize. Page 1 of this document on page 871 there of 366 is a medication administration record for a medication lorazepam. As director of pharmacy for the hospital, could you just tell me briefly what is lorazepam?
Lorazepam is a medication principally used for anxiety or agitation in a category of medication called benzodiazepines.
Now, according to this record, it looks like it has a little PRN reason at the top.
It does, yes.
Okay, and what does that say there?
The as needed reason is anxiety/agitation.
Okay, and would that be an indication of the reason why the medication was ordered?
It would, yes.
Is this a medication, lorazepam, that's commonly obtained from the pharmacy for use in an ICU setting at St. Elizabeth Hospital?
It is, yes.
Is lorazepam routinely used in combination with other anti-anxiety medications or medications like Precedex, for example, in the ICU at St. Elizabeth Hospital?
It is, yes.
Okay. In this particular case, did you review the pharmacy records for this medication in Grace's case?
I have, yes.
Okay. Were you able to determine the order source for the medication?
Yes, the order source for the lorazepam was a telephone order readback and it was issued by Dr. Beck to the receiving nurse.
Okay, and just briefly, what's a telephone readback?
Certainly. So a telephone order readback is normally a situation where the nurse calls the physician because there's a clinical scenario that needs to be addressed. So the nurse calls the physician, and in the process of describing this scenario to the physician will assess the situation and then convey a medication order via the telephone to the nurse. And then in turn, the nurse would read back that order to the physician. And after that process has been completed, the nurse would then enter the order in the electronic health record or Meditech.
Okay. Were you able to tell from the pharmacy records whether this order for lorazepam was in fact verified?
I was, yes.
Okay. And in fact, verified as clinically appropriate by the pharmacist when it was initially entered?
Oh, yes, that's correct. So when the pharmacist verifies the order, they assess it for clinical appropriateness as previously communicated.
Okay. I want to move to the same, on exhibit 366, I want to move to page 878 at the bottom there. If you could take a look at that.
Yeah, one moment, please. Okay, I have it now, yes.
Okay, and this is, it looks like the entry in the medical administration record for medication of morphine.
It is correct.
And were you able to verify from the pharmacy records the order source for this medication?
Yes, this one was a verbal order readback.
Okay. And what's a verbal order readback?
So a verbal order readback is a situation in which the physician and nurse are oftentimes in the same room or in close proximity. And the physician conveys the order to the nurse to go ahead and put it in the electronic health record. So the physician gives the order, the nurse reads it back, the nurse enters it in the medical record. And this normally happens in instances in which the physician can't be pulled away from the care of the patient.
Okay. I want you to go to page 879 of this exhibit.
One moment, please. All right, I'm there now, yes.
Okay. And would this be a medication administration record for a medication known as Precedex?
It is correct, yes.
Is it generally, as director of pharmacy, can you just tell us briefly what Precedex is?
Sure. So Precedex is in a category of medications called alpha-2 agonists. And Precedex is used in the surgical or ICU setting. It's used to treat agitation or provide sedation. It's normally given intravenously.
Okay. Does it have any any properties about it in particular that make it particularly useful as a medication in the ICU?
Yes, so there's lots of attributes about Precedex that make it a desirable sedative / medication for agitation. So a couple of them are that, Precedex causes a very small degree of respiratory depression. So as far as other sedatives go, it's the safest as far as respiratory depression goes. Another advantage of Precedex is it's a titratable medication, which means it has a quick onset and a very quick offset, or it clears from the system quickly. And so it allows you to adjust the degree of the medication that the patient's getting to hit certain clinical parameters easily. And the last substantial benefit with Precedex is it can only go to light sedation. So no matter how much Precedex you give a patient, it won't go beyond normally a RASS score of -2, which is considered light sedation.
In your experience as director of pharmacy for multiple hospitals, is Precedex routinely used in an ICU setting in the hospitals you oversee?
It is, yes.
Okay. Now, the Precedex package insert indicates, for example, that Precedex should be titrated and administered for no more than 24 hours at a time. In your experience as a pharmacist and certainly as director of pharmacy for multiple hospitals, is Precedex routinely titrated and administered in hospitals you oversee for periods of time exceeding 24 hours?
All the time.
Would you expect the pharmacist that you oversaw at St. Elizabeth Hospital in 2021 to know that Precedex was safe to routinely use for periods of time exceeding 24 hours?
Every one of them.
Okay, why?
So Precedex is an older medication. So Precedex was approved in like the late 90s, early 2000s. And when Precedex was approved, like other medications, the prescribing information is approved based on the studies in which the submission was made to the FDA for approval. And at that time, the approval that the company sought was for a 24-hour duration. Now, like other medications, Precedex, after its approval, there were several other randomized controlled trials that took place that demonstrated that Precedex was safe for use well beyond 24 hours. And so those trials were so powerful that and strong and comprehensive.
I'm going to make an objection. He is supposed to be here as a fact witness, not as an expert witness. I think he's crossing the line, frankly.
He's a pharmacist and director of pharmacy. That's within his knowledge.
Well, he can talk about your hospital.
I'm going to overrule the objection. He was identified as a pharmacist. You knew he was.
I thank you, Your Honor. Appreciate it.
So I can proceed with my response?
You can.
Okay, thank you. So getting back to the randomized controlled trial. So lots of randomized controlled trials take place, demonstrating that Precedex is safe well beyond 24 hours. The literature is so robust that even the medical references and pharmacy references will now routinely indicate that the manufacturer advises use with it for 24 hours, but randomized controlled trials in practice support use up to and beyond 14 days. And those are the references that clinicians would use to support practice.
Something called it's a titratable medication. Are you familiar with the term titration parameters?
Very much so, yes.
Okay. Were you able to verify from the pharmacy records the titration parameter governing Dr. Murata's order for Precedex on October 7th in this case?
I was, yes.
Okay. What was the titration parameter for that order?
So I think if it's okay, Jason, I'm going to provide background as to what a titration parameter is first.
If you could, if it'll help you answer the question.
So just so everyone knows, when you order a titratable medication, there's certain aspects of a titrated order that need to be conveyed to the nurse so they're using the medication safely. And so you have to have a starting dose, a dose by which you adjust the dose by, an increment, so a timeline by which you make those adjustments, a max dose, and then a target clinical score, like either hypertension or sedation score, et cetera. And so in the case of Precedex here, it's being used for sedation. And so in this case, it was started at 1 mic per kg per hour with a range of dosing from 0.1 to 1.5 mics kg per hour with an adjustment of 0.1 mics per kg per hour every 30 minutes. So the nurse could make an adjustment every 30 minutes to target a RASS score, or respiratory Richmond agitation sedation score, of -1, which would be considered drowsy, so very light sedation.
Oh. So so I can understand that now. You look at page 879 of exhibit number 366. It looks like
yes,
an initial rate was started by the nurse who began this at 2,200 hours. You see that?
Yes, I do. Yes.
And it says at 2220, it says current rate of 1, and then it says rate change to 0.7. What you just testified to, the starting rate of 1 was something that was part of the original order for the nurse to begin at that rate? Okay. And then the nurse, once they enter that initial order at 1, the nurse then can titrate up or down according, as long as they stay within the titration parameters?
Yes, so the nurse, so the physician would depict the starting rate, and the nurse is given the latitude when using a titrated medication to adjust within the parameters of the order. That's correct.
Know when you're ready to come back in. One thing I just want to say, maybe of substance, is I'm hoping that whatever the people in the gallery have done that has made you uncomfortable to whatever extent any of you are, that it doesn't impact your ability to sit on this case as fair and impartial jurors. If you think that's the case, let the bailiff know. Just give the note to bailiff, and we'll sort through that. If I don't get any notes, I'm going to imagine that. I'm going to expect that all of you are still comfortable and you can be fair and impartial, and it's not impacting you at all, other than just being a unhealthy distraction. Okay, the jury's excused. Counsel, you can approach, please. Allow counsel to take a look at what's been marked as Exhibit 562 and 563, which are the notes that I received from the jurors. I'm going to seal those notes, but I think when you read those, you'll understand why I did what I did. But I thought it'd be, if you want to consider, who the jurors are and what they said, and to whatever extent you want, but I'd prefer not to disclose which jurors those are to anybody else.
Correct.
But you can keep it in consideration for however you want to use them. That's a different note. So I wanted you to see those, and I'm going to seal those now, but you can look at them at any time that you want. So it'll be sealed but available for counsel to look at. 562 and 563 are received. And any questions about any of that? Okay, does any counsel have any issues with the way that I addressed it with the spectators? Okay, and then I thought I'd just give that comment to the jurors, so, because I didn't ask them if they were, to be fair and impartial, but we'll see if we hear anything back.
Did you want to address this?
I think let's just wait to the end of the day. No, that's something we got to address by the end of the day, but we'll use our time here. So 560 and 561, which are the jurors' questions, I'm going to receive. During that interim there, exhibits 90, 91, and 366 were offered, and so nobody objected. Okay, so I'll receive those exhibits. I think the only other thing that I would say is I probably am going to have a little more. The problems didn't come from Mrs. Schara or Mrs. Vander Heiden, as you guys know. It was other people. I would give them a little more wiggle room because they're families. I don't want them to feel like this was directed at them because they're family members, but I think I'm directing my comments at everybody else, okay? I want to just do one thing during this break so I get a better handle on this case. I know we're going to finish Dr. Sylvia and then Allison Barkholtz or Ms. Barkholtz.
Allison is here. I'd like to get her in today if we can.
Okay, and then can you tell me who else you have left in your case as defendants? I know you have Dr. Shokar, Nurse McGinnis,
right,
and Nurse Haynes, right?
Haynes, yes. Yes.
2 clients?
Yeah,
Or not?
there's 2 experts left for tomorrow. That's about it.
Okay, and those experts are, you said Dr. Beach?
will be here. I'm gonna verify with Jason on time to see, make sure who has to fly out when.
Second expert,
Julie Davis.
okay. Okay, and then on Monday, what's your plan?
Well, I guess it all depends on what we're able to do with Haynes. I want to get Haynes in somewhere. I don't know if we'll be able to, he would be available, I guess, to squeeze in tomorrow afternoon if we were able to get the two experts done. Otherwise, we'd have to bump him to Monday. And I know Randy and I had discussed that if we didn't have anyone else to go, and the last two witnesses were Holly and Dr. Shokar, some combination of those two would be the last to go on. I don't know if we can get all three of them done. If we have to do Haynes, Dr. Shokar, and Holly on the same day, I'm not sure if that's gonna be possible.
Okay.
So I'm thinking, depending on what we do with Haynes or what we're able to do with Haynes, we could probably finish somewhere on Monday or Tuesday.
Okay, so my understanding is you have Nurse Barkholtz, Dr. Beach, Nurse Davis, Nurse Haynes, and then the two clients.
Essentially, I just don't know what we're gonna get done tomorrow. It's kind of questionable whether Haynes can get in or Haynes will have to be bumped to Monday. I don't know.
Okay. And what's your preference?
If we have time and we can get them in without keeping the jury here late, I'd love to get Haynes in tomorrow.
Okay, and how long is Dr. Beach going to take?
Be honest with you, I think her direct is probably 30 minutes,
Okay,
30 to 45 minutes. She should be pretty quick. What's that?
20?
You know, sometimes things you say come back to bite you all along.
You stopped saying it. I missed it. Okay, so, and again, I'm not trying to lock you into times. I'm just trying to get an idea. Cross of Dr. Beach, about the same.
Might be a little longer.
Okay, and then Nurse Davis, direct.
Hard to say. She shouldn't be that long, but she could be an hour and a half to 2 hours, maybe. Yeah, I guess I just depends how.
How long? Hour and a half on direct.
Could be. I mean, I don't know. I haven't had a chance to meet with her and pare it down what I want to do, so I'm not sure exactly what it's gonna go.
Okay. All right, any questions about the lineup or the order? And then do you know on rebuttal, are we going to have rebuttal for sure?
Yes.
Okay, and you know who or,
Yeah, we're gonna have Dr. Burdine, on rebuttal.
okay,
I will tell you right now, there will be an objection.
okay, so Dr. Burdine and then anybody else like Dr.
I think there'll be quick rebuttals, but it will be Eichinger, Scott, and Dr. Burdine. I don't expect to spend a lot of time on that.
Not like Dr. Baum or Dr. Beck?
Nope, not on our end.
And it can always change. I'm not trying to hold it to you. I'm just trying to get an idea.
I did tell their attorneys with the non-defendant doctors that we had reserved for other days that we were not calling them.
Right.
Okay. All right, and so Dr. Leonard can be removed?
Leonard, Gandev,
And what about Dr. Baum?
No, right.
Okay, so he's not going to testify for the defense either? And Dr. Beck, not going to testify? Okay. So, that's good. Again, I'm not asking you to lock, if you change your mind, you're free to change your mind. They're on the list. I'm just trying to get an idea. Okay, anything else for now? Okay,
I should have asked for a sidebar. We made the objection and the court ruled on it quickly. Witnesses on the stand now.
right.
Yesterday afternoon, late yesterday, the court mentioned, hold on, what is this name? I looked on the juror questionnaire. He's not on the juror questionnaire. Who is he? It was represented that he was the pharmacist. We did not have an objection to a pharmacist testifying because we believe the pharmacist that was going to testify would be this.
Can I just stop you for a second? What I said yesterday late is he wasn't on the jury questionnaire, not the witness list. And I'm hoping there's a difference.
Correct.
Okay, so the jury questionnaire was prepared and agreed to by all of you. So the jury question, so he was named as a witness.
He was deposed.
Okay,
He was used as a witness.
That's important.
Okay, it is. So you're correct, Judge, it was on the jury questionnaire, but not the witness, but the correct word is jury questionnaire, it was not in the jury questionnaire. It was represented that he would come in today and testify. We believe that was as a fact witness. All of the representation so far has been Ascension may have some fact witnesses coming. He did not file a report. He gave no expert opinion in his deposition. We believed he was simply coming in to testify that these orders were placed and fulfilled by the local pharmacist. I don't know why it's not the local pharmacist who's coming in. It's this PhD from Milwaukee, who's the supervisor of all the pharmacists. He filed no report, he gave no expert opinions. And the court's motion and limine ruling is no one will come in with opinion that wasn't in a report or wasn't given in their deposition. And now he's talking all about what he knows about Precedex and titration and this, that, and the other.
Clinical trials.
This has never been the subject of a report or deposition testimony.
And the reason I dismissed it quickly after trying to listen to what Mr. Mendenhall had said is I don't think he's given opinions on this case or on the cause of death or on the impact of this medication on Grace. He was talking about the historical perspective of Precedex when the objection was made. And so he's given the background of it. It's not an opinion about anything to do with Grace. It's just telling the jurors about this medication on issues that have been discussed the last 2 weeks.
His own, he said it was safe. It was within the parameters. He's giving an opinion on this, the appropriateness of giving this medication to Grace. And he's filed no report on that and never said a word about it in his deposition.
Give an opinion on the medication to Grace.
I didn't hear an opinion either. I've asked him only about his experience with the hospital and whether the hospital, these are medications that are typically used in his hospitals. These are things that he should be able to testify to as a fact person.
He called them safe.
I don't know if I heard that either, but I don't know if that matters, or you can cross-examine him on that if you want to open the door, but he's not going to give opinions as it relates to the issues in this case.
Right.
Or these medications and the impact they had on Grace.
And his testimony is irrelevant.
Well, I mean, that's a whole nother issue. I don't know what else do we need to know from this person? I was sitting here for the last 25 minutes trying to balance the schedule and
Right.
why is he here?
He's not going to be long. I've got maybe
Okay.
5 more minutes with him.
Perfect.
He's talking about the orders that were
under.
Doors are open. You can go in if you want,
I
right?
will.
But then you may open additional doors.
Yep.
So my objection, or Attorney Mendenhall's objection was overruled because I didn't think he was providing opinions in an expert way that had anything to do with this case. If the objection was relevance at that point, I maybe would have had a different thought, like what's the historical perspective? And I would imagine Attorney Frankowiak would have said, we've been hearing all about this medication and inserts and history. And I probably said, okay, I'm going to give a little leeway on that because we have been hearing about it. But 5 minutes is good.
Right.
Okay. 2:30 on that clock, we'll start. We're adjourned.
Thank you, Your Honor.
All right, everyone may be seated. Thanks. We're in the, I think, towards the end of the direct examination. So Attorney Frankowiak, you can pick up where you left off.
Thank you. Dr. Sylvia, I don't have too much more for you. If you could just reference the last page of Exhibit 366, which would be page 883. Let me know when you're there. Okay. This looks like, is this the last page of the Precedex administration order?
It appears to be yes.
Okay. There's a little, what appears to be a little quirk of the medical record system here. I wonder if you could explain this for me. For example, as I understand it, the ordering doctor for this medication was Dr. Murata,
That's correct.
and that was back on the 7th of October?
Of the 7th.
Okay. Well, on that last page there, it says there's a little section that says ordering doctor, and there's a different name there, Daniel Leonard. Do you see that?
I do.
Okay. And are you able to explain why this document might list Dr. Leonard as the ordering doctor on October 13th?
Yes. So what ended up happening in this particular situation is on the morning of the 13th, there was a pharmacy edit to Dr. Murata's original order. Now, when that edit took place, it doesn't change the intention of the original order as placed by Dr. Murata. So all the titration criteria, dosing, et cetera, is the same. So the reason why that edit took place is so that the concentration of the Precedex could be adjusted to allow for less frequent or less often bag exchanges for the nurse. And that's valuable for the patient because it reduces the number of instances or times in which they go without their medication. So it reduces interruptions. And that change can be done autonomously by the pharmacist. And in the record, it would be captured as a pharmacy change only.
I want to go back to page 1 of Exhibit 366, if we could.
I'm on page 1 now.
Okay. And it looks like there's a little dosage. Okay. And it looks like there's a little dosage thing there where it says PRNQ6H. Do you understand what that means? What does that mean?
So that would mean as needed every 6 hours.
Dr. Sylvia, as Director of Pharmacy for St. Elizabeth Hospital in 2021, would you have expected this order for this dosage to have tripped any red flags with your pharmacists?
No.
Okay. Want to reference, if I could, page 878. That is the order for morphine. Let me know when you're there.
I'm there now.
As Director of Pharmacy for St. Elizabeth Hospital in 2021, would you have expected this order for 2 milligrams of morphine to have tripped any red flags with your pharmacists?
No.
Finally, when we look at the page which starts the titration for the Precedex, that's page 879. As Director of Pharmacy for St. Elizabeth Hospital in 2021, would you have expected this order for Precedex when entered by Dr. Murata on October 7th to have tripped any red flags for your pharmacists in the hospital?
No.
Okay. As Director of Pharmacy for St. Elizabeth in 2021, would you have expected the orders for Precedex and lorazepam in combination with a single 2 milligram dose of morphine for Grace Schara in this case had to have tripped any sort of red alarms or red flags for your pharmacist in this case?
No, the pharmacist would have considered it clinically appropriate.
That's all I have. Thank you.
Susie, any questions?
No, Your Honor.
All right, cross-examination.
This actually won't be real long, I don't think. You had absolutely nothing to do with treatment or ordering or pharmaceuticals for Grace, correct? Nothing.
Yes, I
And
wasn't involved in the care.
You didn't review any of these pharmaceuticals for appropriateness based on this patient, nothing, correct?
Patient was receiving care, I did not.
And you didn't review anything in terms of the side effects or the overdosages that happened to this patient, did you?
Grace was receiving care. I did not.
So nothing. And you're not here certainly to opine on her condition at any point in her stay, correct?
As a medical expert or witness.
And then my one question I had the other day was, you are not here to tell anybody anything about why Grace died, right?
To my knowledge, I was not brought in to be a medical expert.
Right. You are completely unqualified, despite a PhD. You're completely unqualified based on what you know today and your failure to supervise any of this, or not failure, you just weren't doing it. You're completely unqualified to opine on her death today.
I would disagree with the term unqualified.
All right. But you're not here to opine on her death at all, right?
I was not brought in as a
Right.
expert witness, but I am qualified.
Thank you. That's all we have, Your Honor.
Attorney Frankowiak,
Nothing further, Your Honor.
Attorney Guzzi. Okay, do any members of the jury have questions for this witness? Okay, there are no questions. Dr. Sylvia, you are finished testifying. You may step down. Thank you for your testimony. You can just keep the exhibits right there.
Sounds good. Thank you
All
for
right.
your time.
Have a good day.
Dr. Sylvia.
A defense, next witness.
Yes, I believe Attorney Guzzi is just going to grab her from the hall. The defense will call Allison Barkholz.
Okay. If you could just remain standing, raise your right hand, and the clerk is going to swear you in.
You do solemnly swear or affirm that the testimony you shall give shall be the truth, the whole truth, and nothing but the truth so help you God?
Yes, I do.
Please have a seat. Can you please state and spell your name for the record?
My name,
Yes, please.
Allison Barkholt, Alison Barkholtz.
Who's taking first? It's your witness? Yes. Okay, Attorney Frankowiak, go ahead.
Okay. Good afternoon, Ms. Barkholtz. Are you presently employed?
Yes, I am.
And with whom are you currently employed?
I work at St. Elizabeth Hospital in Appleton, Wisconsin.
Do you work in the ICU within that hospital? Yes. Were you similarly employed in October of 2021? Yes. But that microphone sometimes comes in and out, so there you go. We'll
I
let
don't
you
want to
go.
get that squelch thing.
Perfect. Okay. Did you have a job title in October of 2021?
Yes, I was the lead RN of our intensive care unit.
What does it mean to be lead RN in the ICU?
Primarily, my job involves taking admissions, discharges, or transfers in and out of the ICU, making staffing assignments for the day. If there were any rounding concerns or compliments from patients or family members, then I would track them. I would be a resource for our nurses, and wherever the nurses needed help on the unit, then I would be a resource for them.
Okay. Would that explanation you just gave me basically be a list of your duties and responsibilities, the things you would do in that role?
Yes,
Okay. If you could just briefly at least indicate for the jury the extent of your nursing education.
certainly. I became a registered nurse in 2010 from Western Technical College. I received my associate degree. I continued my education at the University of Wisconsin-Oshkosh and received my bachelor's degree in 2012. I continued my education on after that and received my Master of Science in Nursing from the University of Wisconsin-Oshkosh in 2014. I'm nationally certified by the Commission on Nurse Certification as a clinical nurse leader, and I'm nationally certified with my CCRN in adult critical care nursing by the American Association of Critical Care Nurses.
When did you begin working at St. Elizabeth Hospital?
In 2012,
And when did you begin working in the ICU in the hospital?
about 2015.
Did you receive any type of special training at St. Elizabeth Hospital that enabled you to serve as an RN in the ICU?
Yes, when you initially become an RN in the state of Wisconsin, you go and get employed somewhere. But to work in a specialty unit such as an intensive care unit or a neonatal intensive care unit or the operating room, you do undergo additional training. And for me, that was about 3 to 6 months of additional ICU specific training in the ICU. So I was paired one-on-one with a preceptor throughout that time, and I received ICU specific training.
And do all nurses in the ICU or who worked in the ICU in October of 2021 receive similar training in order to work as an ICU nurse? Okay. Can you just describe the ICU physically at St. Elizabeth Hospital as it existed back in October of 2021?
Yeah, so we have a 30-bed unit. We had a 30-bed unit then, and we still do now. And the unit is a combined ICU step-down unit. So all 30 beds on our unit are capable and equipped of becoming an ICU care level room at any point in time. So if a patient needs ICU level care, they could be in one room and we could move them to a different room, or we could just move our resources to wherever that patient needed it to be. Specifically in October of 2021, we actually had 2 separate ICU areas on that 30-bed unit because we had a COVID ICU area on one end of the unit, and then we had a non-COVID ICU area on the other end of the hallway. So there was 2 separate ICUs, basically.
Nurse Barcoats, do you remember Grace Schara?
Yes.
Do you have a recollection by chance of the room she was in? Okay. Do you remember what room that was?
2029.
Okay. And where would that be located, I guess, on this 35-bed unit?
So on this 30-bed unit, we had 10 beds set aside that could be placed under negative pressure. One of the things that we did for patients who had COVID at the time was we placed them in a negative pressure room. And so we were able to turn all 10 beds in this section. There's 3 10-bed sections on our unit. And this 10-bed section, all of the rooms could be turned into a negative pressure room to accommodate for a patient who had COVID.
I want to talk a little bit about Grace's case. Do you understand that you're giving testimony here today in a lawsuit filed by Scott Schara, the father of Grace, who was the young woman who was a patient at the hospital back in October of 2021? Okay. As you sit here today, do you remember Scott Schara?
Yes.
Okay. At any time during Grace's hospital stay, were you ever assigned to serve as her primary nurse providing nursing care to her?
No.
Okay. Did you ever personally render any professional nursing care to Grace Schara at any point during her hospitalization?
Yes, I did.
Okay. Can you just explain what that would have involved?
So even though I was never primarily assigned to take care of Grace, as I mentioned before, being the charge nurse or the lead RN on a unit, I'm a resource. And so if nurses needed help repositioning or getting equipment in the room or getting supplies, I would often be called upon to bring them whatever they needed in the room, because these negative pressure rooms were rooms that when you went into the room, you didn't want to go in and out and in and out. You wanted to go into the room with all of your supplies that you needed. But if you forgot something, then I could bring it to you. Or if a patient needed help with something and you didn't have enough people to do the whatever they were doing, repositioning, then I would be a resource. And so I would render care in that respect.
Did you ever have any personal interactions with Mr. Scott Schara during the time of Grace's hospitalization?
Yes.
Okay. And on how many occasions?
Just one.
Okay. Your Honor, may I approach? Okay.
I'm handing you a document that we've marked as Exhibit 371. Do you recognize that document?
Yes, I do.
What is that document?
This is a nurse's note that I wrote on October 10th, 2021 at 8:30 in the morning, it looks like. The note occurred.
And were you presently or personally present in the hospital working in the ICU that morning on the 10th?
I'd like a copy of his exhibit when he goes up before he starts the questioning. Allows me to get the exhibits up on my iPad here.
Have a copy. Your Honor, they were emailed yesterday, so I don't have an extra copy right now.
What number was it?
Yes.
Exhibit 371 on the bottom of this page.
Number it is, and you pull it up, Mr. Mendel.
Catch up.
Okay. All right, go ahead, Mr. Francowiak.
What were your duties that morning, if you recall?
I was a lead RN in the ICU, so I was doing patient assignments, staffing, being a resource. I mean, that was my job.
That morning?
My shift started at 6 a.m. on that morning.
Did you have a face-to-face discussion with Mr. Schara that morning?
Yes, I did.
If you could just briefly describe how you came to have a discussion with him that morning, and then we'll discuss the actual contents of that conversation.
So it was brought up to me that Mr. Schara was interfering in the alarms that were in the patient's room, and the patient would be Grace Schara in room 2029, and that he was turning off the alarms and the pumps that were involved in the care of that patient, and also that he was exhibiting signs and symptoms of COVID.
Now, you have exhibit number 371 in front of you. What would be the purpose of your note, or this note when you wrote it?
The purpose of any note is to document what you have done, either in care of and for the patient, or to document something, whether you notified a physician. Part of our job as nurses is to document what we do.
When you had your discussion with Mr. Schara on the morning of October 10th, did you indicate to him that he would have to leave the hospital grounds that morning?
I requested that he leave the hospital ground to seek his own medical attention.
Why did you ask him that morning to leave?
Into the room to speak with Mr. Schara. I went in and I talked to him for what I recall is at least 45 minutes, which is a pretty long period of time to be in head-to-toe personal protective equipment in a patient room. And while I was speaking with him, he himself was short of breath, he was coughing, he was fatigued, he was holding his hands as he walked around the room on the bed and the furniture because he was weak. And all of those are signs and symptoms of COVID.
Did you communicate the reasons that you had to him for asking him to leave that morning?
Yes, and in fact, Mr. Schara even admitted to me while I was in the room with him that he felt weak and he continued to cough while we were talking. And I think maybe part of the reason that our conversation took so long is because he would have to stop and pause and take a breath and then continue talking. He couldn't talk like I'm talking to you right now for a long period of time without having to stop and catch his breath.
Can you describe the process you went through and who you spoke to before you arrived at your decision to ask Mr. Schara to leave the hospital premises that morning?
I had reviewed Mr. Schara's, situation with the hospital coordinator, and that is like the overall head honcho of the whole hospital, essentially, on the nights and weekends, and also my manager on the unit at the time.
You said this person would be the kind of the head honcho at nights and on weekends. Do you recall what day of the week the 10th was?
This was a Sunday.
Okay, so that hospital coordinator would essentially be the person in charge of things on that weekend since it was a Sunday.
Yeah, they're a 24/7 position, but like during the week, if you wanted to talk to an administrator, then an administrator is present. But on the nights and weekends, the administrator is the hospital coordinator. That's the the buck stops here, I guess. That's
What did the coordinator say to you when you contacted the hospital coordinator?
So I had reviewed our COVID visitation policy with the coordinator, and I had discussed what was Mr. Schara's symptoms, and they thought I should run it by my manager first before going in and asking him to go seek medical care. And I talked to my manager, and she also agreed, yep, the COVID visitation policy is very clear, we should proceed and go and talk with him. And then I went in and talked with him.
Okay. Had it been reported to you at any point that morning that Mr. Schara had been rude or abusive to the nursing staff?
It had been reported to me that he was interfering with the alarms. And before I went into the room, I was able to review the patient's chart and kind of catch up because, as I said, I was not primarily assigned to take care of this patient. And so I wanted to know what was going on with the patient before I went into the room. And that was when it became very apparent to me about Mr. Schara's rude behavior, according to the nurse's notes, before I went in there.
Okay. So you knew about, based on the notes, you reviewed the notes about his behavior, but did you ask him to leave the hospital that morning because he had been rude or abusive to the nursing staff?
No, not primarily. My concern was for Mr. Schara at that point.
Okay. If we could, I'd like permission to publish 371.
You may.
Okay. Matt, could you put 371? Okay. Nurse Barcoats, you have 371 in front of you. Would that be the note that you recall writing that morning at approximately 8:30 in the morning?
Yeah.
Okay. In that note, you write, or you start off by writing, patient's mother and father updated via phone for mother and in person for father about visitation policy. What in general do you recall discussing about the hospital's visitation policy with both Mr. and Mrs. Schara that morning?
Mr. Schara was there in the room with the patient, and the mother was on the telephone. And we were talking about the visitation policy, which had very straightforward guidance that anybody exhibiting signs or symptoms of COVID was not allowed to visit in the hospital.
Okay. And why did you discuss that visitation policy with them at that time?
Generally, we had not allowed visitors. This was in the height of the COVID pandemic, and so our hospital had temporarily suspended in-person visitation, and we were offering a virtual visitation like Google Zoom or FaceTime or Meet or any one of the platforms that you could use. And so I wanted to make sure that when I talked to them, Mr. Schara, who was exhibiting signs and symptoms of COVID, that he knew about our visitation policy. And then as the conversation went on, I found out that the mother, Mrs. Schara, was at home herself recovering from COVID.
We'll talk a little bit about the hospital policy itself in a little bit. You also write in your note, patient's father escorted out of building calmly by security. Did you arrange to have a security guard present in Grace's room that morning to be of help to you or Mr. Schara?
Yes, I did. There was quite a lot of personal belongings in the room. And actually, the security officer was there to make sure that the belongings and Mr. Schara both safely made it out of the building.
Is that the reason why you asked the security guard to be present?
Yeah, to be an extra set of hands for all of his stuff, because he had accumulated a fair amount of personal belongings. He was staying in the patient room, and there was no way I didn't think in my clinical judgment that he could carry that out of the hospital with his condition.
Okay. Did it have to be a security guard? Is there someone else you could have gotten to be an extra pair of hands?
Not in the middle of the pandemic at that time. We were essential staffing only. So the ICU nurses were caring for either 1 or 2 patients at a time. That's the national safe patient staffing ratio. And there are no extra ancillary staff. So there wasn't transporters, there weren't extra secretaries, there weren't ancillary departments walking around. Really, it was only the ICU staff, the staff on the unit caring for the patients, and then the security officers. That was it.
Okay. So you didn't call that security officer to exert any sort of police power or force or anything. You needed an extra pair of hands?
Our security officers don't have any police power.
Okay. Okay. As an ICU nurse who was working in the hospital in October of 2021, were you familiar with the Delta variant of the COVID-19 virus?
Yes,
And was that variant prevalent in October of 2021?
yes,
Was the St. Elizabeth Hospital ICU treating many patients who were afflicted with symptoms caused by the Delta variant of the COVID-19 virus?
yes, we were.
Okay. After your conversation with Mr. Schara in Grace's room on the morning of October 10th, did he leave the hospital premises calmly and without confrontation?
Yeah, in fact, I didn't even need to stay in the room while the security officer helped put his belongings on the cart. I had left the room and Mr. Schara agreed, and he left the hospital of his own free will and his own accord.
Okay. Did you ever at any time during your conversation with Mr. Schara on October 10th, for example, threaten to call the police department?
Not that I recall, and there would be no need for that. Mr. Schara wasn't threatening to me. He had never exhibited anything that made me feel threatened, and so I don't see any reason why I would do that.
And did the member of the security staff actually help him transport his belongings to his car?
Yes, he was responsible for pushing the cart full of belongings out of the hospital.
And I believe you said you recall the conversation lasting somewhere in the order of 40, 45 minutes?
I believe so.
Okay. Were you face to face with him in the same room and able to observe him and his clinical condition personally that morning?
Yes, I was.
And did you personally observe him to be exhibiting objective outward signs of symptoms that you believed at the time to be consistent with a COVID-19 infection?
Yes.
Okay. You've kind of described those symptoms for us. Is that generally what you recall the symptoms being?
Yes, Mr. Schara had a persistent cough. He was short of breath. He was malaised or fatigued or tired.
Okay. Were you concerned or what was your concern in particular about, I guess, his remaining in the hospital in that condition?
In that condition, my concern was for Mr. Schara to collapse on the ground and become another patient.
And would that have been a problem for you?
Yes,
Why?
this is the middle of a pandemic. I don't need more patients.
Okay.
If there's something that we can do to help someone go and receive and seek medical care that's not well, we should always encourage them to do so.
Was Mr. Schara wearing personal protective equipment that morning?
No,
Did everyone else who entered Grace's room in October of 2021 wear PPE? To your recollection, was it hospital policy that those in the ICU wear PPE?
yes,
Did you have any understanding in October of 2021 as to why the hospital required nurses and treatment staff to wear PPE when entering a patient's room in the ICU?
yes, we were trying to stop and prevent the spread of COVID.
Were there any type of recommendations that were made by any type of government body or anything to your knowledge in terms of patient visitation at that time?
In terms of patient visitation, I don't know what was recommended by the government bodies, but our hospital had temporarily suspended in-person visitation, hence our virtual visitation. And then depending on the the weekly COVID prevalence numbers, then we would decide, we being the hospital administration, not me, but like the organization, would decide whether our hospital could resume in-person visitation or not. If the COVID numbers were low, we wanted people to be there with their loved ones in the hospital. If the COVID numbers were high, then the hospital would keep suspending in-person visitation and keep it virtual.
Okay. You also mentioned earlier that one of the reasons you asked Mr. Schara to leave the hospital that morning on October 10th was because you learned that he had been interfering with some of the machines in Grace's room, including pump alarms?
Yes.
Okay. And from what source did you obtain that information?
The nurse taking care of the patient, Emily Fisher, had reported his interference to me.
Okay. Had it been communicated to you that Mr. Schara had been noted to be turning off any particular alarms or machines?
The two primary ones that were brought up to me were the IV pump, which is infusing medications, and then the pulse ox or the oxygen alarm.
Okay. The first one, the pump, which pump was that?
The IV pumps, so it's a little pump that delivers medication, whether it's an antibiotic or an IV fluid or whatever medication that the patient is receiving.
Did you understand what was being done with that pump or what he was doing with that pump?
I was told that he was silencing the alarm on the pump, on the IV pump, so that it would not alarm or alert the nurses when it would alarm. Such as there's a safety mechanism in place on all of the IV pumps where if the machine thinks that there's an occlusion at the end of the IV tubing, it will stop the infusion and it will alarm so that the nurse can come and look and make sure that the tubing is okay, that it's connected to the patient, that there's not an obstruction. And Mr. Schara was turning off that button so we wouldn't know if the pump was alarming.
When one turns off a pump alarm like that, how long is the pump alarm off?
That I don't know.
Okay. When alarms are in the room, do they also sound somewhere else outside of the room or only in the room?
Well, the other alarm that he was turning off was the oxygenation alarm or the pulse oximetry alarm. And this is different than the IV pump. The IV pump is a standalone unit. It's an IV pump over here. And then the pulse oximetry alarm is attached to the patient and it monitors their pulse oximetry level. And for patients who had COVID, this was especially important for us as nurses to know how well was the patient breathing, how was their oxygenation status. And Mr. Schara would turn that off in the room. And when you turn that off in the room, that silences the alarm for 5 minutes in our ICU. And that was a problem because this patient who is critically ill in our ICU, he is turning off an alarm that we use to make sure the patient is doing okay. And for 5 minutes, that could be extremely detrimental for you, for anybody in the ICU.
Okay. And that particular, you described it as the pulse oximeter. There's been some testimony about what that is. That's one device that would measure oxygen saturation?
Yes.
Okay. And that is something that obviously the nurses in a COVID ICU unit would really want to know because the goal is to, according to the testimony we've heard so far, is to keep the oxygen saturation above a certain level or as high as possible.
Yes, and the monitors in the room, when you turn off the monitor alarms in the room, we have a mirror alarm, kind of like a TV out in our main nurses station, but it's only a mirror image. So once you turn off the alarm in the room, we can't turn it back on from the nurses station. It's off for that 5 minute period.
And you wouldn't, or there any nurse who's attending to the patient wouldn't know that?
No.
Okay. Did you state to Mr. Schara that it was a concern to you and to the hospital that he was interfering with hospital machinery and pump alarms?
I did.
Okay. To your knowledge, did any nurse in the ICU instruct him on how to turn off or disable or silence any such alarms?
Not to my knowledge.
Experience as an ICU nurse, are there any unnecessary machines or alarms in an ICU room?
These patients in the intensive care unit are the most critically ill patients that there are in the hospital. You don't have unnecessary alarms. Every piece of alarm or every piece of equipment gives us an important piece of clinical information that we use to take care of the patient. There are no unnecessary alarms.
Okay. And is an oxygen alarm or a pulse oximeter particularly important in the case of a COVID patient? Did Mr. Schara deny to you that he had been interfering with machines or alarms in Grace's room?
Initially, he did.
Okay. At some point, did he indicate that he had in fact been silencing alarms?
Yes.
Okay. Were you concerned for Grace's safety when you learned that Mr. Schara had been interfering with those machines or alarms?
I was.
Okay. Why specifically were you concerned for her?
This is a patient who is dependent on the oxygen that we're delivering, and someone is interfering with our ability to monitor that status. That is of concern to me.
Okay. You next write in your note, Exhibit 371, that patient's mother currently recovering from COVID herself and per her statement does not feel well enough yet. Did you have a discussion with Mr. and Mrs. Schara that broached the possibility that Mrs. Schara might be able to come to the hospital to take Mr. Schara's place?
Yeah, that was one of the reasons that Mr. Schara had called Mrs. Schara that day is he had asked me, well, can my wife come? And I said, yeah, somebody else can come and visit with the patient. That's fine. And he called her, but then she herself said she couldn't come because she didn't feel well enough.
Yeah. Were you in agreement at the time that Mrs. Schara should stay away from the hospital if in fact she was experiencing signs or symptoms of COVID?
Yes.
Okay. Would that also have been a problem if for her to come to be in the hospital if she is also or was at the time showing positive symptoms of COVID?
Yes, and I even documented it here in my note that it says encourage the patient's mother who is primary POA to stay home and that signs or symptoms expressed by anyone coming to the hospital would not be granted entrance into the building to help prevent the spread of COVID. Virtual visitation offered and plans set up for FaceTime.
Okay. Now you mentioned there that patient's mother who was the primary POA, were you aware that she was the primary POA?
Not until they told me that.
Okay. You were told that she was the primary POA?
I don't know whether Mr. Schara or Mrs. Schara told me that, but one of them did.
Okay, otherwise you wouldn't have been able to write it in your note, presumably.
Right.
Okay. You just mentioned there that another thing that you wrote there was that virtual visitation was offered and a plan was set up for FaceTime with patient's iPad with the family. Can you explain what you discussed with Mr. and Mrs. Schara in that regard on the morning of October 10th?
So because Mr. Schara was ill and he was going to go seek medical attention, and Mrs. Schara was also ill and she didn't think that she could come, the plan was to have virtual visitation. And the hospital had purchased like iPads during COVID to help facilitate virtual visitation for our patients. But Grace had her own iPad in the room, and so we just set up FaceTime on her own iPad in the room.
Okay. Is this the way most visitors were communicating with patients and hospital staff in October of 2021 due to the restrictions caused by COVID?
Yeah, virtual visitation was the primary mode of visitation at that time.
Okay. And in your experience, had this virtual visitation procedure been working for patients in the ICU?
Yes,
Okay. Was it agreed then between yourself and the Sharas to set up a virtual visitation means to allow the family to communicate with Grace and hospital staff in the absence of Mr. Shara at her bedside that day?
yeah, the virtual visitation on her FaceTime on her iPad was one thing, and then they also knew that they could call anytime and ask questions on how she was doing,
Okay.
just with a regular telephone.
And did the Sharas agree to this before Mr. Shara left the hospital that day? Okay. It was your understanding when he left that there was an agreement in place whereby there could be open communication with the hospital staff, with the Sharas that day?
I wrote this note. I had no concerns that there wasn't good communication between the hospital and the Sharas.
Now, there's been some testimony in this case that after some discussions between the hospital and Mr. Shara, Grace's sister Jessica was able to take Mr. Shara's place at her bedside. Were you involved in any way with any subsequent discussions between the family and the hospital about Jessica coming into the hospital?
No,
Did you ever personally meet or speak with Jessica, Grace's sister?
no,
Did you have any further personal contact with Scott Shara or his wife after he left the hospital that morning?
no,
Did you personally have any problems in dealing with Mr. Shara that day or on any day previously?
no,
Did any staff member or nurse in the ICU ever come to you and request or demand that you ask Mr. Shara to leave?
no,
Did you bear any ill will toward Mr. Shara or Mrs. Shara at any time when you asked Mr. Shara to leave the hospital that morning? I want to talk a little bit about the hospital visitation policies, if we could. Did St. Elizabeth Hospital visitation policies change in any way in response to or after the beginning of the COVID pandemic? Okay. Now, having worked at St. Elizabeth since 2002 or 2012, would you be familiar with hospital visitation policies as they existed both before and after the pandemic began in March of 2020? Okay. Your Honor, may I approach?
Yes.
Okay.
I'm going to hand you a copy of what we marked as exhibit number 308.
Thank you.
Are you familiar with this document?
the visitor policy.
Okay. And would this document be an accurate copy of the hospital policy for visitors and visitation as that policy existed prior to the beginning of the COVID pandemic?
Yes,
Okay. I'd like you to go to page 2 of that policy. Let me know when you're there. There's a section denoted as subsection K. Do you see that policy there?
yes, I do.
Okay. And this policy under that section, or perhaps could I publish, Your Honor?
Yes.
Okay. Matt, could you put this up, page 2 of this exhibit? Okay. And K has a little section there that limits the number of visitors in the patient's room or indicates the number of visitors could be restricted at the discretion or may otherwise adversely affect patient care. Did I read that correctly?
Yes,
And to your knowledge, was that part of the hospital visitation policy that existed even before COVID?
yes,
Okay. And has that been part of the hospital visitation policy at all times since you began working at St. Elizabeth Hospital in 2012?
as far as I'm aware, yes.
Okay. Now you said that the hospital modified its policy somewhat due to COVID to restrict visitation, correct?
Yes.
Okay. When the hospital temporarily modified its visitor policy in light of the COVID pandemic, did the hospital replace its existing visitor policy, which is represented by Exhibit 308, or did it simply modify that policy?
It modified it.
Okay. Would it be fair to state that the policy we've marked as Exhibit number 308 was not replaced when visitation was restricted at the beginning of the COVID pandemic?
Yes,
Okay. Even in October of 2021, then, would it be true that the hospital retained the right to remove visitors who conducted themselves in such a manner as could adversely affect patient care?
yes,
Okay. Did you consider Mr. Schara's actions on or prior to October 10th of 2021 in interfering with the machines and alarms in Grace's room to be a violation of this policy?
yes,
Okay. And it was concerning to you because it directly potentially impacted Grace's safety and health?
absolutely. Mr. Schara was placing her life at risk by interfering with the machines and the alarms and the pumps.
I'd like to go to page 3 of this exhibit if we could. There's a subsection denominated as Section O, Visitation Restrictions. And there's a subsection 2 under there that says if a visitor becomes uncooperative or disrespectful of the campus staff, he/she will be asked to leave the campus premises. Did I read that correctly?
Yes.
Did this particular provision of the visitation policy remain in effect in October of 2021?
Yes, it did.
You earlier testified that you did not ask Mr. Schara to leave the hospital on October 10th simply because you understood he had exhibited some disrespectful behavior to the nurses. True?
Correct.
Under this policy, would it be fair to state that Mr. Schara's behavior, however, would have been sufficient to merit asking him to leave had that been your intended reason for doing so?
Yes,
Your Honor, if I may approach? Okay.
I'm handing you what we marked with exhibit number 307. Do you recognize that document?
yes, it says COVID-19 visitation policy.
Does Exhibit 307 accurately set forth the hospital's COVID visitation limitation policy, or at least the amendment of the pre-existing policy as it existed in September of 2020?
And let's see, it says 9/22 of 2020. Yes,
Okay. Your Honor, may I publish?
You may.
Okay. We'll put page 1. I think you said, Matt, can you go bring it out a little bit more on the very bottom is what I'm there. I think you mentioned that it indicates that it went into effect, or it says revised 9/22/20.
yes,
You see that? Okay, Matt, bring it up a little bit. And now at the very beginning there, it says, as part of a comprehensive response to the COVID-19 pandemic, we've enacted the following visitor policy effective Monday, September 28th of 2020 until further notice. Did I read that correctly?
Yes.
And under this particular temporary policy, was in-person visitation temporarily stopped?
Visitation has been temporarily stopped. Yes,
Okay, and this visitation policy, I believe you mentioned, modifies rather than completely replacing the previously existing visitation policy that we just talked about.
Yes.
Okay. Now, under the hospital's COVID-19 visitation policy, were visitors to be screened at entry points to the hospital?
yes,
And were they to be screened for physical temperatures greater than 99.5%
yes,
degrees? Were they visitors screened for the presence of a new cough?
yes,
And were they screened for difficulty breathing?
yes,
Were they generally asked if they'd had any recent exposure to a known COVID positive person?
yes.
Were you aware in 2021 what the purpose of those precautions was?
Stop the spread of COVID and help prevent the spread of COVID.
If any potential visitor was positive for any of these screening conditions, were they to be permitted in the hospital?
Yes to any of these questions or a temperature is greater than 99.5 degrees Fahrenheit, the visitor will not be allowed to enter our facility.
Thank you. Your Honor, if I may approach. Document that we previously marked as exhibit number 310. Are you familiar with that document?
Yes, I am.
Okay. We saw this document a little bit earlier in the trial. It was also marked, I believe, as exhibit number 24 earlier. What is this document?
It says our temporary visitor guidelines for COVID-19. Visitor limitations within all essential care settings are necessary for the safety, or visitor limitations within all essential care settings are necessary for the safety of our patients, visitors, care teams, and community to control the spread of novel coronavirus, also known as COVID-19.
Okay, may I have permission to publish?
You may.
Okay, Matt, why don't we put that up there? Okay. Oh, to it. Matt, do we have this version here? Or should I put that one back up there, Matt? Is that the version of the sign that you have in your hand?
Well, the screen is black,
Oh, yeah. We'll
so
put it up there. We'll put it up there one second. Exhibit 310? Okay,
We're
great.
just waiting for the computer to.
Is that
Yes.
you have in your hand?
Mhm.
Fantastic. Was this policy or right? Okay. I'd like to hand you a document, a different document. I'm going to talk about this one, but I want to talk about another one first, if I may. Your Honor, may I approach?
Yes.
Thank you. I'd like to hand you a document that's been previously marked as exhibit reference exhibit number 24. Are you familiar with that document?
yes.
Okay. What is that document, if you recall?
This document says COVID-19 safety measure for our patient and community safety in-person visitation has been temporarily stopped. We encourage communication through the use of personal devices. Consider one of the following apps to connect virtually with your loved ones: Facebook Messenger, FaceTime, Google Meet, Google Hangouts, Google Duo, WhatsApp, Skype, Viber, Signal. Do you want me to keep reading?
Do we have a copy to put up there? Do we have a exhibit number 24? Okay. Can we bring it up a little bit more? Okay. Now, this document here, we saw a little bit earlier in this particular trial. Do you see at the very bottom there, excuse me, there's a telephone number that says 000000000?
Yes,
Okay. Would this sign have been at one point, starting in March of 2020, posted around the hospital?
yes, except it would have had our phone number on it, not a bunch of zeros. This is the template because all of the different hospitals within Ascension and the state had different levels of COVID surge and different levels of whether they were having in-person visitation or not. And so this was a template that you could personalize to your facility. Whatever phone number you wanted for your facility went where all the zeros are.
Okay. And so if this particular sign were up and posted in the hospital, and you recall a sign being very or similar or identical to that, there would actually be a number at the bottom of that document.
Yeah, so for our hospital, it could have the hospital switchboard number and it would say 920-738-2000. In Milwaukee, it might have a 414, whatever Milwaukee hospital number.
Okay, thank you. Your Honor, may I approach?
309.
I'm handing you what we marked as exhibit number 309.
You recognize number 309?
Yes, I do.
Number 309.
This is a document that talks about our response and recovery resources and returning visitors to the emergency department and the acute care settings.
Okay. Does Exhibit 309 accurately set forth guidance from Ascension as of February of 2021 with regard to the modification of hospital visitation procedures?
Yes,
Okay. If we could publish, permission to publish, Your Honor? Okay. Go to page 1. Okay. According to this document, was it the purpose of the guidance to assist hospital personnel in deciding whether to return visitors to the healthcare setting at that time?
yes, and it sets forth circumstances that may warrant resumption of visitors and additional things to consider.
And to your recollection, did the policy guidance contained in this document continue to be in effect at the hospital in October of 2021 when Grace was a patient there?
Yes,
Okay. When we go to page 2 of this document, there's a paragraph that says some guidance, and then it says 2C. We could pull that up. It indicates that any visitor who feels ill while visiting shall immediately report this to the patient's care team and depart the building immediately. Did I read that correctly?
yes,
Okay. In October of 2021, was it your understanding that Mr. Schara had been permitted to enter the hospital earlier to be with Grace, but had developed COVID symptoms at some point while he was in the hospital? Okay. Was it the hospital's policy in October of 2021 to ask anyone who was known to have developed symptoms of an active infection in the hospital to leave the hospital?
yes,
Okay, and that would be the language that we're seeing right there in this policy, Exhibit 309.
yes,
Okay. Did you comply with this policy guidance requirement on the morning of October 10th in asking Mr. Schara to leave the hospital that day? Had it been explained to you previously by the hospital administration that the COVID policy guidelines were implemented for the purpose of protecting both patients and staff of the hospital?
yes,
Did you hold a sincere belief that you were complying with this policy that morning for the purpose of protecting both the patients and staff of the hospital?
yes,
And did you believe you were acting in the best interests of both Grace and her father, as well as the ICU staff, when you asked Mr. Schara to leave that morning? Okay. Now, I think we had talked a little bit earlier about Exhibit 310. You already have it in front of you?
do.
Okay. And are you familiar with that document?
I'm familiar with this document, yes.
And we put it up on the screen here as well. What is this document, just in general?
Our temporary visitor guidelines as it related to COVID-19, our visitor limitations within the Ascension care settings are necessary for the safety of our patients, visitors, care teams, and community to control the spread of novel coronavirus and COVID-19.
Okay, would
And
this
these
be,
were laminated and they were all over the hospital.
that's what I was going to ask you. Is this like a sign that was put around the hospital?
Yeah, these were posted at every door, every entrance, every elevator. So you couldn't go from one part of the hospital to another part of the hospital without walking by and seeing these signs because we didn't have in-person visitation and we wanted people to know how to virtually visit. So these were everywhere.
Okay, so there might be some people allowed into the hospital by exception, but you wanted, these were posted to let people know what the temporary guidelines meant or said?
Yes.
Okay. Do you know why they were posted at, for instance, the doorways to the hospital or the, any stations where people might be checked for COVID?
Well, that's how you get in and out of the hospital is through a door and you wouldn't be able to go through a door without seeing this sign.
Now, this particular sign says over on the right side, specifically states under the third bullet point, that contains language basically identical to the one in the policy that we just read. Any visitor who feels ill while visiting must immediately report to the patient's care team and depart the building immediately. Did I read that correctly?
Yes.
Okay. To your knowledge, would there have been any way for anyone to enter the hospital in October of 2021 without having to walk directly by a sign identical to this one posted at or near the entrance to the hospital?
No.
Did you say it was also posted, for example, in elevators and other places within
Yes.
the hospital?
Yes, there was.
Okay. In October of 2021, if a patient or visitor of the hospital had any questions about the visitor guidelines, was hospital staff encouraged to answer those questions?
Yes.
If a visitor to the hospital in October of 2021 had any question relative to the visitation guidelines, all they had to do was ask a staff member and the policies could be explained or clarified?
Yes.
Okay. In requesting that Mr. Schara leave the hospital on the morning of October 10th, did you believe you were acting consistent with hospital policy at that time? Okay. My last question for you, Nurse Barcolds. In requesting that Mr. Schara leave the hospital that morning on October 10th, did you believe that you were acting not only in Grace's best interest, but also in Mr. Schara's best interest as well?
Yes.
That's all I have for you. Thank you.
No questions, Your Honor.
Lead Attorney Mendenhall.
Yeah, I'm going to have a few questions, Your Honor. Okay. You know, I'm glad you cleared up that sign. These attorneys must have made a mistake. We asked for those documents on visitation policy, and they're the ones who handed over the document that had 00000000000. So thanks for clearing that up for us, because we did ask for all of those types of signs and everything. You know, I guess I'll pick up, let me go back to what I was going to do here. I'm interested in a few more things than Mr. Francoyet. You were the lead RN in the facility, correct? When you're on staff. And you're responsible for staffing operations, patient assignments, and transfers in and out of that unit, correct?
Yes, as well as being a resource for the staff for troubleshooting. If somebody can't get a tube feeding machine to work and they want an extra set of eyes to look at the tube feeding machine, then I go and try to troubleshoot it.
Right. So any questions or concerns that nurses had observed with patients would go through you at some point, correct?
Generally, yes.
Yeah. And how many nurses did you supervise? You said it was 30?
The unit is a 30-bed unit. I don't know how many staff.
30, got it. And then the nurses themselves have either one or two patients each. They're very tightly linked to those patients, correct?
The ICU patients have either one or two patients per RN in the ICU, yes.
Yeah. And you supervised Nurse Emily Fisher during Grace's stay, didn't you?
Emily worked night shift, so I wasn't there on nights. I was there on days.
Okay.
So I wasn't the lead RN when Emily was working, but I was the lead RN the next day on day shift. Emily worked nights.
So she would come on, what, at 7? Would you be leaving at 7?
The night shift would be 7 PM to 7 AM, and the day shift would be 7 AM to 7 PM.
7 a.m. to 7 p.m. So it's 12-hour shifts, correct?
Yes, that's correct.
I'm going to jump around a little bit. The 8th is a day that really concerns me because I'm wondering what happened.
The
You
what
know,
of the day concerns
The
you?
8th, October 8th, 2021. You were on, Emily Fisher came on that night and she testified right there in that chair that no one told her of the overdose, or what some people refer to as an oversedation that was life-threatening to Grace on the afternoon of the 8th. Were you aware of that situation?
No, I'm not privy to the other testimony until after I give mine.
No, I'm just saying, are you independently aware? Because you're the supervising nurse, were you aware that Grace had suffered a life-threatening event on the 8th? No. Yeah, and apparently what really concerned me with Ms. Fisher is she didn't even know. So Grace is recovering. They've given her atropine, norepinephrine, and dopamine to help her recover from this life-threatening event. And apparently Ms. Fisher knew nothing. And apparently you today know nothing.
I'm not assigned to primary care for the patient, so I wouldn't have in-depth knowledge of their medical care or medical record.
When there's been a situation, there's a fancy word called iatrogenic injury. Do you know what that word means?
No, I don't.
Oh, I didn't expect to know a word you wouldn't know here, but iatrogenic injury is when the actual medical treatment causes an injury to the patient. And that's what happened on the 8th, isn't it?
She just says she never cared for the patient.
Go ahead.
Also, I don't think I was working on October.
You weren't working
I'd
on
have to
these?
look back at my time cards.
All right, then
I don't
I'll
You know if I was even working that day.
you may not have been, but I want to ask you, in your knowledge as the supervising nurse, I guess I'm so interested in why Ms. Fisher didn't know about how the hospital had hurt Grace with these drugs that afternoon and had to save her. How would that normally be communicated to the incoming nurse at 7 o'clock?
She would give a report to the oncoming nurse who is assigned to provide direct patient care for the patient.
So somebody dropped the ball, didn't give her that report if she doesn't know about that, right?
If there's any concern regarding a patient, then you would relay it to the next person that you're handing off patient
Right.
care to.
You know-
So I'm not sure what your question is trying to get to. I'm here for clarity, not confusion. So maybe you can
Good.
ask the question a
I
different
need some
way.
clarity. And let's just be very clear. Atropine, norepinephrine, and dopamine have nothing to do with treating COVID, right?
I'm not a physician. I don't prescribe drugs, so I cannot answer that.
Okay. They're resuscitation drugs, though. You know them as resuscitation drugs, right?
I'm familiar with them when used in the advanced cardiac life support algorithms, yes.
As resuscitation drugs.
Yes.
All right. Hmm. Let me ask you something else. So explain to me what. So obviously, no one communicated to Ms. Fisher that resuscitation drugs had been used on Grace. Why not, if you know?
I can't testify to a conversation I wasn't a part of, so I don't know.
But that sounded to me like that's a standard practice to communicate to the oncoming shift what's happened, especially something like a life-threatening event. That would be a standard practice, right? You say that into the mic again.
Yes, if somebody had a life-threatening event such as their heart stopped, they would relay that to the oncoming nurse taking care of the patient. Yes.
Yeah, and let's talk about a couple of things. In the ICU and in the hospital in general, and it really hadn't come up so much in this trial, but I just wanted to ask you this since you might know. Isn't there a patient bill of rights?
I believe that there is.
And isn't that required by something called the Centers for Medicare and Medicaid Services?
I'm not sure who requires it, but I have heard the term used before.
Okay, was that communicated to Scott when he was there? His bill of rights as an advocate on behalf of his daughter, the patient.
I did not personally provide it to him,
Mhm.
but I don't know if anyone else did.
Does the hospital somehow let people know when they go to a hospital that they have a Bill of Rights that they can rely on?
Well, there's a really large bunch of posters posted on the first floor. It could be listed there.
But you don't know that. You know about the visitation policy, but not whether the Bill of Rights is in the public area.
I would have to look. There's like a 8 foot by 4 foot section
Yeah.
of things posted, but I don't know what specifically is on there.
All
I
right.
do know that we had made an exception during our visitation policy for this patient to have Mr. Schara at the bedside at the time.
Yeah, you know,
Because we
that's,
did make exceptions.
yeah, that's interesting to me. It's not really an exception, is it? And I'll tell you why. When I looked at, I believe it was 309, there are some people who are supposed to be there with a patient, and that includes a designated support person. That was right on that exhibit that Mr. Frankowiak put up there. And that says example, a caregiver who tends to the needs or concerns of a person with short or long-term limitations due to illness, injury, or disability.
What's the question, Mr.
Well-
Attorney? I'm not sure what you're trying
well,
to get at. He was there.
An
guess-
exception from the visitation policy because they're no longer visitors is my point. Isn't that right? They're not visitors, they're advocates, they're caregivers, right?
Classify them as that, yes.
Exactly. And your policy actually recognizes that important role. They're there as caregivers and advocates. They're not visitors, not run-of-the-mill visitors. It's very different. isn't it?
Any patient is a patient, and anybody that's not a patient is what we would refer to as a visitor. Whether you want to classify them as an advocate or something else, that's fine. But they're not a patient in the bed that we're providing care for. They're a visitor with the patient.
You know what? I'll grant you that. But let me read this to you. Visitors are not allowed unless they meet these exemptions. So he's exempt from the visitation policy as a caregiver, as an advocate. He's exempt. So is Jess, and so is Cindy, right?
Okay.
Right here, I'm just asking.
And they were visiting. They were there with the patient. I guess I'm not sure what the question is. but
I get
can
it.
Provide
We have
clarification.
we have a whole universe of visitors, right? You got this? A whole universe of visitors. And we have a subset, a group of people who are exempt from the visitation policy. And there's a good reason for it. It's for disabled people. It's also for children. Do you know what Grace's approximate mental age was?
No, I do not.
I think we've had testimony that it's 11 or 12. Is that right, Scott? Yeah. 11 or 12, around thereabouts. So yes, she's 19 years old, but she's disabled and her mental abilities, her competency is about 11 or 12. So doesn't she deserve an advocate in the hospital no matter what your policies are? And doesn't she fit under that exemption? You'd agree with that, right?
I agree that all patients deserve an advocate with them who advocates for the patient and exhibits behavior consistent with kindness and compassion and not hostility. Nurses should not have to worry about their advocate placing the patient at risk or harm. That's not an advocate anymore.
Listen, you're confounding the question here. I thought we had an understanding that he is exempt, Jess is exempt, Cindy's exempt. And I agree with you. Everyone should be as polite as possible with each other and as friendly as with each other as possible, especially in a hospital system. But, you know, wouldn't you agree with this? That alarm that you were talking about, that was going off because of a flow into an elbow, right? The inside of the elbow.
I can't say why specifically the alarms were going off. I wasn't in the room when they were alarming.
Well, you talked about the infusion, and we heard earlier from Dr. Burdine exactly where that went, and it went in the elbow, and it typically goes off anytime you move your arm. That's partly why she was tied down to the bed several times, correct?
Objection,
Aware
Ms.
that she was,
Hold on, so there's an objection, so you have to wait. What's the basis?
Tentative.
I overruled cross-examination, so go ahead.
I wasn't aware that the patient was in restraints or
But-
tied down to the bed, as you say.
Okay, well,
I didn't provide direct care for the patient.
thank you. No, we've had a lot of testimony about that. She's been tied down to the bed several times through the course of her stay.
That's sustained.
Thank you.
allergic reaction, certainly on the 7th and the 8th.
You know, another thing with Ms. Fisher, I want to go back to her for a minute. And I think with any incoming nurse or even doctor or whatever, you know, they have full access to the medical records for their patients, right?
Yes, if they're providing care for the patient, they have full access to the medical record. Yes.
Right. And I guess in an instance like this, where somebody dropped the ball with Ms. Fisher, shouldn't Ms. Fisher have looked at that record to see what had happened that afternoon? And certainly in the days before, on the 7th, when Nurse Haynes had to dial it back because she was
Back in 2020 and 2021.
policies. You're in charge of enforcing the policies and how they operate on the ICU unit. And I guess that's what I'm after, not whether you know what exactly happened. What I'm telling you is Nurse Fisher didn't do it. She didn't know about it and nobody told her. So I'm just asking if there was another way for Nurse Fisher to have found out there was a life-threatening event on the 8th.
Reviewing the medical record and receiving reports from another nurse taking care of the patient are the only ways that I know to get information about what had occurred with the patient.
Right. Why didn't she do that? Is that a violation of your policies there at St. Elizabeth's?
Again, without having all of the facts present in front of me or the situation, I can't testify to what I would or would not have done at the time.
Oh, I will simplify this as much as I can for you. In any patient, any nurse coming in on shift at 7 o'clock, shouldn't they at least look and see what happened at a little earlier in the day for any patient? It just seems obvious to me, but you're telling me that's not the policy.
Overruled. Go ahead.
Can you please restate the question?
It's so simple. It's so simple. Any nurse coming on her shift or his shift, right? They have a duty, I would imagine, under your policies to look at the medical record of things that happened just hours before they came on shift, to have some idea what they were dealing with this patient. Yes? Okay. Whew. You're familiar with POAs, right? Powers of attorney.
Yes.
And again, I guess this sort of goes back to what we've just been talking about. Did the power of attorney for the Scharas was in the record? And is that typically how that's handled when a person comes in who's disabled and has an advocate, that the power of attorney is placed in the record?
It depends on if the power of attorney is an active document or not. You can have a power of attorney without it being active as a document.
The jury's already heard that this is an active document, was an active document.
Again, I don't know that. I haven't.
Okay. Okay, so let's generalize again. Let's come back out a little bit. I'll change the focus a little bit. For any patient who's disabled and has an active power of attorney, that would go on the medical record, right?
For any patients who have active power of attorneys, we request that they bring in the power of attorney document with them so that we can have it available on the chart.
Right, thank you. So let's move on to the DNR. That's a do not resuscitate issue. That's been a kind of a central issue in this case. You're familiar with do not resuscitate orders?
I am.
All right. And if there's a do not resuscitate order on the record, can any of the 3 powers of attorney, renounce that do not resuscitate order and say, we didn't say do not resuscitate. And even if we did, we're pulling it.
For the patient.
I'm not sure.
I think this is more of a general question.
It's a
of
general
the patient.
question, yeah.
So go ahead and answer. So the objection's overruled. Go ahead and answer.
If a power of attorney has a desire for one code status or another, regardless of what it is.
Right.
That discussion would occur with the physician, and then the physician would tell us what the code status of the patient is.
So the physician may not have understood the conversation and may have entered a DNR. I'm going to give you a little scenario here. So a DNR gets on the record, and can that DNR then be revoked by the powers of attorney?
It could be changed.
And it could be changed, you'd agree with me, I think, on this, at any time.
Be changed with the physician, yes,
Hang on a
not
second.
by the nurses.
No, I'm talking about the actual people who are the advocates for the person. That
Could
have
change
the
your opinion on code status at any time during a hospitalization, talking with the physician caring for that patient. Yes,
at any time. So, and that's interesting, and you're talking about the physicians, but if a power of attorney comes to you and says, I want to change code status, I want to get rid of that DNR, you're a nurse. What do you do?
I would contact the physician taking care of that patient
How quickly would you do that?
as fast as I could. I mean, relatively quickly.
Right. And-
Depends on if they track me down in another patient's room or what I mean, it depends on what I'm doing at the time, but I would relay their concern to the attending physician.
And if somebody is in a crisis, a health crisis, your patient's in a health crisis, and if that DNR isn't revoked, she's going to die or he's going to die. How quickly would you get a hold of the physician in that instance?
As soon as I could.
As soon as you could. And how long does that usually take to get a physician? Do you go to the emergency room and get
Less than 10 minutes.
less than 10 minutes? Okay.
I would be comfortable in that answer.
Thank you. The back within the context of Grace's case, where we have an advocate in the room who actually was told when he came to the hospital, well, you're going to get COVID. He wasn't told, oh, when you get COVID, you are kicked out.
In the ICU in 2021 at St. Elizabeth Hospital?
Yeah, certainly. Yeah.
Grace's case, where we have an advocate in the room who actually was told.
In a category of benzodiazepines. So lorazepam, midazolam.
Grace had COVID. Doctor said he was going to get COVID. Makes sense to me. Stay in your room. Almost like a quarantine, isn't it?
I'm not familiar with whether he was told to stay in the room or not. I'm not privy to that. That was not told to me.
Okay. You know, the other thing that strikes me just a little bit funny is, maybe my humor's off a little bit here, but, when someone becomes ill, they're supposed to go to a hospital, not be thrown out of a hospital. And I guess I'm wondering why he wasn't evaluated at the hospital for COVID if he got sick.
I had offered to Mr. Schara to take
Yeah.
him to our emergency room, in fact, and during our conversation while we were both in the room, he had held my hands like this, and we had held hands standing next to the window in the patient room. And I had offered him to seek medical care at our facility.
Yeah. Well, that was very nice of you. Thank you.
Understand the critical illness that he had at the time. You weren't there.
I guess the only other thing I'm wondering about is if there's an advocate there with the power of attorney, and we have this, these exceptions for advocates. It sounds like there was no effort to get another advocate to replace him immediately. at
I
that time.
disagree with that wholeheartedly.
Okay. All right, that's all I have for now, Your Honor. Thank you.
Okay, anything else, Attorney Francolia?
Just a few follow-ups. Nurse Barkholtz, I believe there may have been some, I mean, maybe it's just terminology, but there may have been some mischaracterizations there. To your knowledge, was anyone exempt from visitor policies?
In regards to what are you referring to?
Well,
Like
there
they
were
get to be an asshole and
well, there were exceptions made for certain categories of people at the discretion of the hospital. Okay. But no one was categorically exempt such that the policies don't apply to me because I'm in a special category that the policies can't touch. Okay. And even those who had exemptions for a policy, for example, were still required to comply with the other portions of the policy. For example, an exception was made for Mr. Schara to come in to be with Grace because normally visitation wouldn't have been allowed, but he in fact was permitted to enter the hospital with Grace on the 7th. And he was there on the 10th when you saw him, true? Okay, so that was an exception to the policy that was made. But because that exception had been made, to your understanding, okay, so that was an exception to the policy that was made. But because that exception had been made, to your understanding under the policy, was he then exempt from the rest of the policy, which required individuals who became symptomatic with COVID to leave the hospital?
he was not exempt
Okay.
from that. Yes.
So simply because an exemption had been made at the outset did not exempt him from, for example, being subject to being asked to leave because he later became sick with COVID. Okay. You were asked a number of questions having nothing to do really with your involvement of the case. I just want to understand, you never cared for the patient, so you never went back and looked at her medical records or anything like that.
The only care that I provided to Grace would be in like an ancillary or second person or third person role, helping do cares that the primary nurse needed help with, such as reposition.
Okay.
And I never provided direct care other than that, really.
I mean, you were asked some questions about whether there would be a notation in the record of a life-threatening event or something like that. If in fact no life-threatening event actually occurred, it would make sense that it wouldn't be in the record, true?
True.
You had mentioned that Mr. Schara was not wearing PPE. And I know you had said you didn't have any conversations with Jessica or anything. There's been some testimony in the case that Jessica was in the room for 3 days roughly with Grace. You wouldn't have any understanding as to whether she got COVID for being in the room with Grace?
I have no idea. I've never met Jessica. I've never spoken with her. I have no idea.
Okay. There's been some testimony in this case, for example, that she, unlike Mr. Schara, was wearing PPE. So you wouldn't know if indeed she managed to be in Grace's room for 3 full days without contracting COVID because she actually complied with the hospital's request to wear PPE?
I was not aware of that.
Okay, thank you. You had mentioned, and this was news to me, that you had offered Mr. Schara a chance or an opportunity to be treated that day for what you believed was a very serious burgeoning COVID infection. Yes?
Correct.
Okay. Did he take you up on that?
I don't know. Once he left the room, I didn't track him.
Okay. That's all I have.
Attorney Guzzi,
No questions?
Attorney Mendenhall.
Oh, just one quick follow-up. I mean, you did agree with me that you don't give resuscitation drugs unless you need to resuscitate somebody, right?
Example of the drug in which you're referring to, because there's quite a few under the advanced cardiac life support, so I want to make sure we're talking about
It's the
the same thing.
combination of atropine, norepinephrine, and dopamine.
Well, norepinephrine is generally given for patients with low blood pressure in the ICU.
So it's to help get the blood pressure back up after maybe a drug like Precedex has reduced it.
They could be
Yeah.
given, but
Well, Thank you very much. That's it, Your Honor.
No.
Do any members of the jury have questions for this witness? There's one hand. Excellent. Kevin, you can come down and. And as that question is being circulated, we'll start tomorrow morning at 8 o'clock. There are 2 witnesses tomorrow. Not sure exactly what time. We may get done early. But then there are, I've been told that there's very likely to be 3 witnesses on Monday. And if we can get those 3 witnesses done, that would be when the defense will rest. Things can always change. And the 2 witnesses tomorrow are flying in, as I understand it. So we're going to get them done tomorrow because then they can return home. And then after they rest on Monday, the plaintiff will have an opportunity to have rebuttal witnesses, and that will likely be a day, which will probably be Tuesday. So that's kind of where we're at with the trial, just to give you an update. I'm going to mark as exhibit number 564. The questions from juror 1026, and the question reads, are you being paid to be here today?
No, I am not.
Okay.
Well,
I'm sorry, go ahead.
As far as I know, no, I'm not.
Okay. Any other questions from the jurors? Any follow-up based on that question and answer? Okay, good. You may step down and you're free to leave. Thanks for your testimony.
Thank you.
Exhibit 564 will be received. You can just keep those there. Thank you. And so that'll wrap it up for today, which puts us kind of right on time. Thanks for your work today and you're paying attention to it. If there's any issues, let me know. But just a reminder not to discuss this case with anyone or be involved in any conversations about anything to do with it, including any of the issues. I used this last week. You can't look into me right now. I'm a peripheral issue, right? But you can't be talking about Judge McGinnis or anything to do with Judge McGinnis because I'm part of this case. And that would be the same with any of these issues, medical issues or otherwise, or any of the people involved in it. And then again, if you hear something, your obligation is to turn it off or to walk away from it and then report it to the bailiff. Take those notebooks with you, keep them in the jury room, and we'll see you tomorrow morning. Thanks for your service. The jury is excused. All right, you maybe seat of a counsel, if you can just approach, I'm gonna show you a document. It's just a one-page sheet. It's something I think Attorney Administrator, you had seen during one of the sidebars or at the last break, whatever it was. That document, maybe let you just read it, and then I'm gonna provide a summary of it. That's connected with the note that we received yesterday from the juror that's under seal. So I'll kind of give you a little bit of history of what led up to that most recent note. And this was received yesterday, just to keep it into context. You can look under it if you want. What's under it are the first two pages, which have been marked as Exhibit 551. Yes, and so what happened was at lunch, that juror was able to satisfy what needed to be taken care of in that first note. And then somewhere in the afternoon, I got word from the bailiff that this juror didn't think he could serve on the jury anymore. And I said, well, he needs to put that in writing. And so the bailiff went back to him and he was reluctant to put it in writing because he didn't want to be called in here in front of all of you and he just wanted me to excuse him. And I said, well, that wasn't going to be the way that it would work, but at the end of the day, we would call him in and he didn't have to put it in writing. So I forget when that came in, but about 4 o'clock or 4:30 in that last session yesterday, I got that note. And it was clear to me that he either changed his mind or he didn't want to be coming in here to answer questions. But that last sentence of that note, you know, says something to the effect of, and I can, you know, it causes me a little concern on what happened yesterday. And yesterday we went till 5 o'clock, so I don't want to keep everybody after to talk about this issue because it was late for all of you. And I thought maybe I'd see what happens today with him, see if he came back and said anything, which he didn't do. So what I'm going to do is mark that most recent sheet. I'm going to staple it and it'll be the 3rd page of Exhibit 551. And it'll remain sealed. And I don't know if anybody wants to comment on it or question it on how we handle it.
I guess we could always keep it. That, but if there's any concern as to whether this person following who you have.
I agree. So it's just something I'd throw at you. There was no response from him today at all. I checked at the bailiff, I think in the morning break, just asked, have we heard anything from this juror? And they said no. And I said, good, don't bring it up. I asked again at the end of lunch and they said no. And I said, good, then don't bring it up to them or to that specific juror. So you could do that. I just wanted to bring it to your attention, have you think about it. We could agree that it'd be an alternate juror. And if you guys were both going to agree to it right now, I would probably say wait till the end of the trial because I don't want to signal him out. And I don't want him to feel like he did something wrong. Obviously, the tone of that letter is he's trying to continue to. No, I didn't get the feeling that he was trying to leave. A matter of fact, my sense, and as I'm watching, matter of fact, he was the juror who just asked the last question. You know, so he's involved and he's engaged and he wants to do a good job. And I think there was a period of time yesterday in the middle of the day where he thought he just couldn't serve. So that
I think when they see maybe tomorrow, that we're at the end of the tunnel, and that there's only a few more days left, and then they get a weekend of charge. I guess. But if yeah, I'm very enjoying it right now. Now I keep in mind how it plays out over the next day or so.
good. Okay, so I just wanted to give you notice of that. And then exhibits 371, 307, 308, 309, 310, and 24 were discussed with nurse Barkos. Any objection to the receipt of those, Mr. Mendenhall? Okay, so those are received. I have a note here, Attorney Fleiter, you had thrown up on your cross-examination of the doctor, the timeline of Grace's medical care, you know, which was that chart. I'm not sure, has that been marked as an exhibit? The clerk told me no, but I know we've seen that.
We'll have a hard copy. It was from Dr. Burdine presentation. I didn't understand at that point that we were marking the monsters like that. We'll have a full copy of the whole presentation tomorrow.
Okay. Okay, just if we can kind of clean it up sometime soon. I mean, we're coming to the end and last thing I want to be worried about, I'd like to focus on jury instructions and verdict forms and issues as opposed to exhibits. So thanks for trying to get that cleaned up. And that goes with the rest of the exhibits and then we talked about today. So I'll just hold on to this and try to just work it out with the clerk. Sooner the better. Anything else on exhibits then from the plaintiff? Defense, anything on exhibits?
Just would ask someone to stick around because we have to mark the boards. I want to make sure we have agreement on how we mark it.
Okay.
I mean, they have exhibit stickers in the electronic file, but Okay, so you would waive marking the actual boards?
There's 248 and 249. Those are the two boards, right?
There's 4 boards, 246, 247. Two of the boards, 248 and 249, also have an overlay. So I do think at least those have to be marked, at least the overlays, maybe whether it's 49-1, 249-A.
You're not going to use them again in some other trial, are you?
No.
Okay, so I'd say let's just mark it, right?
Yeah.
Okay, so yeah, just stick around after and try to do that. So if somebody from plaintiff side can do that. Mr. Administrator standing, that's a sign he's clearly ready to get done. The last thing I wanted to make sure was just any questions that you have on the order tomorrow. Okay.
We're ready to go.
Okay, and anything that defense has regarding the order?
No, I think it's gonna be Dr. Beach and then,
Okay,
Is there any thought about, should I try to have Haynes here in the afternoon, or we were gonna just cut it off after those two?
well, I mean, that's a good question. So what I heard earlier was Dr. Beach is going to be maybe an hour to an hour and a half total.
yeah, I think so.
Okay, so, you know, if we start at 8,
Across.
No, you said half an hour, correct? I might, the most I would
okay, so,
take, it may be much less. You see, Your Honor, I adjust on the fly.
yeah. So at 9:30 to 10, you know, let's just say we got it done at 9:30, we take our normal break, we start back at 9:50. You said your direct examination of Nurse Davis is, did you say an hour and a half or 2 hours?
Yeah, it could be hour and a half, 2 hours, maybe a little
Okay.
less. Not
So that takes us to lunch. But, you know, my thought was, can we give them a quick lunch if it's 11:30, and then if cross is gonna be, I mean, do we wanna wait an hour for a half hour of work, or do we wanna give them another 20-minute break, let the one juror do stuff that she needs to do? And then, we just can finish earlier,
We know we're going to be back next week.
right?
We imagine we could get the trial done tomorrow. Sure, we're gonna wanna stay longer. We're gonna be back next week. We wouldn't mind if we end early tomorrow at all. And particularly, I wouldn't mind if we ended early and before they go to lunch, or maybe if lunch is later. So if we went until 12:30, and then there's no lunch break, we just go for the day. I honestly.
Okay, I mean, why don't we aim for that? And maybe we'll just do a lunch that they can eat in a sandwich or something where they can eat it in a, the other juror is gonna need a break around that 11:45 to noon issue. So even if we take a second break for 20 minutes and it's not an hour lunch, then come back and finish up. Does that work for everybody? Okay. All right. Is that okay with you, Mr. Administrator, or you? Told you, my son is playing in the state tennis tournament tomorrow afternoon. And I missed last week's version of it, so this is the team state. So if I can get to Madison at 3:30, I'm okay, but I'm not gonna push anybody on that.
So what are you saying, Franco?
No, and I wasn't gonna bring it up other than, I'm not gonna make them rest. I also think the jurors, I mean, if you read those notes, they're ready to take a break, and they don't wanna say it. And so, you know, for their sake, but, I'm here all day. Although if we get done at 12:30, we're not gonna have any conversations about the verdict form. All right, we'll see everybody in the morning.
All right, well, that seems to be it for the day. We had a couple of winners. One expert witness who absolutely was just towing the line for the hospital, even directly arguing in favor of the ridiculousness that they put this family through, seeming to be more ideologically driven than fact driven. And then we also had the head nurse, who is quite likely the person guilty of this young girl's murder. none of the defense's experts or testimony so far has swayed my opinion that they murdered this young girl. So, pretty awful. We're gonna be back here again the same time tomorrow. In the meantime, we're gonna go raid Cool Frog. Give him a heads up, so let him know I sent you. Have a wonderful day. See you guys later.